A very, very good morning to all of you. Good morning. I was told if it's a conference, it's a great start to the day and people are going to respond if you say good morning. That's a good morning and hearty welcome to WICON's 15th annual conference of Venus Association of India. And I hope all of you are gearing up for today's session. As you all know, we've been waiting for this moment, and without further ado, I extend a warm welcome to all of you for taking time out and joining us here today. And we'd like to begin this event with the prayer. I'd like to invite on stage Ms. Sheila Durai to take us through the prayer.
Let us pause for a moment and pray.
May I please request all of you to kindly arise from your seats?
Heavenly Father, we come before you this morning. We lift our hearts in gratitude and thanksgiving for giving us the gift of this day, O Master. We thank you, Lord, because you are the Lord of knowledge, you are the Lord of wisdom, of enlightenment, O Father. And we thank you for this occasion, this celebration of sharing of knowledge of the Venus Association of India. We thank you because you are here with us and you are going to bless the proceedings, O Father. We thank you that you, O Father God, would help every endeavor of this association, and we pray that we would continue to see your hand upon everything that goes on here. We submit the entire program for today and tomorrow into your hands. In Jesus' name I pray, amen. Thank you.
Kindly be seated. I would now like to invite on stage Dr. Deepak Selvaraj, Professor of Vascular Surgery, current VP of the Venus Association of India, to please join us on the stage for the welcome note. Over to you, Doctor.
Thank you so much, Reena. Good morning, my friends, colleagues. A lot of thought and work has gone into this WICON. I thank you all for coming in from all over India. There are people who have come all the way from Jammu, the west and the east, the northeast. I thank you so much for taking the time and effort amidst your busy schedules to come here for this conference, the annual conference of the Venus Association of India. We take great pride in being vascular surgeons and vascular surgeons who do venous work, which is a very exclusive club. And I am so happy to see all my friends, especially the last 2 years has been very difficult from the hospital point of view. We've all struggled with the pandemic and we have come through. And after the pandemic, this is probably the first conference that is in a hybrid mode. We've still fully not go into the completely real-time mode, but several of our participants are on the hybrid mode. They have come from Europe, the West, Australia, and America. They will be taking part on the hybrid mode. Over the next 2 days, we will have a couple of orations, the Sunil Agarwal and the Ted Kim orations, which will be delivered by Dr. Pinjala and Dr. Dekiwada, and we have the inauguration ceremony as well. I must thank the industry for helping us throughout this program, and they've been together with us right through the organization. The event managers, I want to thank the event managers, Parameshwaran, Neetu, and all of them, and special thanks to Meenakshi, who's also here. And as we start this conference, I would like to once again welcome you all. I hope the next 2 days will be 2 days of knowledge sharing as well as recreation. Thank you so much.
Thank you so much, Dr. Deepak. We have a preview room in Hall B. Those of you who are presenting, if you have to load your presentations, if you have to hand over your PPTs, you are requested to head on to Hall B and make a check of all the technical requirements. Also, we do have certain sessions at a certain time. We will make announcements as we come to it. We would now like to take you through the first session But just before that, we'd like to request all of you to kindly put your mobile phones in silent mode as we're about to begin the session. Requesting all of you to please put your mobile phones on silent mode. In case of emergencies, please do not panic. We will have an assembly area just outside the hall, and we can gather right there and be safe. All right, ladies and gentlemen, I'm hardly finding many ladies here, but we do have wonderful doctors. We'd like to begin with our first session. I'd like to invite on stage the chairperson, Dr. Saravanan Sundaraj and Dr. Jayakumar S. to please join us on the stage. Rest of you can applaud for them as loud as you can. This is the first session of the day. I'd also like to invite our panelists to please join us. Dr. Santosh Tiwari, Dr. Advait Koturkar, and Dr. Kiran Gore. The first session. May we also have cordless mics to be given away on stage. The first session is on superficial venous disease. Superficial venous disease. I now hand over the session to our chairperson. Over to you.
Good morning, everyone. Nice to see you all after a long time, nearly 2 years. This first session is going to be on superficial venous diseases. I would like to call Dr. Shoaib Padaria to talk about advancing laser ablation. This gentleman, no need to introduce Shoaib, everybody knows him.
Let me thank Dr. Deepak, Dr. Vimalan, the entire organizing team for Vicon for putting up this lovely show in spite of the pandemic. Great venue, and I think great arrangements. Thank you very much. So let me take my guard as first batsman, and let me start with the talk. What I'm going to speak today is on advancement of lasers and the 1940 laser, and what exactly is the 1940 laser. So we all know that the original work on EVLA was performed using a diode laser, which was the 810 and 980 nanomicron laser many, many years ago, more than 25 years ago. And over a period of time, we have realized that clinical studies have shown that endovenous laser with a laser emitting wavelengths at 810 to 980 nanomicrons, bare fiber application can cause perforation. We've seen that in our studies, in our clinical practice, and along with that, there's also increase in pain, ecchymosis, and nerve damage occasionally. Now, analysis of the absorption spectrum of water reveals that wavelengths, which are larger than 1300 nanomicrons, show a higher absorption coefficient in water and reduced hemoglobin absorption. This is common knowledge. Further analysis of this absorption spectrum of the coefficient in water beyond 1470 nanomicrons has now revealed a second local absorption spectrum of around 1940 nanomicrons, with the absorption coefficient in water for 1940 being much greater than that of 980 or 1470. And as you will see from the penetration characteristics here in this graph, the penetration with the 1470 is much lesser with that of the 980, and that of the 1940 even lesser than that. So over a period of time, there has been an evolution from 980 to 1470. Today, I believe almost all of us are using the 1470. And we know that as far as the 1470 nanomicron is concerned, there's 40 times higher absorption in water than the 980. But when we talk of the 1940 nanomicron wavelength, it's 40 times higher than the 1470. So we've come a long way. But what we need to do is, does this really benefit our patients? So what exactly is the potential advantage of this 1940 laser? Since light at 1940 nanomicron wavelength is being more absorbed in water, the EVLA with 1940 with a radial fiber would require lesser lead and lesser energy per square centimeter of surface area of the vein. And as a result of that, there'll be less thermal damage to the vein. Because of this lower lead and resultant decreased optical penetration depth into the tissue, obviously there's a decreased thermal alteration of the perivenous structures. And this is very, very important because this will decrease the nerve damage, which we are always worried about, especially below the knee lasers for some of us who do that. And also periprocedural pain is decreased and the complication rate overall are decreased. Now, one of the good studies reported on 1940 is one by Uldis Morens, who has done a large amount of work on this. So he reported about 100 cases of lasers using 1940 nanomicron over a period of 1 year. And he used only about 5 to 8 watts of energy during this study. And he found that as far as the closure rates was concerned in his study, at 10 days, there was a 100% closure rate, and even at 3 months, the closure rate was on 100%. Now, this is quite a good result, but when we use the 1470, we usually see at 3 months, there's about a 1 or 2% recanalization rate. Apart from that, the occlusive distance from the deep vein, because Dr. Uldis Morens goes right up to the junction of the superficial and the deep vein, at 10 days was 0.1 centimeter, at 90 days was 0.5 centimeters. The chance of E-hit was almost negligible. And even the venous clinical severity score went down significantly, 4.7 to 1.2. Not only that, if you see the resorption of the vein, that is the diameter of the vein when you do ultrasound later, he found that before EVA, the average size of the vein was 6 millimeters. 10 days later, it had gone down to 4 millimeters. And 3 months later, it was only just 2 millimeters. Having said that, in 1/3 of his patients, at 3 months, there was 100% resorption of the vein, which means that when you do a sonography at 3 months, there is no vein seen at all. So what he concluded was that when you use a 1940 laser, first of all, you can use a lower treatment power of around 8 watts, similar lead, no fiber carbonization. Now, this is a very, very important feature when you use a lower amount of energy. Because when carbonization occurs at the tip of the laser fiber and you keep pulling the laser fiber along the length of the vein, the amount of energy delivered towards the lower part of the vein is much lesser, obviously because of the carbonization. So there was no carbonization at all here, and this means that the amount of energy delivered was uniform along the entire length of the vein. And also, because you're using less amount of wattage, there's a chance that you can use very superficial veins, just like the anterior accessory great saphenous vein or non-truncal veins, which are very close to the skin. You can use this laser fiber for that. There was another study which was also published in the European Journal of Vascular and Endovascular Surgery on 1940 laser, and they also showed the similar results as for Dr. Morens' study. However, there are two sides to every story. Some may say 1940 works wonders, and others will say, really, is there really any benefit? And Lowell Koibnick showed us that when he did his study, which was published in 2015, and he concluded that the use of low endoluminal energy resulted in a lower vein occlusion rate compared to the 1470 laser. So when Dr. Uldis Morens says that my results were so good that at 3 months, 1/3 of the patients was fully resorbed, the occlusion rate was 100% almost at 10 days and 100% at 3 months, Dr. Koibnick felt in his study that over a period of time, the occlusion rate was much lower when you use lower energy. And similarly, Mark Whiteley's study also in 2021 also said that although there is no great benefit of 1940 compared to 1470, the only advantage this may have is lower use of energy may help us in treating superficial veins more easily. So in conclusions, I would like to comment that as far as 1940 laser is concerned, I think there are still lots more studies to be done. No doubt, it is a good laser. The wavelength is good. It gives very, very good results. I would say as good as 1470, maybe sometimes better. But it's safe and effective. There are studies which show that lower post-operative pain, low analgesic requirement, short convalescence, and more patient comfort. So these may be some advantages. And finally, EVLA with 1940 nanomicron laser guided by intraoperative Doppler ultrasound permits reproducible placement of the radial fiber at the saphenofemoral and saphenopoppliteal junction, if some of us want to do that, enabling a shorter stump, because we know that when a shorter stump is used, this decreases the frequency of recurrence without the increased risk of E-hit. Thank you very much.
We will discuss leaders. So, next speaker, Dr. Vimalin Samuel. He will speak about the future, the glue ablation.
Good morning, everyone, and thank you for the opportunity to give this talk. So today we'll be talking about something that we describe as a new kid on the block, and the question is this the future? So we have numerous aliases for glue. I like to call it glue. It's the easiest thing to say, but you can also call it a whole lot of other things: cyanoacrylate embolization, cyanoacrylate closure, non-thermal, non-tumescent ablation. Now, the mechanism by which it acts is basically when we inject, there's a rapid solidification, there's a polymerization reaction with the blood, and that causes clotting and inflammatory reaction of the vein wall, leading in fibrosis. So when we look at this, there's only mainly one company that is supplying glue in India. So the company says it does a reliable delivery, there's controlled polymerization, biological response, and all permanent occlusion. Now, this is what the company says. There's always a question. We heard Dr. Shoaib talk about something that has withstood the trial of time and something that is new. How does the old compare to new? We want to know the results. So when we look at first just the main advantages, there's no tumescence. So there's no fewer needle pricks. There's only one actually, and then there's no thermal collateral injury, and the compression at the end is not, post-op is not mandatory. This is post-op compression, okay? And then, of course, we have to come to the evidence. Now, we've been having data from 2017 about glue, and most of them have been about 36 months follow-up, and there have been a few RCTs, but all of them have practically said the same thing. Then the V-close trial, which is what has been published and has claimed results all over the world, is that at 36 months, we had 94.4% occlusion versus 91.9% occlusion compared to RFA, and stable improvement in quality of life. So this was the first randomized control trial that compared along with EVLA. So we see that the occlusion rates are almost the same. The main the key word here is non-inferior. That is what we are trying to establish. And we've seen that follow-up at up to 3 years, the occlusion rates are as much as EVLA and RFA. So it's safe and effective to use. Now, the problem happens is when we look at large size veins, that GSV up to 2 centimeters. A normal practice in India, we see a lot of veins that are 10 millimeters and above. So how is it useful for that? And of course the SSV. This is one study that we have that says, this is the WAVE study, that says that it's good for the SSV, the accessory saphenous vein, and up to large GSV. This occlusion rate was 98%. Again, the similar study published in Phlebology, it said GSV greater than 8 mm, there is some increased risk of recanalization on using glue. And when we have increased GSV diameter, it's associated with a longer stump remnant, because when we do the glue procedure, we stay 5 centimeters away from the junction. Now, leaving behind such a big stump, having such large veins, does it translate into poorer quality of life post-ablation, post-using glue? We have studies that says that the VCSS and the quality of life improved significantly in all studies, and the recovery time and pain was much lesser after EVLA. So with any new procedure, there's a whole list of new complications that you can get with glue. And with glue, what we see most common is the phlebitis following the glue injection, because ultimately it is a foreign body that is going to remain within the vein. And there's some people are hypersensitive to glue. There's a swelling often, and then some people have developed granulomatous reaction because it is a chronic inflammatory response.
The DVT is about 3.5%. It's a controlled propulsion of the glue, so glue-induced thrombosis is about 1.4%. And then the other things that are common to both all ablative procedures. So in total, when we have a look at the whole process, we see that it is comparable to RF and EVLA. So the common excuse that everybody made was, where is the 5-year data? Because that is what we have for RF and EVL. And so this was published in 2020. This is the VCLOSE trial follow-up. But if you actually go through the study, they've mainly concentrated on the demographics and the size of the patient and the size of the vein. And there is one slide in the whole study about, it's a Kaplan-Meier analysis about what the occlusion rates are, and they have said it is comparable to EVL and RF. So this is again 91.4, 85.2%. So in conclusion, we can say it's a safe alternative to thermal ablation. It's an office procedure. In our experience, we have done maybe about 30 to 40 of these patients. Patients are, it can be done in an outpatient basis. One of the main cons of do this procedure is it requires 2 people to do the job because there's one person has to apply compression while the other person injects the glue. And there's a bit of a learning curve that comes with using the gun that dispels the glue. And other than that, one of the main problems with using it regularly, what we find in our experience, is the cost of the process. So when we look at the results, they say that long-term results of more than 5 years is non-inferior to EVL and RF. So I think as of now, glue provides a good option for people who are a select group of patients who cannot undergo anesthesia. We see a large group of obese patients who may be rejected for anesthesia, or chronic venous ulcers, or people who are really worried about cosmetic results. Glue is a good option. Thank you so much.
Next, I would like to call Dr. Martinez, and he's going to talk about foam sclerotherapy.
Good morning, ladies and gentlemen. It's a great pleasure for me to give you this lecture called Sclerotherapy, Chemical Ablation, Is It Still an Option? I'm Hugo Martinez, and I'm a member of Aflebobasal, which is the Phlebological Association of El Salvador. We are doing this job with the endovenous chemical ablation, catheter-directed, ultrasound guided, using this long 30 centimeters catheter, 7 French, which we place at the point of the knee. We puncture the GSB and place the catheter until we get to the saphenofemoral junction. Once the catheter is in place, we infiltrate a local tumescent anesthesia to become this GSB very tiny, so we can get that size, almost the same size of the catheter. Once we have this, we start to pull over the catheter. As long as we are injecting polylocanal foam, we normally use 3% polylocanal foam, 0.1 millimeter of foam per every 1 millimeter of vein. Since we normally treat between 20 and 30 centimeters of vein, we normally use 2 to 3 cc's of polylocanal 3% foam to treat all the vein in the muscle. Once we have retrieved completely the catheter, we compress locally the size of the puncture, so we get anesthesia, and then we place these compression garments along all the pathway of the GSB, from the side of the puncture to the saphenofemoral junction. And after that, the patient is dressed with a compression stocking, 20 to 30 millimeters of mercury, and a compression bandage in the proximal third of the muscle. So the patient uses this compression for 24 hours. After 24 hours, the patient is authorized to withdraw the compression only to take a bath or to sleep. We encourage our patients to use the compression as long as they walk and as long as they sit, and we encourage them to walk. In this video, you can see how we place the tip of the central venous catheter in the saphenofemoral junction, and using ultrasound, we left the tip 1 or 2 centimeters below the saphenofemoral junction. If we have any doubt, we use normal saline solution to see where the tip of the catheter is. Normally, we use this method for patients who has an insufficiency of the GSB more than 1 second, affecting the terminal valve, and at least with 10 centimeters length, so we can place the catheter very near to the saphenofemoral junction, and with diameters between 5 and 12 millimeters, as described by the Latin American venous treatment guidelines. Beyond 12 millimeters, we normally use thermal ablation or open surgery to treat patients. 25 patients treated from August 2020 to July 2021. 15 of them completed the protocol, which is about chemical ablation the first day and 5 follow-ups. The first one at 1 week, at 2 weeks, at 1 month, at 3 months, and at 6 months. 17 GSB treated with a mean average age of 53 years old, with a time of follow-up average of 10 months. As you can see, the initial average diameter, the terminal valve and the preterminal valve, is 9 millimeters, and at 6 months, we find normally a diameter of 3.6 or 3.7 millimeters of diameter at the terminal valve and the preterminal valve, not a reduction of the diameter at 6 months. Patients describe the main symptom as pain in 2/3 of the patient, and the main sign as presence of varicose vein or active ulcer in 2/3 of the patients as well. Anatomical results, we found a reduction of 60% of mean diameter at terminal valve and preterminal valve of the GSB at 6 months. Despite venous flow was observed in 64% of our patients, reflux was only observed in 1 of the 17 GSB treated. Clinical improvement of symptoms in all patients was obtained, and closure of 4 out of 5 ulcers at 6 months. As you can see, we normally measure the diameter of the GSB at the saphenofemoral junction before the treatment. After the treatment, the spasm of the GSB is not removed, and at 1 month and 3 months, we normally get this image as complete closure of the saphenofemoral junction and respecting the flow at the common femoral vein. You can see the diameter diminishes at 6 months. We normally have a partially occluded saphenofemoral junction with flow at the terminal valve, but no reflux. Complications of the treatment were transient if there were present, but they were treated locally. Only we had 1 DVT that was treated ambulatory. Despite controversial anatomical results of the procedure, clinical results are quite outstanding, and patients are very happy with the procedure, as you can see in the images, and we as a medical team, we are very happy with the procedure as well. I invite you all to visit El Salvador, which is one of the few countries in the world where you can visit mountain and sea in the same day. Thank you.
So next speaker, Dr. Raul. He will speak on cryo laser ablation and cryosclerotherapy.
Good morning, everybody. Thank you, Deepak, and for organizing such a wonderful conference. I'm going to speak on aesthetic phlebology. I think it's a very important topic. At present, dermatologists haven't picked it up, and I do get requests from the dermatologists that they want to get trained in this procedure. And I think, vascular surgeons also are not picking it up at present because they feel it's a slightly different work. And it requires patience, and it looks very simple in the beginning. But the more you will keep on doing it, you will keep on learning that it requires also a skill set, anything like that. Because it's only in the skin. Really like to acknowledge all these guys. So they introduced me to this Clark's procedure or cosmetic phlebology around 4 years back. And 4 years back, we set up the department of Clark's and, all the cosmetic aesthetic phlebology department actually in the hospital. Hospital actually was not ready to set it up, and so I had to set it with my own money. But 4 years later, we are very happy with it because it took us some time to learn all, it's a different things. I cannot cover it in 8 minutes, but I'll just show you overview what we have learned in the last few years. So what we are talking about is the C1 stage of the SEEP. So this is what we are talking about. How do we treat this group of patients? And I'm not talking about this. So sometimes you have combinations of C1 and C2. So we always prefer to treat the C2 first. And, because sometimes there is a pressure from the C2 venous disease, and you follow these patients up in 2 to 3 months, and a lot of C1 disease goes off. And if the patient does not want any further cosmetic treatment, then we don't touch the C1 veins. Now, C1 is mainly because of cosmetics. So that's what we started when I started the practice, because I learned in Brazil, and all they were for beautiful legs, nothing else. And over a period of time, I realized that in India, there are less patients of beautiful legs, but there are more patients where we can treat these patients. I'll tell you what. So there are two types of veins you have to understand. One is the reticular veins, the blue color veins, what you can see over here, and they are like 1 to 3 millimeters. And please pay an attention to the below diagram. You have to understand, first the veins are blue, and then when they branch out, they become slightly lesser blue, what we call as telangiectasias, and then they also become red. So on the skin, you will see sometimes the blue, sometimes red veins. So it goes from the main vein, they keep on getting smaller and smaller, and the smallest vein, they will be red in color. Now it's important because the more red they are in color, the more oxyglobin is present. The more blue, the deoxyglobin is present. So that's what it is important, because that's how the laser works on the basis of hemoglobin concentrations. Now there are various ways to treat these veins. So I have mentioned, few of the options, and now which is the best option available, we really don't have an answer. So even if you look into the last year's publication of European Society of Cosmetic Phlebology, there is no clear-cut answers. So you can use multiple options for the treatment of these veins. So why not only use sclerosant? You see, the sclerosant drawbacks are basically, one is the reactions to the sclerosant. Second is, we cannot control it. Like if you want to do a vein on the face, you can't inject sclerosant because you cannot control sclerosant. It will just flow. Anyway, it can hurt the eyes, it can close the septums. Next is the skin damage, because if you inject slightly more, how do you know how much to inject? So you cannot have a fixed concentration. So you will have some complications. If you treat 100 patients, you will have 5 or 6 patients where you will have a cutaneous necrosis. The next is a pigmentation, which is, can take really 6 months to 1 year to 2 years for the pigmentation to go. So if you're doing it for cosmetic purpose, it's not very good. So Clark's means, so you do basically 3 important things in this. You do a transdermal laser with a sclerotherapy. You do use a cool layer because it hurts. And you use an augmented reality because you cannot put your hand inside and then do it because it's not possible. So this is our setup, outpatient setup, which we have put in. We put in an ND-Vike laser. It's better to buy this platform because this platform now is being used by the plastic surgeons also. So we do tattoo removals, hair removals, all the other things what we can use by the other specialties. And you can use the same machine for your aesthetic phlebology. You can use a very cheap, around 7 to 8,000 rupees thing like this, or you can use a vein viewer which costs around 5 lakhs. So, you know, depending upon how fancy you want to go and how clear you want to go. You have to understand why do we use an anti-Weick laser and how do we make it. You know, anti-Weick laser is a solid laser, and the solid component in this is yttrium aluminum garnet. And you got a chemical agent in this, what we got neodymium. So as soon as you put in this active medium in this tube and you put in a current, the atoms goes up and then they give you various wavelengths. Now, anti-Weick can give you various wavelengths, which I mentioned over there. So then you can select what wavelength you want. And with various studies, it has been found that 1064 is one of the best lasers which can help us. So if you look into this chart, you see the infrared, like, you know, the red light and infrared. So anti-Weick is a part of an infrared. So it's a mid-infrared rays, which is very good. And there are various advantages. Because it's a longer wavelength, so it can go much deeper. A better absorption in deoxyhemoglobin. So if you want to treat these blue lines, it really works very well. And very low power consumptions. So as it doesn't hurt the epidermis, as you know, the melanin is present in the stratums, from the bottom. And so it does not hurt the epidermis, so your chances of epidermal necrosis becomes very, very low. So let's take up 1 or 2 patients here. So look at these veins. Now, you can do phlebectomies here, you can do plain foam sclerotherapy, and especially in the foot veins. Look into the left picture, there are huge amount of foot veins, and people, the ladies, they come that you got a very prominent foot veins here, you got foot perforator incompetence, rest of all the veins are normal. So if you put in a sclerosant very high amount, then really you're always chance of getting a small vessel, you know, the venous peroneal or posterior tibial vein thrombosis if you inject directly, or it can very high chances of skin necrosis because if you use a dilute sclerosant, then the recurrence is very high. So we have tried all those stuff. So these things, they really work in the veins which are very, very close to the skin. I'll just put in this video. How do they do? We are using a coolant. We are using this anti-Weick laser. So we can use a 6 mm spot. And because that goes very deep. Don't use a 2 mm spot because that really burns the skin. And once you have done this, and then you can, under the vein viewer, you can inject a sclerosant. What sclerosant? You can decide. You want to use dextrose, you want to use 0.25 STD or polydocanol. And once you have done this, you see the results. Like the legs are very clean. So no phlebectomy can give you these results. Plain foam sclerotherapy does not give you these results, as you must have seen in your practice. Now these are the results we want. All that blue color lines, cosmetic. This is all cosmetic now. The results, what we are looking for. Spider veins, really. Now, looking at the pictures, it looks very simple. But mind you, this thing, achieving this result, it really takes time. It requires a lot of patience. You can actually do 4 EVLTs during this time. So it takes time, really. When I have to do this case, I really have to cool down from the arterial cases to coming just into the epidermis. And it's really, you have to have a different mindset to do this. Now, you can actually get this type of results very nicely. You can never get, I'll show you some pictures, very nice. So look at this. Very superficial C2 veins, reticular veins, some C1, and there is a skin necrosis. There is a small pigmentation. So this will happen in some of your patients, everybody. Look into this. Did we did a Clark's or a microfoam? So we did a combination. And you can see wherever I have got this pigmentation left over, that is because of the foam which we injected, a dilute foam. This will get lighter in 6 months, but there is there. So this was a combination of Clark's and plain foam, 2 sittings, but it really takes a lot of time. So foot veins can give you very good results. And look into this foot veins, you know, we can get fantastic results here. This is a man with a really troubled foot veins. As you know, there is no perforators. It's just a cosmetic, that small blush of veins on the foot, and which gives a really nice results. people, this guy was rejected from the army for that small little bit vein. So you can inject a sclerosant into it very easily, but that pigmentation requires time. So here, within a month's time, you can get much better results here. This another doctor, she had a very prominent facial vein here. You cannot use sclerosant. So we just used only plain laser. You can use the machine. I'm just putting in the uses where you can use it. So if you look into the published results, even the Clark's procedure is not 100% successful. So there is a failure. So we have also observed in our setup that if you just do plain Clark's, if you do 4 or 5 areas, there will be a recurrence of the veins there. And this is one of the largest studies published, 577 patients. And you can see the chances of pigmentation, which is very important, skin burn, and the matting is very, very low. It's nearly under 1%. So that's the beauty of using combination of Clark's and this. So what's the drawbacks? Cannot be everything good. I have already showed you. So there is a learning curve, definitely, and it's not painless. And, a lot of our patients, they really cry in pain. So we have started using the local anesthetic creams and make them wait, and then you have to clean it up or use the lesser laser settings with the repeated laser courses. It's an expensive setup. It's not cheap. It will cost you somewhere around 80 to 90 lakhs. And if we have to do the whole leg, means the whole day is gone. Okay? So it really takes time because it's very, very slow. So what we do is, whatever the most prominent area the patient is worried about, we do the Clark's, and we combine it with a plain diluted sclerosant in the other areas. So, this is what we have learned. Now, in future directions, we should compare the study. There is no comparative study head-to-head. Because, as you know, the C1 veins are of different types. So there are 3 studies underway. So we should be able to get the results this year. Comparison of exactly Clark's and plain sclerotherapy. Because sometimes I feel there are some patients where 0.25 polydocanol gives you also the similar results in some patients. But I cannot predict because some patients, it causes pigmentation. So I don't have a control on what the patient will get. Second is, different sclerosants like STD or polydocanol, they should be compared, which is very important. And I feel that all in the future, the Clark's needs a bit more clearance and the places where it can be used. I feel the foot veins, the facial veins, hand veins, and in very patients who are very sensitive to pigmentation, it should be used. Thank you.
Thank you, Rahul.
Next, Dr. Sheglo is going to talk about phleboarthrosis.
Dear colleagues, ladies and gentlemen, thank you very much for the beautiful possibility to participate in your conference. Several words about me. My name is Ernest Sheglov. I am professor in the Petrozavodsk State University. Petrozavodsk is a small city nearby St. Petersburg, nearby the Finland border. I am working on the problem of phleboarthrosis for more than 15 years, and I have a lot of patients. And I am very, very glad to discuss you and to describe you some of my results. You see that phleboarthrosis is a very huge problem, and the last time we were speaking about it in different journals, as in Russia, as in the international journals. I want to talk about its treatment. You see that in the United States, we can see that in 1918, the last guideline for the management of the osteoarthritis of the hand, hip and knee. It's the last reduction of this guideline. And what we can see here, the knee arthrosis. We can see that the most important drugs are oral non-steroid anti-inflammatory drugs and topical non-steroid anti-inflammatory drugs, which are strongly recommended. I don't know the situation in India, but I know that in Russia the most important drugs are glucosamine and chondroitin. And in the United States you can see that these are strongly against using these drugs for knee phlebotosis. We can see oral and topical non-steroid drugs are most important, and other drugs are strongly recommended or recommended against. We can see that the non-steroid topical anti-inflammatory drugs are the most important, but their doses should be as low as possible, and the treatment should be continued for as short time as possible. Also we can say that these drugs are very important part of the knee osteoarthritis treatment, but we must use them as short time as possible and in the lowest possible dose. So, we must welcome any drug or any method that can reduce the non-steroid anti-inflammatory drug dose or the duration of treatment. The purpose of my investigation was to evaluate the influence of vein-active therapy on phlebotosis patients' need for non-steroid anti-inflammatory drug. The main principle of the investigation was that we have a group of patients with a knee phlebotosis. That was the combination of varicosity and knee arthrosis, osteoarthritis, but we have no varicosity, these patients had no varicosity treatment before our investigation. What we do? We have no changes in arthrotic treatment. The same treatment as it was before the investigation. The same drugs, the same physical rehabilitation, no changes in the arthrosis treatment. But we use micronized purified flavonoid fraction and compression stockings for these patients. And we evaluate the influence of this treatment on the need for non-steroid anti-inflammatory drugs for these patients. The clinical group was 105 patients, the control group 37 patients. The diagnosis was confirmed by X-ray and ultrasound, no varicose treatment before, and the evaluation before treatment 6 and 12 months after the beginning of investigation. The clinical group received regimen recommendations, compression stockings with a pressure between 20 and 30 millimeters, and micronized purified flavonoid fraction once a day. Control group, the same treatment as it was before the investigation, the treatment only osteoarthritis without varicosity treatment. The results. We evaluated the patient's need for non-steroid anti-inflammatory drugs, but we can't evaluate the exact dose of the drug because the patient used the different drugs before the investigation. So we used the survey with the possible answers. The need for non-steroid anti-inflammatory drugs has decreased strongly, has decreased, the need without changes, and the need has increased. What results we received? The clinic groups, they reported that 79% of the patients decreased the need for anti-inflammatory drugs. Strongly decreased 12%, and without changes 9%. The control group, without changes 86%, decreased 8%, and increased the need for anti-inflammatory drugs 6%. That's why we made this conclusions that vein-active therapy reduces chronic vein insufficiency symptoms and decreases the need for non-steroid anti-inflammatory drugs in patients with knee phlebotosis. This therapy must include compression stockings and micronized flavonoid fraction. Now we have more than 15 years of investigations, more than 1,000 patients with knee phlebotosis. I will be glad to discuss the problems of pathogenesis, diagnosis, treatment of this disease. For example, I think that the very important question is the question of the hen, the chicken and the egg. Varicosity leads to knee arthrosis or knee osteoarthritis, arthritis leads to varicosity. I think that I have the answer on this question. Thank you very much for the possibility to participate in your very interesting conference. My email is on this slide, and I will be very glad to answer the question or to discuss any problem with all my colleagues from India. Thank you very much. Best wishes. Bye.
Next presentation, the topic microwave ablation and its clinical outcomes. The presenter, Dr. Motsas.
Respected colleagues, ladies and gentlemen, good morning. My name is Matjaž Vrtovec. I'm interventional radiologist from University Clinical Center Ljubljana, Slovenia. I'm honored to present at this distinguished VACON 2022 meeting. I will talk about our initial experience with microwave endovenous ablation technology. Microwave endovenous ablative technology is relatively new, not mainstream and not very known. It is more niche or still exotic modality as HIFU. It is thermal ablative method and it requires use of tumescent anesthesia where done. Of course, every interventional radiologist, phlebotomist, or vascular surgeon has its preferred endovenous modality. In reality, to achieve optimal result, the best is to use modality which addresses best anatomical, constitutional, and functional specialties of the patient. Microwave part of electromagnetic frequency spectrum is stretching between 1 and 300 gigahertz. Microwave field, when applied to tissues, causes water molecules to rotate very fast, and friction produces heat. In theory, microwave technology should have bigger and more homogeneous volume of ablation and should be less dependable of thermal conductance of tissue around the active probe tip. It does not need electrical conductivity of the tissue to produce heat. Ablative efficiency, especially when tissue immediately around probe tip becomes more dry during ablation, can affect the ablating efficiency. Literature about microwave endovenous ablation and about comparison to other modalities is not very vast. If we try to draw some modality comparison from their use in the field of oncology, microwave ablation should offer less peri-procedural pain, larger and more predictable ablation volume, and in theory, this should result in more consistent ablative effect. In our institution, we use microwave system produced by Eco Medical Instruments, China. It consists of dedicated microwave generator unit and disposable, soft tip, flexible, not sterilizable microwave probe. When introducing probe into the vein, 7 French introducer sheet is needed. Maneuverability of the probe in the vein is good. The probe has blunt soft tip and can be successfully steered also through slightly tortuous veins. Probe active tip measures 2.5 centimeters and is very well visible at ultrasound, as you see on screen. About our series, we included patients older than 18 years with saphenofemoral opening measuring less than 10 millimeters and venous disease graded C2 to C5. Patients with active cancer or infective disease and also pregnant women were excluded from the series. Patients with past DVT or recurrent varicose veins were not excluded. Ablative modality, microwave modality, was chosen randomly. We started with the first microwave procedure almost exactly 1 year ago. Till 10 days ago, we performed 42 microwave procedures on 42 veins and 42 patients. Majority of treated veins were great saphenous veins. Initially, we used ablative protocol as suggested by manufacturer, that is 40 watts for 7 seconds per segment. Ultrasound follow-up was planned at 3, 6 and 12 months post-procedure. Because of not very favorable first results or technical outcome when using 40 watts protocol, we recently changed ablative protocol, upgraded it to 50 watts per segment. Presence of edema, pain, cramps was also evaluated. Patients filled out civic questionnaire, but those data was not yet included in our results. Till 10 days ago, we controlled 26 limbs on 26 patients. After initial 40 watts protocol, 13 patients were controlled at least 3 months after ablation. 5 of them, that's 38%, presented with completely closed vein. In 4 patients, ablated vein was still open but showed no reflux. 1 patient had partly opened, partially insufficient vein, and in 3 patients, that's 23% of them, ablated vein remained open and also insufficient. In patients controlled 6 and 12 months after the 40 watt protocol, the number of patients controlled was 9. Only 1 patient was controlled after 1 year after the procedure. Of those patients, in 6 or 60%, ablated vein was still open and still insufficient. In the other 5 patients, in the other 4 patients, or 40%, ablated vein was successfully closed. After changing the protocol to 50 watts, only 3 patients were controlled till now, after 3 months post-operative. So no realistic statistical comparison can be done yet, but nevertheless, known still open or insufficient vein was noted. 2 treated veins were completely closed and 1 partly closed, but clinically none of the controlled patient was symptomatic anymore. No edema and no pain or cramps were present. So we can probably conclude that microwave technology has a good safety profile, is well tolerated by patients, but actual by manufacturer recommended ablative energy is probably too low to achieve favorable result. Corrected, higher 50 watts energy protocol might prove optimal result. Connection between vein diameter and successful ablation is quite probable. Thank you for your attention.
Thank you. Now we'll start the discussion. Anybody from the audience would you like to? Yes.
Hi.
Yes,
This question is for Rahul, if he's around.
Yeah.
Yeah. Hi. Rahul, so for CLACS, I think one of the challenges with cutaneous or transcutaneous laser has always been how safe it is in darker skin people. So I just want to know what your experience has been with using in the darker skin, and you get more cutaneous burns in that?
Yeah, fortunately, North India. So we don't, as you know, there are 6 second grades, and normally most of the skin what we have treated, they are grade 4, grade 3. And so we hardly get any patients with 5 and 6. But if you look into Brazil, they do get a lot of patients at 5 and 6, and you just need to lower the energy. And so you can do it, there's no problem. But you just have to lower the energy, that's it. Because you see, most of the skin, this anti-VAC will go deeper into the deeper dermis. And so it will not affect the epidermis. So unless you use a smaller diameter shot, like, so we use a 6 mm spot, so which will cross the epidermis. And so it will not get absorbed by the melanocytes. So even if you have a darker skin, it will not affect. So, but yes, definitely you need to lower the energy if you have higher, and if you have to increase the energy if you have a whiter skin.
Yeah. I think this is something that probably those of us who practice in South India and
Yeah.
you know, maybe
It
other
will-
parts of the world need to be very
Yeah.
aware of. And unfortunately, it doesn't always come up in the Western literature and the Western discussions.
Absolutely.
So we can get misled on that. But
No, no. But
thanks
this-
for bringing up those finer
No, no,
nuances
no.
of
These
how to
are,
deal with it.
this is the basics of when you do an anti-bike laser, any skin laser actually, and that you need to know the type of skin. So the first thing, if you look into the protocols published by any company or anything, is the first thing what you do is a type. And then you go for the doses. But it's a very important point for the people who are very, who are just doing the beginning.
Right, one more follow-up.
Yeah, please do, please do.
So this is to Dr. Matej. I mean, fantastic presentation and congratulations for the honesty of what you've shown. It's not very often that people are willing to show the results which were not quite up to what they would expect. But seeing what your results are with microwave, where do you think its position lies today, given that you have, in a sense, better established technology like RF and laser?
No, you're not audible.
Maybe once he's back.
He's not.
So this is more of a comment than a question. If you see amongst all the presentations that were made, the results are basically based on what the initial diameter of the veins were and what the final diameters of the veins were later. So I would like to ask members of this audience and the panelists, what do you take as the diameter in which position of the patient? Are we keeping a standard 45% inclination of ultrasound of the patient while taking the diameter of the GSV? Are we taking it in a standing position or is it in a supine position? In all three different positions, the diameter of the vein is grossly different. So there has to be some standardized protocol, at least in our association amongst our members, when we measure veins. Most of the radiologists, when they give a report, they do that in a supine position. There are two problems with this. One is in the supine position, the vein diameter is much lesser. Secondly, many a times you will never get reflux in the supine position. And therefore, when the patient stands up, there are gross varicose veins. When he goes to the radiologist center, the patient is lying down, there are no varicose veins seen, and the results of the radiologist is this is normal venous dominal study. So I think we should come to a protocol. I know it's very difficult for us to have a patient in standing position, but at least if 45% inclination is done, that should be the standardized protocol for ultrasound in all our patients, and also as far as procedure, diameter of the vein is concerned. I like the opinion of the Apollo.
Pinjal, any comment, Pinjala?
I will pass. Absolutely very good point. And we, when we started including all our patients into the study, so this was the basic problem we had. So because how to measure in the standing position the pre-op, and sometimes you are in on the outpatient, the people will take the patients on table. Then we went through the research and found that there are a lot of studies which have taken the diameter as a standardized in the lying down position at the 45 degrees. So that then we standardize all our protocol that all the measurements we will do will be at 45 in a standing position, 10 centimeter below the septum-femoral junction. Because and this is, there are a lot of papers on that. Because you should not measure at SFA or 2 centimeter because sometimes that is very dilated and the rest of the vein is approximately 8 to 10 millimeters and you could have a 14 millimeter, 15 millimeter at SFA. So if you are doing any studies, I think you can, what we do in a practice, we are collecting all data. So we have standardized that and we have found that below, near this, sometimes the vein is very small. SFJ is very big sometimes. So around 10 centimeter below the SFJ is a very nice place, is reported. But we can standardize everybody.
The protocol which we follow and which we discussed last time in the Asian Venous Forum was this. Size of the GSV at the terminal junction, terminal valve. When I say that, it means at the junction of the superficial and the deep vein, number one. Size of the GSV 2 centimeters away from that, because most of the time when you're doing ablation, that's when you're ablating it. Thirdly, in the mid-thigh, not a particular level of so many centimeters, because size of the thigh will differ in different people, from the knee joint to the groin, mid-thigh. The reason for this is that many times mid-thigh perforator is just at this particular level and size of GSV below that is much higher. Then 2 centimeters below the knee joint. Because again, there is a below knee perforator which sometimes goes into the GSP and causes dilatation of the vein. And then 2 centimeters above the ankle joint, again for the simple reason that sometimes there is a mid-leg perforator and above ankle perforator. So in each individual patient, if you take these as their standard diameters, then you have a proper diameter setting. Now this is a suggestion, but I think VI should take this up and make a formal protocol so all our members would follow this.
Thank you so much. We'll have to halt the discussion here. Once again, thank you to all our panelists, our speakers. A special thanks to Dr. Matt Jas for joining us throughout, and he's joined us virtually. We are glad that he stayed through the session. Thank you to our chairperson, and thank you to our panelists once again. Few announcements to make. Yes, you can applaud. Please put your hands together for our speakers and the entire session panelists and our chairperson. On that note, I have few announcements to make. We do not have any coffee breaks during the entire conference, but just in case you want to grab a coffee, you may walk behind the panel, which is right there, and take a left. You'll find a coffee shop. You can grab your coffee and you can quickly join us back. And those of you who want to visit the stall, there's a Tulsi stall which weaves Kanchipuram silk saris. They are the experts in the field, and you may visit the stall and help yourselves right there for more information. We do have a gala dinner today at 7 p.m. and that is at Savannah Hall. Also, we have back-to-back sessions. Thus, those of you who are the designated speakers, you're requested to load your presentations, load your talks at the Hall B and run them through. Those of you who just want to have a technical check, you may walk to the corner of this hall towards your right, and you will be able to help yourselves with the technical check. We would now like to move ahead to our next session, but just before that, doctors' papers, that starts at 9 a.m. Those of you who are presenting are requested to assemble at the other room. We'd now like to start with our session, and this is deep venous disease. I'd like to invite our chairperson, Dr. Edmund Stephen, and Dr. Tarun Grover to please join us on the stage. May we have you on the stage, please. I'd like to invite our panelists to join us, Dr. Bhakta Vachalam, Dr. Rajarajan V, Dr. Balakumar S. Do we have them with us? Yes. I'd also like to invite Dr. S.K. Tiwari and Dr. Ilya Kumar to please join us on the stage. I'd like to request each of the speakers for stepping up to the stage. Your time limit is 8 minutes only. We'd really appreciate if you can stop at 7 minutes 30 seconds. And those of you who are asking questions are requested to come closer to the mic, be louder and be clearer. And the session's about to begin. I'd like to hand over the session to our chairpersons. Over to Dr. Edwin and Dr. Tarun.
Thank you. Thank you for that. For a minute, you had my attention when you said you can go and speak to the Kanchipuram sari people and they will help you. And then she said with information. I thought we'd get some saris for free. Thank you. So we'll get on to the session without much ado. And we have Dr. Robbie, who is going to take us through the nuances and the importance of IVUS in deep venous system. We all know that this is coming on, and thanks to inputs from several of us sitting in the hall and those joining us virtually, this is quite an important topic. So over to you, Robbie.
Thank you. So just saying it's good to be back here in Mahabalipuram, so I'll get going with this. So we all know what the limitations of venography in looking at the deep venous. Essentially, you're looking at a low pressure system. There's a poor correlation with compression because the pressure differentials are really very low. So you always look for other clues. Is there some pancaking? Is there some flattening of the vein? Are there collaterals? Or we started doing what we described a long time ago, looking at trial ballooning to see if there is a narrowing. Now, none of those are particularly good. So that is where the role of IVUS first came in. So IVUS takes its origin in the coronary world, where it was very popular. It was really brought into the peripheral venous system by good old Dr. Raju, who we've all got to thank for unveiling the deep world to us. And after many years of the work that he did, they'd come up with this trial, which is the venography versus intravascular ultrasound for diagnosing and treating iliofemoral vein obstruction, which is the video trial. I'm just going to quickly go through this. So that's just the data on the basis of which we are kind of defining what should be practiced today. So they did 100 patients across 14 centers, looking at advanced disease, so the indications for doing it were right. They compared multiplanar venography, looking at the common, the external iliac, and the common femoral vein in 3 directions, in 3 planes. And they did an IVUS for all patients, and they considered more than 50% stenosis as significant, which is fair. What they found was that multiplanar venography underestimates diameter reduction significantly. If you use diameter measurements alone, using venography, you will miss a lot of lesions. When you start doing IVUS, and you use this definition of 50%, you will pick up an additional 1/3 of patients whom you would have missed on venography. And most of us, we actually practice venography maybe in multiple planes with a trial ballooning to try and identify these more subtle lesions. So what's been the impact of doing an IVUS on a patient where you suspect deep venous pathology? So the distribution of treatment plan changes. If you look at the 57 patients who underwent treatment, 35 went from no treatment to getting a stent. So literally 1/3 of your patients ended up getting a procedure where they were not. In 13, the number of devices you required extended because you were able to identify the extent of disease as being more than what was apparent just on a venography. And in some, it changed the plan from treatment to something else. And in 3, it actually changed the plan from treatment to no treatment, which is actually interesting that you were able to define on IVUS the problem as something else and putting in a stent is not going to solve it. So what video showed was that IVUS is more sensitive for assessing treatable iliofemoral vein stenosis compared to venography, and it leads to revised treatment plans, which is fair enough. Now, when I started looking at IVUS first, it all seemed like one black blur, and I really did not understand very much of what was going on. So I'm showing you a couple of videos which hopefully have come from our experience, and hopefully is a bit easier to understand. So this is just an introduction of what IVUS looks like. So you see the middle bit over there where the catheter is kind of, you can see the catheter in there. Up there, somewhere at the top or the bottom, anywhere, it can be the aorta. Now, remember the IVUS catheter does not always sit at 12 o'clock. So the aorta can be at 12, 6, 4, 3, anywhere in between, because the catheter itself can rotate. The blue bit there, the big black one in the middle, is of course your IVC. And as you come down, you begin to see the bifurcation of the aorta splitting into the right and the left common iliac arteries. And you can keep identifying this. And remember, the artery might swing around as your IVUS catheter rotates. And you can begin to see compression of the left common iliac vein between the vertebral body behind and the iliac artery above. And this is not something which you're very well able to appreciate on a normal venogram. And you can keep tracking this. So you see the left common iliac artery where it splits again into the hypogastric and the external. This is another site where you get compression of the iliac vein. This is another site which you're able to identify on IVUS, which is very easy to miss otherwise. So when you do an IVUS, you really want to start from the very top, pull back all the way down. And I always combine this with an ongoing fluoroscopy so that I know where the catheter tip is. So I've got a fluoroscopic landmark and what I see on the IVUS for me to figure out where I am. So this is one of our patients where we did a venogram, and it looks like maybe there is something at the right common iliac vein. When you do the IVUS, you see the degree of compression she has over there of her left common iliac vein, which confirms the fact that there is a problem which looked very equivocal. So by doing IVUS here, we were happy that there is a problem. You do your diameter measurements, and this gives you good accurate diameters as to what is the size of the normal common iliac vein where you want to go in. And it does an area calculation, and it actually shows you area reductions as well if you want to see them. So when you look at area reduction, that is much more specific for knowing how significant the degree of hemodynamic obstruction is. Once you have that, we stuck in a stent. The venogram looks beautiful. And if you look at the IVUS, so that's coming into the IVC, you're beginning to see the top of the stent struts coming down, and the stent is nicely expanded. The vein walls are touching it all around. So this is an appropriately sized stent that has treated the entire lesion. So we'll be able to size the stent correctly when you do that. This other case was a chap with 2 chronic venous leg ulcers, both legs. He's had them for years. Superficial scans did not show much. And when we do the venogram here, he repeatedly has significant reflux down both iliac veins. The blood's just not going into the IVC. And when we do an IVC venogram, again, there is reflux coming all the way down into both the iliac veins. So is he a classic refluxing pathology? And honestly, we used to do a lot of deep vein valve reconstructions, but since the onset of deep vein occlusion that you've worked it out, you realize that the majority of them have an occlusive problem somewhere. It's this failure to identify because of which we ended treating that. We did another venogram going higher up, and you see what looks like a classic suprahepatic IVC narrowing. Now, is this just part of the diaphragmatic pinching, or is this real? So when you do the IVUS here and you're coming down from the heart, you see that area of narrowing that just went past? That was a really, really tight, narrowed segment which was scarred. Can we play this video again, please? Unfortunately, I don't have the controls here. Yeah, thank you. So coming now, you see that bit where it just squinches down? That helps you identify what is happening there. And this is when we come down the right leg. This is from the IVC, that narrowing within the, where it joins the heart. And when you inflate the balloon, we actually don't see that much of a waste. And this is the problem in the venous system. You can have a subtle obstruction which is causing significant hemodynamic compromise. This is not like the arterial system where a tight stenosis is always seen. So we go ahead, post-IVUS, there is better clearance. It still does not look great. I'm personally not very happy to put in a stent over there which might stick into the right atrium. So we elected to just plasty that. Did a venogram on both sides, which again now shows that there is forward flow going through, but it still looks flattened. We decided to stent both iliac veins. So this is the post-stent. So you're seeing the stent coming up shortly inside. That's the stent. That's the opposite side stent that we're seeing over there as we come down. The ipsilateral stent, again nicely within the system over there. And similarly on the other side. So IVUS here showed us that we have actually managed to treat both of those iliac vein segments adequately. This is at the top end of the IVC where we are coming down. Looks clean, keeps looking clean, and we don't see the narrowing we saw before, which made us much more happy about not putting in a stent into an area where we did not really want to put in a stent. So IVUS changed what we would have done here. We've used IVUS for following up patients who've had stents, who've not got anything new, but we just want to make sure they're not missing anything. And you see this again, that your stent is widely patent. This is somebody whom we've done an endovenectomy and a stent for. Venograms look good, but again, these are patients who are precious. You don't want things going wrong. You do an IVUS, the stent is nicely in place. There is a lot of scarring around it, but the stent is open, not compressed. There's no luminal loss. And lower down, we come into the endovenectomized segment, which also looks fine. So IVUS definitely adds to the diagnostic and therapeutic decision-making process for deep venous disease. I personally don't think it is that helpful in post-thrombotic syndrome, other than for the sizing. It is especially useful for the compressive syndromes like the classic May-Thurner. Thank you for that.
Thank you, Robbie. Thank you. We'll take questions in the end. Thank you. I think we have Dr. Arvind Das Lee, who I was hoping to meet in person here, but he's probably sent in his recording on, again, another topic that we don't see much of, but is of interest, Paget-Schroeder syndrome.
Greetings, friends. I'm here to discuss some of the issues with the management of Paget-Schroeder syndrome. And I'm grateful to the organizers for providing me with this opportunity. We all know that it is a rare condition. It is seen predominantly in men in their 20s and 30s who are otherwise healthy and often athletic, muscular build. It is more common on the right side of the For the pathogenesis, one has to look at the anatomy of the thoracic inlet again. The subclavian vein traverses through a narrow space between the first rib and the medial end of the clavicle. In this space, there is also potential compression from the subclavius muscle and the costoclavicular ligament. Repetitive trauma over the vein from all these structures can lead to perivenous scarring, which ultimately leads to sudden acute thrombosis, which presents as epoch thrombosis. The diagnosis is often obvious on history and examination. Duplex imaging can be confirmatory, sometimes limited by body habitus and the presence of the clavicle. When in doubt, we perform a CT venogram. MR venography and catheter venography are also other options. Hematological testing for thrombophilia is not generally warranted. However, there's some data to suggest that there's a high prevalence of thrombophilia in this cohort. We did have a patient not long ago who ended up being a triple positive antiphospholipid antibody syndrome. He had extensive clot burden, including the superficial veins in the arm. So anybody with that kind of presentation, along with some unusual features, may warrant a thrombophilia screen. Moving on to the management, which is of course the main purpose of this presentation. So what happens when we just anticoagulate these patients, which is in fact what the ACCP recommends for all upper extremity DVT. Data suggests that there's a 20 to 30% risk of severe post-thrombotic syndrome with just anticoagulation. We have data from the late 90s, which seems to suggest that with anticoagulation alone, you can expect total symptom resolution in anywhere between 17 to 40% of people. So the vast majority will be left symptomatic with coagulation. Looking at lysis, it can of course be of any form, CDT, pharmacomechanical with devices like the AngioJet, JEDI, even the ECOS catheter, any form of lysis would work, and what was available can be used. And provided that the indications have been appropriately selected, one can expect that with lysis you should have good thrombus resolution. And usually on venography after lysis, one would find significant venous scarring in the just below the medial end of the clavicle. However tempting it may be, it is not the time to be performing any endovascular treatment at this stage. It universally leads to poor outcomes. Because of this, we look at decompression of the underlying bony fossa within the thoracic inlet. And this centers, of course, on removal of the first rib. A systematic review in the Annals of Vascular Surgery in 2015 showed up to 95% relief of symptoms with first rib resection as compared to 54% with lysis alone. Another systematic review published quite recently in the JVS 2021 again gave very good results with first rib resection of symptom relief up to 98% as compared to 70% for lysis. So to summarize the treatment outcomes, anticoagulation alone, one can expect about 40% complete resolution of symptoms. With adding lysis, you can expect anywhere between 55 to 70%. And when we have decompression using the first rib resection techniques, then we can get over 95% symptom. So if it is worth removing the rib, when should we do it? There are a few things to consider in response to that question. Firstly, data would show that in 1 in 3 patients, there will be a risk of rethrombosis of the lysed vein if the time between lysis and decompression is extended beyond 6 weeks. One of the fears with performing rib resection early after lysis and having the patients marinate in heparin for many days is the risk of bleeding and complications. Data would suggest that in most first rib resection series, the risk of hemothorax and significant nerve injury runs at about 1 to 2%. A recent randomized, not a randomized trial, a systematic review shows that by doing the first rib resection within 2 weeks of lysis, the bleeding rates runs at about 7% compared to when it is done after 2 weeks. However, there is a compromise in terms of the preoperative recurrent thrombosis. Subgroup analysis of this series showed that in 2/3 of the patients in the early group who had bleeding complications, most of them were in the group that had their ribs resected within 24 hours after lysis. So that would suggest that the best window is anywhere between 1 to 2 days after lysis to 2 weeks from lysis time. What's the best approach to removing the first rib? Transaxillary is familiar to a lot of us. What one must remember is that the areas of bony compression is actually in the anterior end of the first rib and also over the medial end of the clavicle and its attachments. And even with the transaxillary approach, it is important to extend the resection to include this part. A supraclavicular approach, which is again what we would use for arteriothoracic outlet, would be somewhat compromised in terms of removing this part of the first rib simply because the vein would get in the way. We find the infraclavicular approach is the best approach for venous thoracic outlet syndrome. This is a relatively straightforward approach, starting below the clavicle on the medial end and removing the subclavius muscle and the costoclavicular attachment before taking care of the rib. We often don't end up removing the posterior end of the rib, but it doesn't appear that that is going to be of any great significance. Should we be stenting the vein or considering things like open venoplasty? In my limited experience, I would say no. Patients tend to do quite well once they have had lysis and first rib resection, regardless of how ragged the vein looks after venography and angioplasty. There are, however, some series which have looked at stenting in this space, and patency rates tend to range between sort of 55% for primary patency and up to 100% secondary patency. I do not think that it would be something to use on an every case basis, but something to consider if there is significant residual stenosis or symptoms in the longer term follow-up. So to summarize, anticoagulation alone may not offer good symptom resolution in majority of cases. Lysis and first rib decompression offer better long-term outcomes with excellent resolution of symptoms. The infraclavicular approach is eminently suitable for decompression of the thoracic inlet. Stenting is not something that is routinely recommended and may be reserved for persistent symptoms or high-grade stenosis on follow-up. Thanks for your patient listening, and I'm happy to take some questions.
Thank you, and now we move on to the next speaker. He happens to be Dr. Adarsh Kabra. He will be joining us virtually from Jaipur, and he's going to speak on pelvic venous disorders.
Good morning, everyone. Well, to define pelvic venous disorders, it's the spectrum of symptoms and signs that arise from the veins of the pelvis, that is the gonadal veins, the internal iliac veins, and their tributaries, and the venous plexuses of the pelvis, and their primary drainage pathways, which involves the left renal vein, the iliac veins, and the pelvic escape points. Now, before we head down to what exactly pelvic venous reflux is all about, we need to first find out what the anatomy is like. Now, what we need to understand is that a single internal iliac vein is seen in approximately 73% of the patient population. 27% have two separate internal iliac vein trunks, which can be separated by nearly 2 centimeters. More common in females, nearly 35% compared to males. And if there is a duplicated trunk on one side, there is a 50% possibility of the duplicated trunk on the opposite side also. Very rarely the internal iliac vein can drain directly into the common iliac vein confluence. I have myself seen 4 such cases, and it is an important variation to remember. As far as the valves are concerned, the common iliac vein had a valve in only 1%. The external iliac vein had valves in 26%, which was a parietal bicuspid valve, usually located 2 centimeters from the ostia. The right external iliac vein system had 3 times more valves compared to the left. And the internal iliac vein had developed either ostial or parietal valves in only 10% of the patient population studied. Clinical history has a lot of meaning in this situation because there is a significant overlap of symptoms between the venous and non-venous causes. Venous origin renal symptoms can relate to micro or macrohematuria. It can be also left flank or abdominal pain, which can be worsened by standing, sitting, or walking. There can be pelvic symptoms, which can be dull unilateral or bilateral pain with occasional sharp flares. There can be pain at the buttock or perineal region in the standing or sitting position. Prolonged postcoital pain is very frequently seen in this situation. Now, a combination of postcoital ache and tenderness over the ovarian point was noted to be 94% sensitive and 77% specific for distinguishing a venous origin cause from other causes of chronic pelvic pain by Baer et al. Way back in 1988. Now, of course, symptoms can be localized to the external genitalia or the lower extremities also, and they arise from either reflux through the recognized escape points in the pelvic floor or from iliocaval venous obstruction. In men, it's often seen as testicular discomfort or infertility. Very, very rarely does it cause features of chronic venous insufficiency in the lower limbs. Rarely, it can be associated with sciatic or tibial nerve symptoms. Symptoms associated with sciatic nerve varices include pain radiating from the buttock to the lateral aspect of the leg, which is often worsened by sitting. Now, of course, there are various pelvic escape points that we all should understand. The obturator and the ischiatic escape points lie towards the anterior part of the pelvis. The pudendal escape point lies towards the center of the pelvis, whereas the gluteal escape points lie towards the posterior aspect of the pelvis. Now, there are different sources of reflux that can happen, and these sources have been divided into different zones. Zone 1 consists of the left renal vein. Zone 2 consists of the gonadal and the internal iliac veins with pelvic venous plexuses. Zone 3 of the pelvic origin extrapelvic veins, and Zone 4 involving the lower extremity deep and superficial veins. Now, we must understand that a reflux arising in Zone 1 can lead to symptoms in Zone 2 and also in Zone 3, and similarly reflux arising in Zone 2 veins can lead to symptoms in Zone 3 and Zone 4. Now, different patterns of reflux have been seen. The most commonly identified veins which were refluxing was the left ovarian vein and the right internal iliac vein. The right ovarian vein was the least refluxive vein in the pelvic venous system, and a combined reflux was seen in more than 50% of the patient population studied. Once we know that there is a pelvic venous congestion or reflux or a disease that is happening, of course we need to evaluate these patients further. The first examination is always a transabdominal or a transvaginal duplex. Further evaluation can be either in the form of CT or MR, and even a dynamic conventional venography with or without the use of an intravascular ultrasound. Now, there have been various classification systems that have been used for the assessment and management of pelvic venous disorders, but the one that encompasses a complete anatomic and hemodynamic picture is the SVP classification that has been proposed by Mark Meisner's group, which consisted of various professionals from across the globe. Now, the SVP stands for the symptoms, varices, and the pathophysiology, divided into four different sections, just like the SIAP classification. And similarly, for the symptoms, it's the varices in different segments. And of course, the pathophysiology consists of the anatomy, the hemodynamics, and the etiology, the A, H, and E segment of the pathophysiology component. The anatomy, of course, looks at all the veins that have been studied along with the pelvic reflex points, which is mentioned as PELV. You can see that at the bottom of your slide. The hemodynamics, as we all know, in these veins can be either obstructive or refluxive, and the etiology can be either thrombotic, non-thrombotic, or even congenital, very rarely. How to use this classification? Well, first and foremost, all 5 domains and subdomains have to be documented individually. We must understand that the pathophysiology domain, or the P domain, includes the anatomy, hemodynamics, and the etiology. Now, let's say if there is a May-Thurner syndrome of the left lower extremity causing edema, it would be classified as an S0, V0 because there are no symptoms or varices related to the pelvis. It will be classified as pathophysiology as the left common iliac vein, the hemodynamics as obstructive, and the etiology as non-thrombotic. Now, along with this, also the SIAP classification is supposed to be used in its independent manner to do a complete assessment of what the pathology actually is like. And of course, there's a scoring sheet that has been given, which can be used very comfortably. Now, the treatment, of course, consists of embolization. Various forms of embolization materials and techniques have been used. Coils, of course, are the ones that have been used most commonly. There is a hybrid technique also that is used, which uses foam distally in the varicosities and coils proximally in the main trunk. A lot of investigators have used glue with or without foam, and very rarely even plugs have been used to occlude these vessels if the vessel is grossly dilated. Now, we should understand that ablation should start distally and proceed approximately both to stop reflux in the future and to reduce the risk of pulmonary embolism of any device that is left high in the vein. Of course, the outcomes. Literature has been divided as far as the success of symptom relief is concerned, and the success ranges from 60 to 100%. We must understand the difference between technical success and patient-related symptoms, and last but not the least, we must also understand that the cause of chronic pelvic pain can be both venous and non-venous, and both these pathologies can coexist at the same time. Thank you very much for your patient hearing, and I thank the organizers for having given me this opportunity to present my views on a very complex yet not looked at very frequently problem as far as venous pathology is concerned. Thank you very much for your time and attention.
Thank you, Adarsh. Now we move on to the next topic, which is happens to be an interesting topic, venous trauma, the battlefield experience, and Dr. Manvendu Jha is he going to join us here or is going to join us virtually? Virtual, okay. So let's move on to his talk as well.
Morning everybody. I will be discussing my small experience of venous trauma that we managed over a period of 4 years in an austere environment, basically in anti-insurgency ops. The period of my study ranged from January 2017 to September 2021. In above this, we included all patients with arterial and venous injuries. The brought in dead patients were excluded from the study, and pro forma was noted in terms of age, sex, transfer time, the mode of injury was most of the time it was penetrating, and the treatment given, complications and outcomes. The age of the patients were all young serving soldiers, ranged from 21 to 47 years. We had 46 arterial and 54 venous injuries. Most of them were combined. There were few isolated injuries. All cases were, the nature of injury was all ballistic in nature. All gunshot wounds or splinter injuries or mine blast injuries. This is one such injury which came. It was multiple splinter injuries, if you can see. They are not bullet wounds, there are multiple splinter injuries which came of the left lower limb. The majority of the involvement was the lower limb. We had 24 cases involving the lower limb veins. Majority was popliteal vein. We had 15 injuries, out of which 4 were isolated popliteal vein injuries and 11 were involving both artery and vein. Same for femoral, we had 2 isolated SFA V injuries and 4 combined with the SFA. Sorry, the tibial veins we had 3 cases. In the upper limb and all, internal jugular vein and SMV. In abdomen we had renal veins. In the associated injuries we had all sorts of things, including craniofacial trauma, thoracic and abdominal gunshot wounds, orthopedic and nerve injuries. So overall, we had the lower limb vein involvement in 24 out of the whole 34 cases. You can see in this picture, this is the SFA which has been severed, and this is the SFB. In this case, we had done an intervention graft repair for the artery and a lateral venous repair for the vein. 8% of the limb injuries had come to us with effective tourniquet. Most of them were evacuated by the peripheral medical officers. The mean time of presentation was ranged from 1.5 to 19 hours. Obviously, there is a drastic difference depending upon the location of the patient, the climate, evacuation facility available, and time to evacuate the patient from the firing area. The timing of surgery ranged from 2 to 7.5 hours. This is the whole time of surgery, just not the vascular part. We had a limb salvage rate of almost 91.67% with an amputation rate of 8.3%. Only one patient who came to us within the 12 hours, we had an amputation. Rest of all, we had successful outcomes. All the bypasses were done using the saphenous vein. Fasciotomies were done in 18 patients. We had 18 cases of foot drop, out of which 15 had recovered within 6 months. In treatment modalities, we did primary repair of the veins in 9 cases. Most of them were lateral venorrhaphies or anterior wall suturing of the vein. These were basically mainly the SFB and the CFB. And in the 3 cases, we had jugular vein primary repair. 11 cases, out of which maximum were popliteal vein injuries, we did a interpolation vein graft, and we made it a point that we repair all the venous injuries in sync with the arterial injuries, not just ligation. But in the distal forearm veins and below knee veins, we had to do ligation in overall 14 cases. The complications, we lost 3 patients due to AKI with MODS and 1 to the perfusion injury. We had 3 amputations as already discussed. We had 15 cases of foot drop and 3 cases of wrist drop. The main problems faced were basically evacuation. Unless the patient was on roadhead, we had heli evacuation to rule out, but majority of the patients could not be evacuated in time because of heavy shelling or weather or snowfall. so air evac became a problem. That's why the mean variable time of evacuation was there. In pre-hospital trauma care cannot be given in a wholehearted manner at the site of encounter which is going on. Hypovolemic shock, restraint to revascularize, always a bane for the vascular surgeon to do or not to do, especially when the patient has multiple injuries, he is in important shock, and obviously heparinization is a big problem. Now we always, as everywhere time is done, we prefer life over limb and the role of damage control surgery, especially when multiple organ systems are involved. Role of primary amputation cannot be overlooked as a life-saving measure. Now, majority of our patients had penetrating injuries, so everyone came in variable degrees of shock. So we did not give any heparin in the trauma center or preoperatively because most of the patients were in resuscitation. In few cases, depending on case-to-case basis, we did give heparin, especially in popliteal artery injury repairs, but we gave only 1/3 of heparin dose just at the time of anastomosis. After we had taken arterial control and harvested the vein route, we gave heparin. We ensured it that we always do the vein repair also in time. Obviously, there is a bleeding risk is there, but again, in heparinization also you are to give or not to give. But as a vascular surgeon, you always tend, especially in limb injuries, we went towards giving heparin though in low doses, and we preferred infusion of unfractionated heparin over low molecular weight heparin. To conclude, mortality and morbidity due to triad trauma has decreased significantly. We have moved towards endovascular approach, especially in arterial cases, but not in venous ones. Autologous graft is always preferred. We encourage the medical officers in periphery to put a tourniquet before transferring the patient to us, but we never applied a tourniquet during our surgery part. And repair of vein was given equal importance as that of artery, especially in the lower limbs. Thank you.
Thank you, Manvendu. I understand that both Arvind and he are online, but we'll take questions in the end. Dr. Shekhar, we'd like to hear from you about iliac vein stenting. We know that you have been part of this journey in the past, present, and look forward to knowing what's in the future from you. Over to Shekhar.
Good morning, friends. Over the next couple of minutes, I'll be sharing my slides on the evolution of venous stenting. To start with, let us see what the steps for evolution were. It started with, and I think that is still evolving in our country, accepting the role of outflow obstruction as a pathophysiology for the symptoms that happen in the leg, especially non-healing venous wounds. The other evolution is accepting that it needs to be addressed with stents. And then there is an evolution of stents, which I'll speak about, and of course the role very briefly of IVUS. Dr. Robbie has already touched on that, so I won't dwell too much into the role of IVUS. Of course, I'll be talking about a little bit, one slide or so on what the future holds. Well, why there is so much talk about a narrowed venous a narrowed iliac vein segment? It all starts, if I can take you back to your early days where we used to study physics, when you look at the Poiseuille's law, you can clearly understand that the resistance to flow is inversely proportional to the radius to the fourth power. So in essence, therefore, a twofold increase in radius decreases the resistance by 16-fold, and as we all know, the basic essence of putting in stents is to reduce the venous hypertension. So this is the physics involved in putting in stents into the vein. And once we started, understanding the value of this, that is when the whole process of venous stenting picked up throughout the world. The first reports of a successful deep venous stenting originated from Germany, Sweden, and the US in the early 1990s, but the mainstream attention increased rapidly in the early 2000s after the publication by the Stanford group of O'Sullivan and Dake. and of course the best known series by Neglen and Raju. To start with it, the first understanding was that arterial stents are different from venous stents. In the treatment of arterial stenosis, the goal is to restore peripheral perfusion without any dissection or extravasation. To avoid these complications, arterial revascularization is performed without actually being a strict perfectionist, in the sense that the goal is basically to just restore your distal circulation, and so a little bit of under correction still achieves an acceptable clinical result. On the other hand, as far as venous stenting goes, the whole goal is to eliminate peripheral venous hypertension. And even a minor residual venous stenosis can actually contribute to elevated peripheral venous pressures and residual symptoms. So this is where the whole evolution of venous stenting and the understanding played a role. And therefore, as I said, the critical stenosis threshold in the venous system is regarded by some as being much smaller than what is acceptable in the arterial system. The stressors in the venous system is also different, so the understanding of this itself, once we started understanding this, we evolved as in our role as clinicians putting in stents into the veins. The stressors in the vena cava, cavo-iliofemoral system is different. As you can see, the vein is exposed to repeated arterial pulsations. And with the changing position of our body, in ambulation, the geometry and the movement of the pelvis, the shape of the vein also changes. Additionally, there are other mechanical stressors which I won't dwell into deeply, but you can see on the slide. So what is the ideal venous stent? With these requirements of venous application in mind, the ideal venous stent should ideally have a balance of radial force as well as flexibility. The flexibility is because it should conform to the shape of the vein, as and when the vein, as I said, with the movement of the body and the movements in the pelvis, it takes up a different shape, so it should conform to that. And so ideally, the vein dictates the shape of the stent, that the vein should dictate the shape of the stent rather than vice versa. The current stents for the arterial system are frequently quite rigid, and because of that rigidity, they are non-conforming to the shape of the vein. And so basically what it does is it straightens out the vein without allowing the vein to be in its original shape, dynamic shape that it is in. The ideal venous stent is also larger, and so as you can see that it should span most of the cases it should span the entire common and external iliac system. It should be precise without foreshortening. Unfortunately, that is a trade-off for increased radial force and flexibility. And most of our patients are much younger, so you need a venous stent that is durable and lasts for a considerable time. It is said that a venous stent, ideal venous stent, should last at least 50 years, if not more. So the first stent was the Boston Scientific wall stent, and as you can see, the results are pretty good, especially in the NIVLs, slightly inferior in the post-thrombotic disease, but they're pretty good. And especially in the healing of venous ulcers, which is probably one of the most common indications that we use them for. But it's not without, this is the picture of the venous stent, wall stent, but it's not without any shortcoming. There are two shortcomings of the Boston venous stent. One is that if you study the body of the stent, if you study the anatomy of the stent, you realize that the body of the stent is strongest in the center, and the two ends are soft. And much more compressible. So if you want to do a precise, say in a May-Thurner syndrome, you want to precisely deploy it, you may land up, deploying the soft, compressible end of the wall stent at the exact site of compression, and that may lead to this kind of coning that you see in this picture. So to avoid that, what was recommended was that the wall stent should jut, and most of us, when we started several years back doing venous stenting, what was taught was that the venous stent should jut well into the IVC. Now, that was what the idea was, because we were using wall stents. And the downside of it was that one did not foresee that this adapted technique led to the contralateral iliofemoral DVT, and more cases as days started being reported where we saw a successful venous stenting in one leg, and a couple of months or years later, patient presenting with the jailing, due to the jailing of the opposite common iliac, presenting with DVT on the opposite side. So to overcome this, what was then suggested was the Z stent, and this was applied, and you can see the Z stent being rigid was applied in a kind of a telescopic manner over the Boston wall stent, and the results are pretty good. In fact, there are good studies suggesting that the incidence of contralateral DVT were acceptable with this technique. We have a present generation of newer stents now. There are about 7 of them available in Europe. In India, we have only the red marked ones. They have been studied well, and at least 3 of them are available, and we use them, including the obliquus, which you can see here. They have all undergone good trials and successfully been studied. A little bit about IVUS. Of course, the IVUS is one more evolution tool in evolution which actually helped. But as Dr. Robbie suggested, initially we were all doing this kind of a balloon wasting test, quite a messy thing and not accurate. But then with the evolution and more access to IVUS in our country, and now quite a few centers I find are doing IVUS in venous stenting. You can see the positives and negatives of these. I won't go much into that, except that you can see a post-stenting, the IVUS actually gives you a good, wide, patent venous stent. The future, of course, and this is my last slide, is bioabsorbable scaffolds. We know they have been used quite extensively in cardiology and then been withdrawn due to various reasons. The advantage of having a bioabsorbable scaffold is it provides a vessel support and potential anti-proliferative drug delivery can be added to this biodegradable scaffold. Theoretically, it's a good option. There can be less concern of jailing of the venous tributaries, including the contralateral iliac vein, and there could be a decreased risk of late stent fracture and late stent thrombosis, which was an issue with the biodegradable stents when they were used for the cardiac in the cardiac scenario. Also, the scaffold could be less magnetic resonance and computed tomography imaging artifacts with the biodegradable stents. Due to the larger venous diameter, probably the issue of late stent thrombosis would be less. But this is all work in progress, and probably the future of venous stenting would be when we actually get this kind of technology for use in our clinical practice. Thank you.
Thank you, everyone. And I think we have come to the end of a very interesting session. And I think the take-home message is that anyone who is doing deep venous interventions, IVUS is a most important tool in your armamentarium. And as Robbie showed, a very interesting case, and it's very interesting to realize that these dynamic compression in various areas could be caused by various things. Like in that case, probably the caudate lobe of liver causes the compression of the IVC, which is a dynamic compression. And this can easily be missed on a CT venogram, because normally when we carry out a CT venogram, we tell the patient to hold their breath. The moment the intrathoracic pressure increases, the IVC expands, and you miss these lesions. So if you don't have IVUS, then you will be totally missing these lesions. For all chronic non-healing venous ulcers, the patients who had undergone various interventions, CT venogram was the ideal investigation, I would say, a decade earlier. But now, if we have a patient who has a non-healing venous ulcer despite various interventions, I think rather than subjecting them to a CT venogram, we should straight away order for a diagnostic IVUS study, and in case we should counsel them that in case we see a lesion, then probably we're going to stent it as well. And
yeah, thanks, Tarun. I think we have about 5 minutes probably just for some questions or comments. Just trying to keep in time with the session.
One question to Dr. Shekhar. Hi, Adarsh. Our experience in Vellore is the post-thrombotic legs, we are not having a very good results on the long term with venous stenting. For some reason, the Indian setup with the population, the follow-up is not very great. So we've kind of now very selective about venous stenting in post
necessarily we don't go in and put in the stent. Whereas in the vein turners, we are very happy to do the stents because the longevity of the stents is much, much better. And I'm not sure if others have the same experience.
Shekhar, Robbie, anybody wants to take that on? That in post-thrombotic limbs, the experience with stenting is not great.
I think that I think that goes with the literature. If you see the literature, the best results are with the NIVLs, the Methana type. Unfortunately, the load of post-thrombotic legs in India is huge, and the bulk of the patients who we do stenting for are who have had venous ulcers for years, and they are just searching for solutions, and this is one solution. Even if you get a 60% or 65% chance that the venous ulcer heals, I think the patient accepts it. But yes, it goes with the data worldwide also that venous stents are better for non-thrombotic rather than thrombotic.
Thanks, Shekhar.
So I would actually agree with Deepak. I mean, we were very aggressive treaters of post-thrombotic syndrome with stents, and we reported our data for venous ulcer healing. And venous ulcer healing is about 60%, but it does not say sustained. Stent patency in PTS is, our own experience, it is not 88%. That range of 66 to 88 is, I think, I'm not very sure where that data comes from, because that 88 is not what we see in practice. And I would agree with Deepak that in post-thrombotic syndrome, I have become much more conservative in deploying a stent. I will aggressively venoplasty, but I'm more conservative on putting in a stent. It doesn't stay open very often.
We have others. Do you want to ask us something, or do you want to comment briefly?
Arvind, and my question was that was with regards to the timing of stenting in the upper limb post lysis and post resection. And then how do you keep them open for a long period of time? Because the outflow in the upper limb veins is not as much with regards to the cardiac output as it is for the lower limbs. So how do you go about with maintaining patency in these stents?
I think the question is for Arvind while he comes on.
Yes,
yeah.
Okay.
Like I said, can you hear me?
Yeah, can.
Yeah, sorry. Like I said, I'm not a big proponent of placing stents for upper extremity DVT, the Paget Schroeder. The data seems to suggest that just with lysis and first rib resection, regardless of how the vein looks after the procedure on venography, we get good results. We get symptom resolution. So the placement of stents is actually not essential. What we do, we use the angiojet for lysis, then within 2 weeks we bring them back and take the first rib out. At the same time, after we've done the first rib, we do a venogram during that same anesthetic, and then we balloon that vein up to about 12 millimeters, and that usually gives us some good flow through the vein. It doesn't look pristine, it doesn't look perfect, but we don't generally place a stent. The only time we would consider placement of stent is even after all that. If it looks like there is no flow, then we may consider placement of a stent. If we do place a stent, then we'd be obviously placing them on dual antiplatelet therapy and anticoagulation. So dual antiplatelets for 6 weeks, and then anticoagulation and aspirin alone for the full period of 6 months after that. We usually also at that time would put a double tubing grip on the arm and put a calf compressor. You can put a sort of a small calf compressor on the arm, and then we connect it to a sequential compression type of thing for the first 24 hours to just kind of keep that flow. As you mentioned, the flow is sluggish and it's not ideal for keeping a stent open. But like I said, we don't routinely place stents. In fact, in the last handful of cases that I've been involved in, we have not placed a stent.
Thanks, Arvind. We are short of time, so just one last question from Ilya Kumar.
Dr. Manvanduja, impressive series here for venous repair. Just a comment. The role of heparinization in these trauma cases, which I like to add, is it improves the patency of your repair and also prevents progression of the thrombosis, and so it keeps the collaterals open. So have a more likely chance of limb survival one. Second is, how long do you anticoagulate these patients? Since the venous repair, we know, goes down, but as long as it functions, it keeps the arterial, it improves the patency of the arterial repair. Thank you. And can one more small question? No, thank you.
Adarsh, I think the question is for you. I'm not sure. Did you hear us?
I think the question was for Manvendu Jha, but I can answer that question.
Yeah, that's a trauma.
So I fully agree with Ilay Kumar.
Yeah, that's for trauma. Yeah, Manvendu Jha. Is Manvendu online? Okay. The other thing is, I think we are getting questions on chat on the group. So kindly, speakers, could you please look and respond on that? Dr. Shoaib, I'm really sorry. We need to run on time. So we'll keep chatting on the group. Thank you very much, everybody, and we'll go on to the next session.
Chairperson, thank you so much to the panelists, and thank you to all of you for sitting through and enjoying the session. Let's give a big hand to our speakers, our chairperson and our panelists, please. Thank you. On that note, I have an important announcement to make. At sharp 11 o'clock, we have an oration from Sunil Agarwal, led by Dr. Devendra B. Dekivadia, and this session is open to all, and we want all of you to join us sharp at 11 a.m. And we have our next session starting shortly. I stand corrected. It is the Sunil Agarwal oration, which will be rendered by Dr. Devendra B. Dekivadia. And now we will begin the session 3. I'd like to invite our chairperson, Dr. Edwin Stephen, to please join us along with N. Sridharan. May we have you join us on the stage, please. I'd also like to invite our panelists, Dr. Radhakrishnan Raju, Dr. Shankar R, to please join us. I'd like to invite Dr. Prabhakaran and Dr. Naveen as well to join us on the stage. Session 3 is titled, How I Do It. I'd like to request the chairperson to take the lead. I'd like to request all our speakers to stick to the speaker time duration, which is 8 minutes only. Over to you, sir.
Hi. Morning, please. Hi. Somebody asked me whether this is a permanent fixture. Sorry, guys, get used to me sitting here, I think. Thank you. Yeah. We have stalwarts in this session, carrying on from where we left off. So thank you for the previous speakers for setting it off so well. Dr. George Joseph is no stranger to anybody in this room, nationally and internationally, and we start off the session with him telling us how he does a hepatic vein recanalization.
Good day to all of you. I thank the organizers for this opportunity to present some of our work on Budd-Chiari syndrome, especially hepatic vein recanalization. We have treated 70 patients with Budd-Chiari syndrome. They're mostly young, and duration of symptoms has varied from 1 month to as many years. The etiology is idiopathic in 69%, which I call the group 1. And other conditions like prothrombotic states and veno-occlusive disease account for the remaining 31%, which I call group 2. The site of obstruction in Budd-Chiari syndrome could be in the hepatic IVC alone in 37%, the hepatic veins alone in 21%, and both the hepatic IVC and hepatic veins in 42%. And the lesions may be stenotic or occlusive. And the length of the lesions may be discrete webs which are 2 millimeter thick or 3 centimeter long occlusions. So we have both IVC and hepatic vein problems in Budd-Chiari syndrome. Here's an example of an IVC web just above the hepatic veins, which are patent but flowing into the IVC and then downwards. So this was recanalized and just balloon angioplasty done to get a good result. But often we need to stent, and this is an example of an IVC where with a total occlusion, which was balloon dilated and stented in 1998, and this result was still good 21 years later, and this is the follow-up angiogram. Now, this is the problem we more often encounter, where both the IVC and the hepatic veins are occluded, and unless we open the hepatic veins, the patient is not going to improve clinically. So here's an example where both the IVC and the right hepatic vein were recanalized and stented. So how do we recanalize these hepatic veins which are occluded terminal, their end in the IVC? One technique is the jugular approach. So we have a right internal jugular vein access, and then we use a needle, which could be a Puckenbrough needle or a Colapinto needle, and we go through the IVC into the hepatic vein, which is patent within the liver. So we're crossing the occluded segment, and then we pass a wire down into the hepatic vein. Here's an example where the right hepatic vein was recanalized and stented to get this result on the right side. Another technique is the percutaneous transhepatic approach. Now, we developed this because the previous technique had the problem of cardiac tamponade. So when you come from transjugular approach, you may go through the pericardium and then enter the hepatic vein, and that may cause tamponade. So this is a relatively safer approach where we come percutaneously transhepatic using ultrasound guidance or carbon dioxide angiographic guidance, enter the hepatic vein, and then go on to recanalize the occluded segment and enter the IVC with a recanalizing wire, which is then exteriorized from the internal jugular vein. And then we complete the procedure from the right internal jugular vein and often put coils in the tract that we made through the percutaneous entry into the liver. And here's an example of balloon dilatation and stenting after percutaneous transhepatic recanalization of the hepatic vein. And the third approach is the collateral approach. Here's an example of a patient who had IVC obstruction, occlusion, and hepatic vein occlusion. And the yellow arrows show the patent hepatic veins within the liver. And the purple arrows show a large collateral from the IVC below the obstruction going into the hepatic vein, which is patent within the liver. So this is draining the hepatic venous system. So it's possible to go through this and then recanalize backwards, or actually it's an antegrade recanalization because that's the way the hepatic vein flows. And then you can bring the wire back into the IVC, exteriorize it, and complete the procedure with angioplasty and stenting. Now this can produce tremendous results, these techniques. Here's a child who came in a real miserable condition with severe ascites and really malnourished. And this was the problem. The hepatic veins were all occluded and the IVC had a web. So we recanalized the right hepatic vein, stented it, and also stented the IVC. And a year later, the child looks completely recovered. All the ascites is gone and she's asymptomatic. So very gratifying results when you do this procedure. What happens if the entire hepatic venous system is occluded or obliterated? So then you have to do a TIPS procedure. But the difference in this situation is we have to do it directly from the IVC into the portal venous system because the hepatic veins are not patent. So here's an example, needle passing from the IVC directly into the portal vein, and then we dilate that tract, and this intraparenchymal tract is then stented, usually with a covered stent, and this is the result that we get. So there are complications. 10% was the overall significant complication rate, mainly significant liver bleeds, but most of these can be treated conservatively. And we had 2 cardiac tamponades, which were related to the transjugular hepatic vein recanalization. And then we have thrombosis of the tips or the portal vein in prothrombotic states. The outcome was good in the idiopathic group. There was a 94% immediate success, but 27% needed repeat procedures. And at follow-up, at about 2.5 years average, 83% of the patients were asymptomatic and there were no deaths. But in the group 2, which is prothrombotic states or veno-occlusive disease, initial success was less, 86%, repeat procedures required in half of them, 52%. And then at follow-up at 19 months, only 56%, or about half, were asymptomatic. 8 had died in the follow-up period, and 6 of whom had hepatic cirrhosis. So, in conclusion, endovascular treatment is highly effective for Budd-Chiari syndrome, especially the idiopathic group. They do better. It is a less morbid alternative to open surgery, and it's important to recanalize occluded hepatic veins. If you leave them occluded and just deal with the IVC, that's not going to solve the problem. And with these current technical advances that we have, it's possible to treat most of these patients with Budd-Chiari syndrome. Very important to follow them up periodically and do repeat procedures if required, and that will improve their long-term outcomes. Thank you for your attention.
We have the discussions at the end of the session. Now I request Dr. Sandeep Agarwal, consultant vascular surgeon from Nagaram Hospital, to talk on endovascular recanalization of iliac vein and IVC in chronic venous occlusions.
This one?
Good morning, everybody. Thanks to the organizer, and everybody felt very happy meeting after such a long time after the COVID era. Today, I am going to present the iliac and the IVC venoplasty. Dr. Robbie and Dr. Shekhar has, I think, made my job quite easy by explaining the use of the IVUS and showing different types of the stents. So this 37-year male, but this is quite far. There is no laptop here. Okay, 37-year male, venous ulcer over the left middle malleus since 4 months, and associated with severe pain. There is a past history of the bilateral DVT. The infrarenal IVC and the bilateral iliac vein stenting was done, and the approach was bilateral SFE percutaneous and the right IJV. So bilateral SFE were punctured, jugular approach was taken, and using the Tromo wire 035, bilateral iliac veins were crossed, and then the IVC in the serial dilatation with the different sizes of the balloon using the 4, 5, 8, 10, then 12, made the suitable lumen, and then this was the balloon venoplasty. Oh, that is wrong. There is a significant waste you can appreciate, and then these were the different types of the stent using the Y-plasty. Venovo, which has been discontinued now from the market. So this is the whole iliac vein up to the SFE were stented using the, and then remolding of the stent. Now, this is the final outcome of the right side. The same thing was repeated on the left side. And this is the final outcome. You can see both the SFV, iliacs and IVC. So this was the case where both the iliacs and the IVC juxtarenal was occluded. Now the second case, 32 years male, recurrent venous ulcer over the right medial malleus associated with pain and hyperpigmentation, past history of DVT with pulmonary embolism and IVC filter in situ since 9 years. That was non-treatable filter. So what we did, the inverted Y configuration stent venoplasty of the IVC with bilateral iliac vein, approach was bilateral SFV and right IJV. And because the IVC filter was there for last 9 years, it was clogged. So what we had to do, we had to crush the IVC filter, lateralize it, and then we had to put the stent. So this was a quite difficult case because IVC filter was already there, which was non-retrievable. We had to snare the wire from the IJV approach. This was the IVC filter, Gunther tulip. This was wire passed through the filter and little bit lumen made in the IVC. So this was snared. And then the IVC filter was crushed, lateralized, and then 2 stents on both the sides were put. Whole track was balloon with the different sizes. The same thing was done on the left side. I request the organizers to give me some extra time because the third case is a very interesting case.
How much more time do you need?
3 minutes.
Is it possible to play the, let him, yeah, okay. I think it should come up.
So the both sides were stented and there was a good flow. Please skip this and directly come on the third case. This was the third case. 30 years male, past history of the DVT in right lower limb from 2013, swelling of the right lower limb and non-healing ulcer since 3 years. The stent venoplasty of the right common iliac vein and the IVC, approach what right SFV, right IJV and less CFV, and this was done under local anesthesia. This case we did only day before yesterday. And here, if you can appreciate, the whole IVC was clogged up to the in the suprahepatic segment also, till it was entering the right atrium. So we had to make the lumen throughout the IVC, ballooned it, and then whole IVC we stented right from the suprahepatic vein up to the bifurcation and in the iliac vein. This was the Illuminex 16, 12, and this was the so whole track had to be stented, and this was the final outcome. Thank you very much. Thank you for giving me the extra time.
Thank you, Dr. Sandeep. Challenging cases. We'll take questions in the end. We'll now head to Dr. Danesh. I think he's also on line as a presentation on yet
another. At the outset, I would like to thank organizers of Viacon 2022. I'm going to speak on venous ulcers, many ways to skin a cat. I thought I would just talk about my approach and my philosophy of treating such patients. It's an age-old advice by many clinicians, GPs, general surgeons, orthopedic surgeons that once you have a venous ulcer, you have to live with it. We, for a vascular specialist, that's not really true. Many times we get these patients referred with these kind of bandages. End of the day, the therapist's skill is really key and important how to put the bandages on. Sometimes you see such kind of bandages as well. My approach, clinical evaluation is most important. There's a need to take a good history and examination. Symptoms suggestive of venous pathology like old DVT or fractures of the limbs or bedridden state or any hormonal treatment in the past or pregnancy. Also need to find out whether it's a first ulceration, first time, or a recurrent ulceration. Occupation also is important to find out. Peripheral pulses examination is the key because sometimes you have arterial insufficiency, you need to decide about pressures for stockings. Of course, presence of varicosities, LDS, pigmentation, eczema, and inverted champagne bottle appearance, these are the key, whether it's a deep vein involvement. I also look for ankle disability because of long-standing ulcers causing inversion. I also find out about previous treatment, like what kind of bandages or stockings they have used and what topical drugs they have used. Duplex examination is important. Sometimes a swab if the ulcer is infected and X-ray if there's a long-standing ulcer. In duplex, I get it done from my sonologist in supine standing, rule out superficial reflux at multiple levels like SF and SP junctions or perforators in multiple positions in the leg. Course of truncal veins like the straight or tortuous. Find out also old DVT changes as well as imaging iliac veins. So when do I consider more test? If it's a C5, C6 stage of legs, if there are recurrent ulcerations, if the adequate and correct therapy to relieve venous hypertension like compression, dressings, and superficial reflux ablation, and in spite of this, the ulcers are not healing. If it's a post-thrombotic legs or old DVT, if the severity of symptoms, heaviness or pain are not relatable to findings like few varicosities, like sometimes in young women, you might see few varicosities, but the pain and heaviness is a lot worse. It's a ratio of a May-Thurner syndrome. And end of the day, like every clinician would when I have a gut feeling or intuition. Which test I would ask? Definitely CT and or MR venography, sometimes both. I was imaging in many of these patients if you are heading towards iliac vein stenting at a time of stenting or before doing stenting. Ulcerous biopsy, sometimes it rule out vasculititis or even malignancies. And MRI of painful part of the legs, because I have picked up local sarcomas a couple of times. So if somebody has a painful leg with varicosities and ulcerations which are not corroborative, then definitely rule out some MRI of local pathology. There are different ways to skin a cat, mostly in combinations like absorbent dressings with Cutimate or Aquacel Ag non-adherent. Sometimes I use back therapy as well. I would use the macronized flavonoids, which are venotonic drugs, which helps venous emptying, pentoxifylline, sometimes in LDS, occasional antibiotics for local infection, and NOACs and aspirin if there is iliac vein stenting. Compression therapy, prefer Ulcerex stockings over bandages. I find compliance is better. And superficial reflux like laser ablation or perforator, either using foam or laser or surgery. Then iliac veins, I was with stenting and then followed by the healing integrate or SHG. This is a combination with bandage techniques and pressure, but I use Ulcerex, which is basically one on top for 2-layer stockings. And I think it gives a better compression as compared to 4-layer bandage. The compliance is much better. And then you have superficial venous ablations like lasers, perforators with foam sclerotherapies, in May-Thurner, iliac vein stenting. It's a very classical where you have a recanalization of channels through post-thrombotic veins, and which is why you develop LDS and pigmentation post-thrombotic symptoms. IVAS is useful in iliac vein stenting. Now I had an iliac vein stenting in September. Nearly took 6 months from that size of the venous ulcer to come to this size in March this year. So took almost 6 months. Close follow-up is the key. Keep an eye on ulcer size reduction. Tell patients to take weekly photos of the wound so we know how the progress is, or if there's a deterioration. If poor healing, I suspect recurrence of superficial reflux somewhere else, or imaging for deep veins, and if they find, treat the cause. Once ulcer heals, regular compression stockings are important to prevent any recurrence, and change of pattern of job, which may be possible in some of the patients. This was a study done by one of our DNB students, managing venous ulcers due to superficial reflux with early intervention and compression stockings versus compression stockings alone. This is a single center observational prospective study with 84 patients, and all venous ulcers due to superficial reflux with patent DVT, patent deep system were included. Exclusions were patients with secondary varicosities, mixed pathology of ulcer or pregnant females. Primary objective was time of complete ulcer healing, and secondary objective was recurrence of ulcer, rate of ulcer healing, or ulcer-free period and quality of life score. And interestingly, early intervention showed average 1.29 months of ulcer healing, whereas in conventional therapy compression, 2.21 months to heal the ulcers. But follow-up in 2 weeks, right up to 6 months, definitely the quality of life was much better in people who had an early intervention over conventional therapy. So my learnings, compliance for compression therapy is important, and if it is poor, it definitely causes poor or slow healing. Difficult for many people to adhere to effective compressions like farmers in hot weather. Sometimes they also get pain, so they are not compliant. Elderly people find it difficult, especially with arthritis, and many of these couples have no home well, it makes it really difficult. So they prefer ulcer to pain, and which is where I think wraps could do a trick which are easier to put them on. Healing or reduction in size of ulcer develops confidence in you for further interventions like EVLG or IVAS or stent. Post-healing, regular follow-up is the key, continuing with compression therapy with stockings once the ulcers are healed. Ulcer healing is faster only if superficial reflux and ablated, but if it's a deep system intervention like deep iliac vein stenting, seems to be slower but definitive after deep vein injection. So very important to know that ulcer healing is faster if only is a superficial reflux and which is ablated. But if it's a deep vein reconstruction, it does take a longer time, but it's definitely progressive and definitely heals. I guess we still only know half why they recur in spite of best adequate, acute and long-term therapy. Thank you for attention.
Thank you, Dr. Danesh. We have Dr. George Joseph and Danesh online, and Dr. Sandeep is here. So the floor is open for the next 5 to 7 minutes for discussions and questions. Ilya Kumar.
Thank you, sir.
So my first question is for Dr. Sanjeev Agarwal.
Perhaps the mask off will make it clearer.
Yeah, can you hear me now? Yes. Sir, very interesting cases, excellent techniques that we have followed. But my small doubt is, for what subset of patients, particularly with PTS, like what stage of Villalta score, whether they're moderate score or severe score patients, you would take up for stenting? Because we know, as you know, the patency rate for deep in, DVT induced, that is post-thrombotic iliac stenosis or occlusion, has a poor patency rate. So I saw in the second case, the patient had only edema. So class-wise, it is C3. Another question for Dr. Karnakar, sir. Sir, in your study done by your postgraduates, excellent study, that's what the Evra trial.
Ilya Kumar, wait, I think we'll go one question at a time, please. Thank you.
Dr. Ilya, the purpose of doing the venoplasty or the stenting is not to keep the stent patent for long. The purpose to heal the ulcer then and that time, because after putting the stent or after doing the venoplasty, the ulcer healing also takes at least 3 to 6 months. And you never know the stent you have put or the venoplasty without the stenting you have done, for how much time it is going to happen. Many patients, they come, the stent is blocked within 6 months, and we have the patient where we have put the stent, the iliac stent, the 5 years or the 7 years back, and still it is repeated.
Thank you, Dr. Sandeep. Dr. George, question for you, sir. Edwin here. For these patients who you are stenting, what is your anticoagulation protocol?
Yeah, so during the procedure, we give a bolus of heparin, and if we do check the ACT, we keep it above 300. After the procedure, in some of these cases, we have put the patient on long-term oral anticoagulant therapy, because there is a theory that these beds and obstructions that do develop in Budd-Chiari syndrome, it starts off with a thrombosis, which then organizes and then finally becomes a web. So, although there is no great evidence showing that giving anticoagulants prevents web formation, we do keep them on lifelong oral anticoagulation. And then because we put in a stent, we'll give one antiplatelet drug as well. Usually it's just Ecosprin. But in the first 1 month, we may give 2 antiplatelet drugs. But 2 antiplatelet drugs plus anticoagulant may be too much. So we may give clopidogrel plus anticoagulant for a month, and then aspirin and anticoagulant.
Thank you, sir. So, Dr. Shankar and then Ilya Kumar for your second question.
So, excellent cases, sir. Thank you. My question is that retrograde cannulation of that collateral vein you showed one case. How to seal that entry point after the procedure?
No, there is no entry point to seal. So collaterals are open at both ends. One end is the IVC, the other end is the hepatic vein. So it's basically decompressing the hepatic venous system into the IVC. And so if you are able to find a collateral through which you can get a catheter into the hepatic vein, then you point it towards the IVC back again, that is higher up towards the right atrium, and then using a recanalization wire. So there are a variety of sharp recanalization wires. You pass through the occluded terminal hepatic vein and enter the hepatic IVC. And then you pass it up into the right atrium, snare it out, and complete the procedure from the right internal jugular vein. So when you finish, this collateral is just left as it is. You don't need to close it or anything. And the only place where you need to close something is when you come percutaneous transhepatic. So there you're going through the ball of the chest cage, through the liver, and then you're hitting hepatic vein inside the liver, which is patent. So that track has to be sealed off, and there we put a coil when we're taking the catheter out. But for collateral approach, nothing needs to be done. That's the beauty of it. It's it's not very invasive.
Thank you, sir.
I have
Thank
a
you, sir.
detailed query for Dr. George Joseph. Sir, good morning. This is Dr. Sandeep Agrawal. There is a tendency in the GI patient to bleed either from the upper GI or the lower GI. Even after putting the stent, if the patient have the bleeding, upper GI or lower GI, then what is your take of the anticoagulation and antiplatelet?
I'm sorry, I couldn't hear that well. Could somebody from the panel just repeat it briefly for me, please?
I think what Dr. Sandeep is asking is about the patients having GI bleeds also, sir, in these patients when we are doing the interventions, and your experience with that. Will that be a...
Yeah, so many of these patients have portal hypertension and varices, and they present with GI bleeding. And once you open out the hepatic venous system, the portal pressure also falls dramatically, and the GI bleeding stops. So it's in fact therapeutic to relieve the hepatic venous outflow obstruction in these patients with Budd-Chiari syndrome.
No, sir,
in terms of relieving portal hypertension.
If after putting this stent, even the patient has some bleeding, what do you do about the anticoagulation and antiplatelet?
Right. So then you don't give anticoagulation. You may just give aspirin alone. So if there is overt bleeding going on and you have deployed a hepatic venous stent, it's not essential that you need to anticoagulate. It's only during the procedure that you may anticoagulate. But after the procedure is over, you can stop the anticoagulation and just give aspirin alone. And if the bleeding is significant, don't give anything at all. We haven't seen acute stent thrombosis just because we stopped anticoagulation. And even the role of anticoagulation in Budd-Chiari, idiopathic Budd-Chiari syndrome is not a well-defined, proven one. It is basically empirical. So there are reports saying that there is no benefit. So if you don't give anticoagulation, I don't think you're going to pay a price.
Okay, thank you, sir.
Thank you, sir. Ilya Kumar, last question. Thanks.
Sir, my question is to Dr. Danish Kamekar, sir. Sir, very interesting study that you have done by your student. As we see in those graphs, the group with compression and intervention over a period of 6 months' time, they are almost coming together. But as we know, after 1 year, there is attenuations of these results. So both intervention group and with compression group alone. That's what the ESCA study was, the sub-analysis came about. So it will be interesting if your student can follow it up for another 1 year, the same patients whom early intervention has been done. So that will be an interesting study. Thank you, sir.
Thank you for that comment, Ilya Kumar. I think we'll bring the session to a close. And Danesh, probably you have a comment to make, Danesh, or about carrying on the study for another year on one of the arms. I think we have a link issue, so probably you could put that up in the WhatsApp group. So again, questions, speakers, please look out for queries in the WhatsApp group and answer to that. So back to you, Madam MC. And thank you, everybody. Thank you, speakers, for that wonderful session. Thank you, sir. Thank you, Danesh. Bye for now.
Sorry, Ilya Kumar, I missed that question.
Thank you.
Yeah.
Danesh, you just unmuted, I believe. Do you want to answer? Danesh? I think we'll call it quits for now and request Ilya to please have a chat with Danesh later on as well. Thank you. Thank you, everybody.
Thank you.
Thank you so much to all our speakers, our chairperson and our panelists. We will now move ahead to our next session, but it starts at sharp 11 o'clock. We do know you've been sitting here since 8 o'clock, so we'd like to give you a breathing space. Please use the washrooms which are towards the exit and join us back at 11 o'clock for the Sunil Agarwal oration that is rendered by Dr. Devendra B. Dekibadia. And this session will be compared by Ms. Sheila. And I'd like to request all of you to join us back on time so that we can abide by the time and continue the sessions accordingly. Thank you.
Good morning. Faculty, delegates, and the industry, kindly come to the ballroom for the very first Dr. Sunil Agarwal oration. Hi, everyone. They say a picture is worth 1,000 words. But what about a memory? A memory is priceless. And today, the highlight of today's conference is the much-awaited Dr. Sunil Agarwal oration, the very first Dr. Sunil Agarwal oration. So, may I now call upon the stage the dignitaries. As I call upon your name, may I request you to please come on stage. Dr. Harinder Singh Bedi, the President of VAI. Dr. Indra Agarwal, wife of the late Dr. Sunil Agarwal, Professor and Head of Division of Child Health at CMC Vellore. Dr. Saravanan Sundarraj, founder member of VAI and Director of the Vascular and Transplant Unit at Madras Medical College. Dr. Sanjay Desai, Secretary VAI. Dr. Gulshanjit Singh, Treasurer VAI. Dr. Roy Verghese, Chairman of the Governing Council of VAI. Dr. Deepak Selvaraj, Vice President of VAI. I now request Dr. Prabhu Prem Kumar to welcome the gathering for this very first Dr. Sunil Agarwal oration during YCon 2022.
Can I request those who are on the back to please fill up the seats? Thank you. How do you honor someone who's held your hand, who's taught you to take the sutures right? How do you honor someone on whose shoulders you built your career, your life? Sunil stood for everything that is good here, as a fond memory, as a friend, as a mentor, as someone who will call a spade a spade. It is indeed my privilege to welcome you all for this, the very first Sunil Agarwal oration. I hope each of you will relive the memories of Sunil, for he always is in our hearts.
For this oration, the citation reading will be done by Dr. Saravanan Sundarraj. Over to you, sir.
Good morning, everyone. Sunil was a very good friend of mine. 7 of us, including Sunil, started this association 15 years ago. In fact, the first meeting was held at CMC Vellore among 7 of us. I am really proud to stand in front of you, and I'm sure he will be proud wherever he is watching us. Dr. Sunil Agarwal oration is established by the family, especially his parents, Mr. Pawan Kumar Gupta and Mrs. Pushpavalli Gupta, in partnership with the Venus Association of India, to perpetuate the legacy of Dr. Sunil Agarwal. This oration seeks to honor extraordinary surgeons who present the passion, integrity, and human nature of Dr. Sunil Agarwal to inspire other surgeons to emulate commitment to excellence with compassion. Dr. Sunil, former professor and head of the vascular surgery, joined the Christian Medical College, Vellore in July 1978, after graduating from Doon School, Dehradun, and DAV College, Chandigarh. Armed with MBBS and MS in general surgery from prestigious CMC, Vellore, he took on the role of faculty and surgeon with diligence and compassion. Subsequent to his training in vascular surgery at Queen Elizabeth Hospital, Adelaide, Australia, he was instrumental in starting a one-year fellowship vascular surgery program at CMC Vellore. He excelled in his leadership roles as professor and head of the general surgery. The Department of Vascular Surgery went from strength to strength during his leadership. The foundation for endovascular training was laid by him, and his team now stands tall on his shoulders. As a senior vascular surgeon, he was an active member and office bearer of both Vascular Society of India and Venous Association of India. With a primary focus on patient care and passion for teaching with high standards, Dr. Sunil Agarwal believed in extending services to the mission hospitals in the true spirit of CMC, not to be ministered unto, but to minister. A champion for poor patients, he walked an extra mile for many, not by demand or enforcement, but by demonstration of influence, seemed to be his personal motto. He was instrumental in personal and professional development of many who are excelling in vascular surgery now. Throughout his illustrious career, he taught, trained, mentored, and inspired young surgeons. His unassuming, selfless, humble, kind, non-judgmental, excellent life of leadership with a healthy balance in personal and professional life has left a beautiful legacy for all vascular surgeons. To honor his exemplary life and service, we are delighted to present the first Dr. Sunil Agarwal oration to Dr. Devendra Dekiwadia.
Thank you, sir. It is indeed an honor for us today that Dr. Indra Agarwal is here with us. May I now call upon Dr. Saravanan Sundarraj and Dr. Roy Verghese to honor Dr. Indra Agarwal, who is here with us on this very first Dr. Sunil Agarwal oration. Thank you, Dr. Indra, Dr. Saravanan, and Dr. Roy. We go to the highlight of this program, and that is the Dr. Sunil Agarwal oration. And to introduce to us the speaker, we have Dr. Sanjay Desai, the past president of VAI. Over to you, sir.
Morning, everyone. It's indeed an honor to be associated with two great people. One, of course, Sunil, who we all have fond memories. He was a wonderful host, and the less said, the better. So, but it's an honor that we institute this, and we have the family with us to have the first oration here. Talking about Dekiwadia, I think the first thing which came into my mind when they asked me to introduce, Dekiwadia comes from the region in this country where when we ask people Kemcho, they say Mazama. Literally means, how are you? It's the immediate reaction is, I'm happy, or I'm joyful, or I'm wonderful. It's the kind of people, that's the region he comes from. And he emboldens that with his presence. So it's my honor to introduce him. We all know him as a cardiovascular surgeon. Few things which we don't know, which I shall try to put it up, is he passed out from PGH Chandigarh He worked at Jamnagar Medical College. He went up to the post of associate professor, and then went on to set up the Dekivadia Institute of Vascular Sciences. He's got tremendous interest in terms of cardiac cases. He's done about 3,000 heart surgeries, about 2,000 thoracic surgeries before going into vascular work. He's a pioneer in heart surgeries in Saurashtra, in Rajkot, and he has established the state-of-art center, including a vascular cath lab in Rajkot. Some of us who are at Rajkot for one of the conference which he organized will fondly remember the quantity and the quality of work which is happening at Rajkot, and it was all due to this man's effort where he has taken vascular and venous work across the country. What we know him as a surgeon, I think what we do not know him as a person, we all are passionate about a lot of things other than our work. You know, a man is recognized not by the profession, but what he does beyond his profession. We are all passionate about doing a lot of things, but he's somebody who's done that. He's an artist trekker, which I have personal interest in, and we share some common interests. He's been traveling across countries. He's traveled across 68 countries. I think most of you here will say I have done more than that. But what he has done is he has traveled on his own, self-driven. So he loves driving. He drives across countries, across borders. He's visited all the borders of our country, spent time with the Jawans. What we see nowadays on the TV channels, you know, a lot of filmy people going up and spending time and showing it. He has been doing this from years before, you know, anybody thought of doing this. So he has spent most of his time with the Jawans at the borders, which is tremendous. Like I said, this is a passion for most of us, but he has been doing it. He is into farming. He loves farming. You should spend some time with him to realize the amount of work and the knowledge he has about the fauna and the flora in the country. And it's very encouraging to see that he has time, apart from establishing a vascular center, doing so many professional work, and he still finds time to do this with the family. Like I said, he's contributed enormously to the society. He has held various posts. He's been the past president, chairman of the Governor Council. The most important contribution from him and for the sustenance of VAI has been he's put it into order. He's got a system organized for the functioning of VAI. He has made a permanent office, we have a secretary, and we have a process in place. So I think the credit goes to him for having set up and has the VAI established so well. He is now contemplating, or I don't know if he's already finished, he is writing a book with the motto, "Youth Never Dies," and I think that personifies what we see in him and the way he comes across when you meet him. And it's wonderful to know that this book is going to come across. I don't know if it's come or he's in the process, but that will be a wonderful read. Again, sir, it's an honor to have you, sir, and may I call upon you to deliver the Sunil Agarwal ovation. Over to you, Dr. Dekivadia. Thank you.
Thank you very much for that wonderful introduction you gave. I want to share my screen. So let me share the screen first. Am I visible? Am I audible? Can someone put this on the full screen?
To the speaker, requesting
Yeah.
you to put yourself on the full screen. The control is given to you.
Yeah. Now, the side panel is hiding me and preventing me. Am I audible? May I
Yes, you
know?
are. Could you
Can
please
someone
try
answer?
now? Give us a moment.
I stopped sharing. No, I'm able. No, I'm here. I'm here. Yeah. I hope I am audible. Good morning, everybody, and good afternoon from Australia. It's just a coincidence that Sunil studied over here, and today I'm delivering this little talk from Australia. Thank you very much for those kind words, Sanjay. I hope I stand to do the same. I would, like all of us, wish that it would have been a pleasure that Sunil was a delegate listening to this talk. It is difficult to accept that this talk is in his memory. Anyway, life goes on and it has to go on. And so all of us have to. But as I talk, his face comes in front of me. His smile is as it was when I used to meet him. And when I saw his family, I thought I must meet. Unfortunately, I had to be in Australia by 15th of March. Otherwise, I would have been sitting there with you all first. The YCON 2022 theme is research and innovation. And we have to think in terms of what research and innovation has to come into the venous diseases. And it's very interesting as we go on. First, research and innovation comes from the art of observation. And as you observe, and the observation get converted into thoughts, and the thoughts provocate observation. And this cycle continues. And as you record this observation, finally, it leads to a search. And this search results into a research or innovation which we publish. Painful knee and ankle with varicose veins around were studied and published. 1956, 62, 65, 72 and 2001, and then forgotten. But then a recent paper has revoked the observation by our friends. These are the veins around the knee joint. You can see this huge one popping down here, this part, and the vein which are concentrated around the knee. And the person, that the people, the sufferers, they had painful knee. So this observation around the knee and ankle, see this complex drawing over here. And the final outcome, look at the toes, what has happened to the toes. This led a thought that it could be a perforator doing something or something this or that. But then the MRIs, when they were studied, and the posterior and middle tarsal subtalar joints were assessed, analyzed thoroughly, and inflammatory arthritis was detected due to these veins. And our friends Roy Varghese, Malay and Manjusha, they made a clinic-based Indian experience of phleboarthritis in a study of 197 patients. A direct association was found between severity of the chronic venous disease and osteoarthritis. Early treatment of CVD could prevent the dysfunction of the knee joint. Phleboarthrosis is a real condition, and its recognition assumes greater importance with increase in life expectancy and lifestyle expectation. So let us look 1956, 62, 65, forgotten, but again brought to the notice in 2020. This is a very, very popular picture. Everyone sitting over here doing vascular practice, venous practice, doing sclerotherapy. There's nothing new in this picture. But till someone got an idea that this winged cannula, what we call a butterfly cannula, if that is used to inject sclerogens into the superficial veins, as we have to keep the needle as parallel to the skin as possible, this small idea worked wonders, and it went into an innovation. Here is one more example. Stability of foam when we do sclerotherapy. This is our day in, day out problem. In a short while, the stability of the foam goes away. So there are new foams coming in. Oh yes, there is a big research going in France, where you will be having a foam which will look not unlike that of a lather, which is made, with the help of a shaving cream. But till then, this was a little bit of an experience. 3 drops of Contrapac, that dye, NGO dye, mixed with the saline and the sclerosant would stand 4 times longer than when this was not added. So small things which come to our notice, we should bring to the notice of our own brethren, and we should also bring forward for the world to know. We very often see, when we see an ultrasound study, the source is unknown. There are varicose veins, and the ultrasound study says that the great saphenous vein and the short saphenous veins are non-refluxing in the entire length. That they can see the perforators which are incompetent, but these perforators are no way connected with the venous bunch which is visible. Then what do we do? The source is unknown. Where are these veins coming from? And I am sure everybody sitting in this hall and those on the virtual platform have faced this at least once in their practice. So here we go. This is a vein. The source is unknown. What to do? Yeah, we can inject a sclerosant, and a beautiful paper this morning we read about the YAG laser Rahul presented. It's so wonderful. Yes, we know the cosmetic component of this. These veins will go away, but soon newer ones will come up unless we know why or what is the source. There is another example of such type of a huge veins, neither related to the great saphenous vein nor to the short saphenous vein, somewhere coming out, jutting out from the posterior lateral aspect of the thigh and spreading right all the way across the thigh, the knee joint and the thumb. This is another beautiful example what we have, gravity and reflux fanning down. So we can assume that there is something wrong here, and with gravity all these veins are becoming the grunt and bearing the grunt, and this is why there are superficial varicosities seen, what you call as a spider vein and telangiectasia or anything else. But when the anti-gravity fanning is there, why this happens? It's very easy to treat. Oh yes, patient will be here from morning, evening, go on home. But no, why there is an anti-gravity fanning? So this thought and observation went on and on in search of a source. We planned varicograms and found some very interesting observations. Let me share a few of these observations with you. This is case 1. Lateral veins, multiple extensive on the left lower extremity, right extremity spared. Commonest thinking is ovarian vein reflux, or another thinking could be that this is the lateral venous plexus, the congenital anomaly remaining, blah, blah. But then when we did the varicogram, we found out a component. This is how the veins were draining. The ultimate vein, this vein was going into the hemiazygous vein. And as we traced it further near the diaphragm, and then when in the cardiac area, it went into multiple vertebral veins. before finally draining into the right atrium. And the deep veins, they were normal. There was nothing wrong there. So was it something, some pressure generation? Was it that back pressure which resulted into varicose veins? What it is, that was the question. Case 2. Here you can see there are veins, very small, and we name them popliteal fossa veins, and otherwise everything was found normal. But when we did an angiogram, there was no history of deep vein thrombosis. This much portion of the popliteal vein was missing. And as we injected, we could see all this. There is no further reflux down in the tibials. And then these veins are draining straight into the P3 segment of the popliteal vein and the superficial femoral. So here, why this is, what had happened? Is there an injury? What it could be? Only a local segment missing. Why? This why is where we stop. This case which I showed just now, and you can see this portion is somewhere there is a ring-like varicose vein. So this could be the source. Now what's there? What's wrong there? So we made an injection in that ring-like, and yes, this is an obvious picture. There's a lot of varicosities which you see. Well, that's nothing new in it, and that's the question is, what is the need of doing all this thing? We could have just injected or hooked them out. No. As we studied, we found there were two superficial femoral veins. One was looking pretty normal, pretty smooth, nice. The other one was looking little odd. And in these pictures, we found out outpouching of the valves. And there was some disease in the deep vein over here, which was leading to development of the varicose veins. So in all these cases, whatever I'm showing, the GSV and SSV normal, non-refluxing in the entire length, but yet there are varicose bunches, and then where do they come from? In this patient, very simple, we could see this bunch over here, clinically very easy to recognize, and then with the help of ultrasound, very easy to trace around. However, as we took a varicogram, we found out that there were multiple channels and all were arising from the junction of the common iliac vein and the external iliac vein. It was this point from where there was a back pressure which was created. Why was it created from there? Any pelvic pathology? No. Abdomen ultrasound? Normal. Any history of any surgery? No, nothing. Nothing was there. So as we look into these cases, here, this picture I had shown you earlier. Now let us see this varicose bunch over here. When we did a venogram, there was very interesting observation. The popliteal vein was quite normal. It was draining well. There was a large draining channel over here. This is all very easily understandable because there could be a large channel, and these we can label as perforators and so on and so forth. But this is what is important to observe, that in a very, very short distance, you can see the number of valves. So we counted them. There were 1, 2, 3, 4, 5 valves in this very small segment, and that each valve was probably causing a pressure. Was it causing? Why was it causing? What about the calf pump? These valves should be helpful. None of them were incompetent. Yes, they were all normal, but they were causing these varicosities. So we are again, there is a why, and we don't have that answer. A chronically swollen thigh and varicosities. And the varicogram showed that these veins were draining into the vertical group of lymph nodes. So when this vertical group of lymph nodes, yes, Professor Wool has demonstrated it very well in his anatomy atlas, a wonderful atlas, where you can see that the source of reflux could be these chronically inflamed lymph nodes. And they result into not only varicosities, but they do result into a swollen thigh as well. Now, seeing this picture, anybody would say, oh, yes, this is a post-thrombotic and this vein is draining on the other side and all that thing. No, my dear friends, no history of DVT. And if you see both these veins, this one normal and the other one normal. Bilateral, external iliac, common iliac, normal, IVC normal, but a local venous bulge. Why did it happen over here? What was the reason? Again, this is a case where we have a history of deep vein thrombosis, but the GSV is not refluxing, and the patient has a varicose bunch in the thigh. Deep vein venogram and varicogram were planned. The deep vein venograms show absolutely normal veins. When we do a varicogram from these veins, let us see what we see. It is only an isolated bunch becoming varicose. The GSV remains normal, the deep veins remain normal, only this bunch. So why did this bunch happen this way? What went wrong in this particular place? Was there an infection? There was no history of infection. Was there a trauma? There was no history of trauma. So something is happening, and if this is allowed to grow, it could easily, transmit all other tributaries towards the knee joint and lead to phleboarthrosis, maybe something new which you don't know as yet. So, the parked observation, varicograms were performed in the pre-USG era. USG machines and use of Doppler ultrasound shifted the balance towards the non-invasive. That doesn't mean that the cath labs have died. We do use cath labs for deep vein thrombolysis or for arterial procedures and so on. The cath lab is one of the best companion, like Doppler is our stethoscope, and cath lab is probably the most trusted nurse working with us and giving us the best output towards the patient. Many a times people feel that the end is reached, but that may not be true. Interestingly, a paper published in 1987, it narrated that we have known everything what we wanted to know about veins and we did not know anything further. However, every one of us know after 1987, there has been a mammoth progress. Like this morning, we have been listening to various types of lasers and the various frequencies what Shoaib told us, and what Rahul demonstrated, what Sandeep demonstrated. Everyone, when Robbie demonstrated, so many things have coming up and up. So it cannot, but this was a paper published. The use of varicography to identify the source of incompetence in recurrent varicose vein was attempted way back in 1984. But this was way back in 1984 when the ultrasound was not there and their focus was on recurrent varicose veins. Here comes a question. Which vein do we call recurrent? If we call recurrent vein, then the GSV or its branch which was refluxing and we had ligated or burned it out with EVLT or RF, and then again it woke up, then it is a recurrence. But we all as surgeons know that if an appendicitis was there and an appendix was removed, and then if there was a post-appendicectomy pain, the cause was not appendix, there was something else. So these recurrent varicose veins could be something else as a source. Intraosseous phlebography and pelvic phlebography is nothing new. Article in Portuguese, an article in French, years back were presented. Presently, no abstracts are available. But if you go back to and read the atlas of Professor Wool, he has shown intraosseous venous drainage systems, and he has also shown dilated veins resulting into a dilated foramen into the bone and a chronic pain in the bone, around the joint, in the joint. So dear friends, a lot remains to be understood. A person like Sunil, who dedicated his life and trained so many young surgeons, I think the best we can do for him in his memory is a message which I will soon deliver. These veins, how do we explain this type of veins? It's very, very difficult. There are other veins, we keep on seeing the main trunks which we are looking for, lasering out and this and that, the professional call. Here, these veins, we keep on seeing such type of patients and we go on labeling them that this could be the congenital present veins and this could be this type of veins, but yes, why they are there? What is the reason? This patient, very easy diagnosis. Yes, there is an IVC obstruction, there is something this, something that, the Budd-Chiari syndrome or 1, 2, 3, 4. No, there is no ascites, Budd-Chiari is less likely. Okay, then there is an occluded IVC, yeah, fine. And these are the alternative channels, agreed. These are the commonest channels. But have we ever seen channels also on the back? Where are they going? Why they are seen over here? So this why has to be answered. The pictures on the right side is Katie syndrome. Yeah, Katie syndrome, very right. But look at the veins. The veins, the way they have dilated. The skin also is giving a cover, not like that of a caterpillar being covered. You can see each and every area. And then there is, yes, there is pigmentation, understood. But look at these veins. How to explain this? Where is the gene? What is the gene modification? And on this side, left side, this is no congenital. This is such a superficial vein running, becoming aneurysmal here. This is a great saphenous vein. It was refluxing in its entire length right up to the ankle joint, causing this discoloration. And this was causing such a severe reflux and volume reflux that patient used to remain in tachycardia. When we dealt with this, after we did a deep venous study, everything was okay, and then we treated all this thing, the tachycardia component went off. Tachycardia with occasional extra systems. So there is a message to the young generation. Look, I am at the other end of life. I don't say I'm going to die tomorrow, but then I am towards the setting sun. I have lesser number of years to live than most of the young people who are sitting over here have. That doesn't mean I should stop working, I should continue work. Yes, and I would, as long as my body permits. I would go on trekking also, I would go on writing books also. Like Sanjay mentioned, yes, I've written one book on diabetes, and the title is Diabetes a Friend. Don't run away from diabetes. There's another book which I've written for the final MBBS students, because we are all getting far away from the clinical knowledge. We just want to finish off, no mugging up. Simple, ready reckoner, 94 pages. It is published already. The third book I have written is O Musafir Tu Jayega Kaha Sanjay. It is already there. It's available on Amazon as well as it's available on net, and it is very much there. What a journey called life can teach you. That is the motto right now behind writing that book. I wish I could share. I think President Bedi is carrying a copy with him, and I'm very proud and happy to share that the foreword of that book, Musafir, has been written by none other than Professor Ramakrishna Pinjala, one of our members. So dear friends, cycle of observe, think, observe does not take a couple of years to a new thought. It takes a couple of decades. So what? Continue thinking and observing. It does not cost to think and observe. It may reward. And my message to the young generation, the budding vascular surgeons, the growing vascular surgeons, the thoughtful vascular surgeons, and a message as if it is coming from Sunil to all of you, dear friends, is we do conduct studies, but we have a habit of writing our results are comparable to the Western standards. Why? Why can't we come out of that? Say these are our results. Let it go to observation. Let it be rejected or accepted. But we have our sincere results that this is what we observe and this is what we think. So someone sometimes thought that there is something in these oranges which takes away my cough pain. And then that thought went on and on and on and on, and then diosmin and flavonoid and micronutrients, etc., all of you know. So why from these oranges? But there must be an observation. Our country has millions of such observations written in our books. All sorts of, I'm not going to quote Upanishads or Ayurveda or anything. No, they're written millions of them. We can search something. Since 3 years, I've stopped talking Rama. I speak Ram. I don't speak Krishna. I speak Krishna. I don't speak yoga. I speak yoga sanam, or it is yoga. Why do we want to follow others? We have our own. So my dear friends, these are the most challenging veins. The spider veins, the source unknown, the thought process to be evoked in yourself, the observations to come together, to study and find out something new and present it to the world. I think if we do that, that would be the best we could do for our friend who departed from us so early.
Thank you, sir. Shall we give it up for Dr. Devender B. Dekiwadia? To honor him, we have the presentation of the plaque of honor, the medal, the citation, the certificate, and the shawl. I now request Dr. Indra Agarwal to honor Dr. Dekiwadia, and on behalf of Dr. Devender, may I request Dr. Harinder Singh Bedi to receive the presentations.
Can we have a standing ovation?
Yes.
Standing ovation.
Can I request the delegates to please stand, and we will have a standing ovation for Dr. Sunil Agarwal's oration. Thank you all. We'll continue to applaud as the presentations are done. The plaque of honor. The plaque of honor in memory of Dr. Sunil Agarwal, presented to Dr. Devender P. Dekiwadia. The Medal of Honor, the shawl, the certificate, and finally, the citation of the first Dr. Sunil Agarwal oration. Thank you, Dr. Indra and Dr. Harinder Singh Bedi.
Thank you very much. Thank you very much. I'm delighted. I'm honored. And I thank all of you from my heart. Thanks a lot.
Thank you, Dr. Deke Wadia. I hope you can hear us.
Yes, I can.
Yes, we have overwhelmingly enjoyed your talk. It has been most encouraging and most inspiring for both young and old. Thank you very much. Goodbye.
Dr. Sunil Agarwal is known as the doyen of vascular surgery, a great academician, a passionate teacher, but more than anything, he was a loving husband and father. May I now call upon Dr. Indra Agarwal to represent her family in giving the response to this first Dr. Sunil Agarwal oration established by the family and the Venus Association of India. Over to you, ma'am.
Good morning, everyone. At the outset, I'd like to thank the Venus Association of India for responding to our request to set up this oration in the memory of our dear Sunil, whom we lost so suddenly and tragically. This is just a small way of remembering him and honoring him and showing the respect that we had for him and for what he meant to many of us who are gathered here. To some, he was an honorable colleague. To others, he was a revered teacher, mentor, and guide. To others, he was a faithful friend. And to us, as in the family, he was our pride. But above all this, to his patients, he was a beacon of hope. This was shown in the way he looked after them with empathy, kindness, dedication, compassion, and true selflessness. Sunil had very humble beginnings in a small town of Saharanpur in UP, but he got the best education that any child could dream of, having graduated from the Doon School in Dehradun in the north, and then studying in the Christian Medical College, Vellore in south. And thanks to the farsightedness of his father, who valued good education above everything else, he was instilled with qualities of benevolence, kindness, and generosity, which he learned very early in his life. And the way he lived his life thereafter is a testimony to this. In spite of being blessed and gifted, Sunil lived a very simple and humble life with very few needs for himself. But he was always there for a shoulder to cry on. He was always there to give simple and practical advice to anybody who asked for it. His clarity of thought was always admirable. His righteousness and forthrightness was always very evident in the way he lived his life and dealt with various situations that he faced. I'm sure many of you have your own stories to tell, your own experiences to share. Sunil was an inspiration to many. For us as a family, he was our star. But to many of you over here, we have lost our star, but many of you have actually, in the surgical fraternity, probably lost a lot more. We hope that through this oration, which has been instituted by us, by his proud parents, he will live on. The principles with which he lived in life will be an example to many young budding surgeons, who probably many of whom are sitting here. I would also like to take this opportunity to thank the vascular unit at CMC, who have overwhelmed me and the family with their love and regard that they have shown us. I'm sure you will take the unit and the department to greater heights, and I'm sure make Sunil proud. Thank you very much for giving us this opportunity to being with you here today. Thank you.
Thank you, ma'am. May I now call upon Dr. Deepak Selvaraj, Professor and Head of Vascular Surgery and the Vice President of VAI, to propose the vote of thanks.
It's been an honor and privilege to come and stand here and the first Sunil Agarwal oration for my beloved teacher. He has been a great source of inspiration for me personally, how to conduct myself with integrity
and be very straight in whatever we do. Call a spade, he used to tell us. Like the rest of the Venus Association of India, all of us, we really miss him. I thank the Venus Association of India for giving us this opportunity, as well as I thank the family, Dr. Indra, Appa and Amma, and their sisters and brothers, the sons, for giving Venus Association of India the honor to have an oration. It will be an uphill task for many of us to reach the status of Sunil Agarwal as a teacher, but that is what we will all have to aim. As youngsters, the future awaits us. All of us have to be good teachers and transfer the knowledge to the next generation. Like Dr. Dikivadia said, think, observe, and innovate. And always question yourself, question your failures, and come up with new ideas, new theories. Make friends, travel, have a laugh, enjoy your meetings. Life is more than just academics. And this is what Dr. Sunil taught us. On behalf of all of us, I thank you all for coming here for this oration. And on behalf of the Governing Council and the President, I thank you all again. We will now continue with the next session.
Is this your mobile?
Yeah, it's my mobile.
Once again, thank you to all our dignitaries who joined us on the stage. Thank you to Dr. Devendra B. Dekivadia, and thank you to the session's MC, Ms. Sheila, for taking us through the session. We'd like to move forward and take you through another session, and the chairperson for the next session, which is setting up a vein clinic, is Dr. Roy Varghese and Dr. Gulshan Jeet Singh. May we have both of you on the stage, please?
And say, Master of Ceremony, Bharani.
Ladies and gentlemen, thank you so much for your patience so far. I'd like to request all of you to kindly be seated. We would like to continue with our next session, and we have our chairpersons joining us for this session. Mic is right here.
In this session, we are going to have two talks. The first talk is setting up of a vein clinic. Now I invite Dr. Deepak Chalviraj for presentation. The topic is setting up of a vein clinic.
Meanwhile, requesting all of you to kindly be seated. We will have the lunch break after this session, and we will make announcements accordingly. Over to the speaker.
What do they control? Good afternoon, everybody. So as we were trying to set up the talks for this conference, we thought we should have a very light talk after the oration and before lunch. And so Sanjay and me, we decided we'll have something which is very different from academics and which will enthuse some interest, hopefully. So today my talk is on a one-stop vein clinic. And this has been something that we've been thinking about, and we started doing it at Vellore. So I call it the Vellore model. And I would like to, as I go through the slides, I will tell you how we actually started doing this and how we established our vein clinic at Vellore. So the existing systems that we have in all our hospitals and clinics, we don't have any referral systems in India. It's not like the NHS. We have a very crowded outpatient clinic and super waiting times. So patients just come. They just decide to come, so they come. So they just come here and they are really unprepared for what they have come there for. They don't know that they have to wait. Sometimes they don't bring anything to eat. They have got children as well. And many of them are hospital hoppers. They go to a hospital and then they meet a doctor there who says something, and then they're not very convinced, and then their brother says, hey, I know this doctor is very good, go and meet him. So they go to another hospital. So they just keep hopping from one hospital to another. It's not a very good system that we have in our country. So number of visits before any intervention. We have at least 3 visits. So we did a small study at Vellore, and the quality control team actually, we have a QMC team that actually did this study, and they interviewed all these patients who came to the outpatient clinic, and they said the minimum number of times they've had to come to a hospital after the first visit is almost 3. So that is not a very efficient system at all. So the first visit is actually a feeler. The second visit is with a kith and kin after discussion at home, and he has to come for a third visit for an ultrasound scan, and finally decides on the date of surgery. So what happened during the pandemic? I call it the corona conversion. The patients became smarter, the smart patients. They became internet professors because they had to stay at home. They couldn't get out of the house. And they started having net-based second opinions. And there was a growing acceptance to telemedicine. And in Vellore, we actually initiated something called the eMeds, which is the electronic medical distribution system, where we actually do a prescription on our computers, and somehow we figured a way where the medicine reaches the patient all over the country, right from Arunachal Pradesh to Kanyakumari. We used India Post to do that. And then we also we established intelligent call centers, which were actually helping us in this whole scenario. So how does this work? How does the one-stop vein clinic work? So you need a reception, you need a good, smart call center, you need to have a proper triage team, and you have to have excellent vascular nurses, specialist vascular nurses who can actually do many of your work, including scans. You need a doctor, but he's not the most important person in this whole thing. And you need a small theater team and somebody to do a post-op monitoring, and then you discharge the patient. So all this happens in one day. Patient comes in, you do all these things, and he goes off in the evening. So central to all these things is the call center. So the call center has to have 3 or 4 people with some computers. I'll tell you how we actually figured out the call center. They have to liaise with the patients. They collect data like reports, scans, and pictures. So all this is done by the call center people using a computer, a terminal, and a web-based server. And they have to fix telemed appointments, fix direct appointments as well, and track emed queries, because you're going to see a patient with venous ulcer and going to give him a 4-layer dressing, and then it has to go and reach the patient and liaise with the doctor, pharmacy, patient, and the courier service. In this case, in CMC, we use the India Post. So at least you need to have 4 computers or workstations, 1 supervisor, 3 personals, and 3 personals, a LAN connection, scan, fax, telephone, WhatsApp, and chatbots really have changed the way we liaise with patients. So that's how it whole works. You have the call center, the doctor's order, the patient. This is how our eMeds works. Then they liaise with the patients, they liaise with the payment portal, the pharmacy, and the courier service. So triage, next thing is the triage. As soon as a patient comes in, you have the reception followed by the triage. And the triage has to be, again, nurse-led. They take a brief history, brief examination of the legs, including the pulses, and dressings may need removal. And then the patient goes to a vascular lab. You have, again, a specialist nurse or a vascular technician there who does the ankle brachial pressure index, TCPO2s, air plethysmography, and duplex scans. So then, by the time the patient reaches the doctor, most of the work is done, and then you have a guy sitting there who calls him the specialist, and all he has to do is to convince the patient to undergo a certain procedure. And all the procedures in these one-stop vein clinics is done under local anesthesia, and patients will be discharged on the same day. So you need to have after you see the patient, you need to have a theater. We should have a very friendly atmosphere, because the patient is walking in and he's going into theater, and you have to explain the procedure properly. And please tell the patient that it is not a painless procedure, although there will be some pain. And we have started using more and more non-thermal ablative techniques like glue, which have less pain, and foam sclerotherapies, and we even do microphlebectomies under local anesthesia. So after the procedure, you need to have a post-op monitoring team, and at least 2 hours of monitoring we have. We ambulate the patient, give them adequate compression, and we usually review them after a month, and escape consults can be ordered by teleconsultation if the patient wants to ask any queries before the monthly appointment. And stockings and drugs are distributed by month. If the patient feels happy to have a teleconsultation after a month, we see them, we extend the medication and send the medicines by eMeds, the electronic medical distribution portal that we have. So you can actually, like Dicky said, you can let your thoughts fly, and you can add these other rooms if you want to. You can have a compression therapy room, and which can have at least 4 patients at a time, a multi-chamber compression. You can have people doing manual lymphatic drainage and teaching of drainage techniques, videos, stockings measurements, how to wear a stocking, advised on the best stockings that the patient needs to buy. And you can also expand some more if you can use reflexology. A lot of people just swear by reflexology, naturopathy. We're in India, we've got all these things, so you can include them. Anything to do with legs, Ayurveda, yoga, fish massage, if somebody wants to do that. And so it's basically a one-stop vein clinic, and let your thoughts fly. Patient comes in and goes home very happy. So what are the advantages? It eliminates waiting times, abolishes unnecessary outpatient appointments, it saves time, enhances patient satisfaction, and quality of life can improve. There's a huge cost saving which is possible. But what are the limitations? Some patients may need other department consults like cardiology, medicine, etc., geriatric medicine. And some patients may have complex varicose vein, thrombotic issues which need further evaluation. And sometimes it's very difficult to convince the patient, when he comes in, but he has to come in prepared. And theater facility has to be utilized optimally, otherwise you might run into a loss. And so you need an optimal patient load. And to start off, I would suggest this works well in cities and urban-based clinics. So in conclusion, it's an attractive option. There are very few licensing issues. Specialized vein clinics are the need of the hour. And sometimes it not may be a one-day affair, because for insurance, the insurance patients who have insurance may need to have longer stays. That is an issue which we have to sort out. Thank you so much.
Thank you, Dr. Deepak, for covering the nice topic, the setting up of a vein clinic, specialist vein clinic. and we can have a discussion at the end of the second talk. Now I invite Dr. Sanjay Desai for the topic formalizing education in venous disease. Dr. Sanjay Desai, please. Thank you.
Thank you, sir. Well, as Deepak said, we thought we'll have some light topics or, well, not really light because this is something which deals with what we are all here for, continuing our knowledge, continuing what we have to learn, continuing to see how we can provide better for our patients. Most importantly, I'm passionate about teaching. I think most of us are. And education makes it very important because I keep telling this, as surgeons, we are not just here to operate. I think the three basic aspects of any doctor or a surgeon or a physician is, one is to learn, second is to do, and third is to teach. That is what makes it complete. I think if you're not that, then we are not qualified to be doctors. So I think that's very, very important as a practice. That is why we call ourselves practitioners. It's very important. And nothing more to be more in this field where it is human touch which comes into the picture, and we deal with lot of emotional aspects as of what we are seeing. As we go, I think in the last couple of years, Deepak did mention the corona changes in terms of practice. We have seen how consultation is gone from patient to virtual to online, and now we have TV ads. I don't want to name some of the companies which offer surgeries. You just dial them. Now there are apps which are being advertised, and they talk about treatment, and it's become more technically demanding. And yes, technology is evolving, and as everything evolves and we need to merge the technology, that's how we all improvise and how we go. Medical science is also rapidly progressing. It's in Dekivadia's talk, what he spoke about veins, which were stocks, seen everything in 1927, but no, not really. There are lots more to see, or maybe, should I say, discover. It's already been there, we haven't seen it. So medical science is advancing rapidly. And when both of these are advancing, there's always the point where it merges, and we have to keep in account what is happening. Changes are constant, and that's something which we all have to accept. There are changes for good, there are changes for bad. Whatever it is, we have to accept the changes. If not, we don't progress from where we are. Now, coming to the topic, formalizing. When we say formalizing, we talk about a structured program, a structured system in educating. And when we talk about this in relation to medical science, well, medical science is not really science. So it's so vast, it's so diverse, and there are so many overlapping specialties or subspecialties now. And it definitely makes it a challenge professionally and in terms of practice, how we do this. So what is the need? Where are we looking for? Why are we looking for this formalizing? What are the challenges we are facing, and how can it be done? I think first two topics, we are all good at criticizing, we are all good at picking faults. That's the most easiest thing to address. But when it comes to how it is done, that's the most difficult part. Even after how it is done, to follow that how it is done becomes even more difficult. I think that is where we struggle. So what is the need? See, as doctors or as a medical profession, we evolved from treating, managing diseases. So we were all doctors. Then we became physicians, we became surgeons. From general surgery evolved cardiothoracic and vascular sciences, and then vascular science surgery came on separately. And now we talk about venous surgery, we talk about angiology. So, it's evolving too rapidly for us to catch up. And as we better understand the disease and the management, we should evolve. If we are not evolving, like I said, changes are constant. If we are not evolving, we are stuck. And if we are stuck, we are extinct. So when I say extinct or we, I don't mean as a profession, I mean as the way we can give treatment or we can manage the patients. That is what we are here for. And we always have to give a holistic approach. Now, this is something which I'll tell you what we need to do. So the challenges are plenty. we have lost focus of the challenges, or we have really lost focus of where we are heading. I think this is something what has happened because, like I said, we started as surgeons, we started as physicians, you know. I remember my professors and, you know, their colleagues, they could do everything. They could do from craniotomy to hernia to vessel repair and everything. And before that, there were physicians who were operating. In fact, yesterday I was talking in some of the government rural hospitals. Even now, surgeons, physicians are, and I wouldn't say made to do, they do minor surgeries, and when they take calls, they are expected to know basics. So that is how it was. But we are losing touch with where we started. We are evolving too rapidly. The most important thing is the importance nowadays is being given to the methodology of treatment or the technique rather than the disease. We all talk about how this can be done, how that can be done, what are the different technology available, what are the different methods available. But we are really losing focus of what is the disease. Does this technology, yes, I'm not debating whether technology is good or bad, but whether the disease pattern is understood by the person who's treating. You know, when I was training general surgery and when we were starting, laparoscopy was just coming in, there was a dictum, if you should have done at least 25 open cholecystectomies before they allowed you to hold the camera. So that was how it was. So there was some importance laid upon what you should know before you embark on a newer technology. So now the technique is gaining more importance rather than the disease. Of course, there's a lot of glamour which has come in. I think, well, good or bad, it's good to always be in the limelight, but it has its fallacies. We all know what glamour can do. So we are not in a profession where glamour is a necessity. It's always nice to be recognized. We are not going to be on, you know, podiums of various filmy or show events, but it's always good to be there. But will that change what we are practicing? And of course, the thought, it's just not mistreating and getting away. That concept is not limited to veins, but veins, yes, are very forgiving. We can do away with veins in most part of the body. We can just ligate most of them. That's why I was telling what happens in an IVC trauma. I said, no, you just ligate, nothing is going to happen if it's an emergency. So you can get away with anything. Is that also a challenge with what we are dealing with venous surgery? And as we better understand the disease and management, is this too much to handle? I think we are not really evolving from what is happening. We are actually going round and round. We are probably, you know, amongst ourselves, we are on a lot of gray areas, stepping on each other's specialities, so to say. But that is something which adds to the challenge when we start drawing borders and start making lines that this is mine and this is yours, and that's also a problem. So how it can be done? Like I said, this is the most difficult part. I had to spend quite some time to come down to this slide and see what can be done. I'm making it in general. Well, as any specialty, if you look back, the first thing is the acceptance of the space or the subspecialty. I think, okay, time's up, so I'll just finish. I have one more slide. So acceptance of the subspecialty is important. Recognition of the same. I think this is the most important. The first thing is we need to get it accepted. Once it's accepted, we need to be recognized. Recognized is not by force or by demand. I think it should qualify demand, it should qualify respect. So once we do what we do well, people will respect. I think that is something what we should aim for. Structured training of the disease and management should not be in isolation. That's very, very important. I have been stressing on this. We cannot train individual procedures. We cannot train individual techniques. It's always good to have it in a holistic way, and that is what makes it very, very, very respectful, so to say. Eventually, if we don't do that, we'll turn up becoming Frankensteins. So if we'll have a jack of all and master of none, and that eventually is going to dig into what we are really wanting to provide as we go by. So that's my last slide. So education is a right for all. I think it's a basic right. It's in the Constitution. So that's a right for all. We need to make sure that we are educating a system of healthcare and not a personal. I think this is something which I want to stress upon. and we need to get the system rolling. We need to get that into effect, into a structured training program, and that is what will make formalizing the Venus education more helpful and more long-lasting. Thank you very much.
Thank you. Now, I would like to make one observation, and it's a matter of fact. The Venus Association of India stands for passing on the knowledge, one. And it also stands for associating with others to spread the knowledge and also to learn from them. Now, if there are any questions from the audience, please come out to the mic. Yes, Malik.
I'm just trying to expand on what Deki Wadia said and what I missed the first half of your talk. But anyway, the issue is that, you know, there are certain words that we have so far been ashamed of speaking, and one of them is Indian Jugaad. I no longer use that word even internationally. I call it an innovation at low cost, and then people, you know, come and listen to this, and then after some time, when I'm sitting in the audience, they come and say, we do the same thing. So I think it's best, you know, put that way, that research and innovation, but innovation at a low cost.
Thank you. Can we close the session now? Thank you.
Thank you so much to our chairperson, and thank you to all of you for sticking with us so far. You're right here seated, and you're smiling through, applauding for it, and it feels special, it feels good. Thank you for that. And on that note, we'd like to take a quick 10-minute lunch break, but when I say lunch break, you are requested to grab your meals, come back, and have your lunch here as the session goes on, because we have our next session that is lined up accordingly. And I hope all of you will quickly take your breaks, grab your lunch and come back. Lunch is sponsored session, and it is sponsored by Sigvaris. So we'll now take a clinical symposium break. Requesting all of you to come back to the hall in next 10 minutes. Quickly grab your lunch boxes, lunch plates, and come back to the hall. See you soon. Thank you. A very good afternoon to you all. Thank you so much for quickly grabbing your lunch and making it up to the hall. We are grateful for your time. Thank you so much. And on that note, we'd like to start our afternoon session, Sigvaris Raps by Dr. Rahul Jindal. The stage is all yours, sir. Yes, you may applaud and welcome him. Over to you. Do you need anything?
Yeah. Very important. Good afternoon, everybody. Sorry to push you out of your lunch, but I think it's an important thing. Can I have the talk, please? I'm going to talk about RAPS as a compression. You know, RAPS has been introduced in our country, recently around 2 years back. And we were very reluctant to use in the beginning because it was expensive. It's nearly 3 times the cost of the stockings. And you always feel who's going to buy it. And because the people were reluctant to buy stockings. And we were also trying to find a place where the RAPS can be used. This was always the thing. And then you also have to learn how to use it. It is slightly more complex than the stockings, but once you know the little bit, then it's very, very useful. So I have made this talk very practical. I've taken few slides from Sigvaris, few slides are of mine own, and I really don't have any conflicts of interest. So I just want to have a raise of hands. How many people are using RAPS regularly? 1, 2, 3. So 5 people from the whole audience. So means this talk will be really very important for the people who are using the RAPS and also for the people who are not using the RAPS. Okay? And there are different names of the RAPS, and it becomes really confusing if you don't know, because we as you know, society, we have not taken a separate lecture. There should be a workshop on the RAPS, which we are planning to launch in, we're planning to do it in August. And how many people know in the audience what is AccuTab? Anybody knows what is AccuTab? Okay. So the people who are using RAPS also does not know what is AccuTab. So that's bad. Okay. So that's the fault of Sigvaris guys. Sorry guys, but that's your fault because you have not trained the people properly, the people who are using RAPS. Okay. So how do you size the RAP is also very important. It's not that somebody just dekho ya medium aayega ki small aayega. So it should not happen like that because it will not be the right thing to do. So we have only one nurse in our department who we got him trained in the RAPs, and whenever the patient, we think that patient requires a RAP, he only does it. So it's not that any nurse in the department will do it. And if he's absent, then it becomes a problem because I have to find the time for that. So why RAPs? No, RAPs are much, much easier. You will see a lot of patients in your clinic who have difficulty that I cannot wear stockings. RAPs can be worn by anybody. It's very, very easy to wear it. If you have deformed legs, they are very useful because stockings, you must have seen, a lot of pictures where the stockings has actually gone through the skin, has put in, abrasions. The patient has got a dermatitis, very difficult to wear stockings. Patients have got poor weather conditions, very difficult to wear stockings. So let's see some pictures. So these are our real clinic pictures. Look at the type of stockings the people wear. So, we keep on clicking pictures whenever people wear stockings in different formats, which are not normal. Okay? So like this, okay? Like this, the patient was having stockings on this, really got the whole skin was cut at the champagne area near the ankle. So it took us 3 weeks to heal that ulcer, which was created by the stockings. Because you can't wear stockings in that leg. It's impossible. Okay? Now, this is really a true picture. This patient comes in and I took a video. Okay, aap dal ke dikhao stockings kaise dalte ho? Okay. He says it's very easy. It takes me 2 minutes. But my swelling is not going down. As soon as I walk for a few, minutes, and on the top of that, he wears socks. And my swelling is not going down. So do something, and somebody has advised him an iliac vein stenting, okay? And you could have seen the leg, it's not even 10-20% higher. It's a post-DVT, iliac vein stenting, you can imagine what is happening. Okay? So it just required change of mild compression, he'll be absolutely fine. So, very basic. So weather is a very big problem, especially as South India, now in North India, we have got 33 degrees. So it's a very important thing where people wearing stockings is difficult because donning is very difficult for stockings, especially people who are old, arthritic, everybody. I always try to wear stockings myself. It is a problem. It's not easy, So let's see this group of patients. Now try whichever stockings you take, Jobs, Medi, Sigvaris, you can't put in stockings here. How will you measure the size? There is a huge difference in the foot and the If you measure the sizes, it will not come into any of the charts. So how do you size them? It was a nightmare situation. So before the wraps, what we used to do was, we used to do the compression bandages, multiple layer, make the legs slightly bit more better, and then we used to do what we call as flat net. Do you know what is flat net wear? So what that means is, flat net wear is a way of weaving it. So it is size to measure. So there is a guy there, he takes the sizes and use a different garment, which is not as the stockings garment, which we call as circular garments. And he used to make the stockings and we used to put them on with a zip or, you know, simple stockings. So that used to work very well. But normal box stockings cannot work. Now, wraps are also useful for self-management. Let's say the patient comes with an edema and you put in a stockings and patient really wears the stockings. Within 5 to 7 days, the edema will go off. And your diameter can reduce up to 20 to 30%. The stockings will not be of any use now. It will become loose. So the patient has put in a money, but within 10, 15 days, he can't use it now. So the wraps are adjustable. So you can actually take care of nearly 30% of the swelling in the leg by adjusting the wraps. So the same thing can be used for this swelling and the same thing can be used for this swelling. So the patients can adjust the wraps accordingly. So, you know, these are the basic advantage which I've already told you what the wraps has. Now, always the next question comes is, does the wraps also have the similar sort of compression? And of course, you know, 4 years back, you know, one of the international meetings, I saw the wraps for the first time. And, you know, we always thought, will they really work? Because our basic thing was, they are not covering the foot. So when the initial wrap came, they only came for the calf. And so we thought, if the foot is not covered, will they be able to provide the same compression? So then these studies came up, and you can see at the dawning, it was low, and when you are walking and climbing stairs, the pressure can go up to 40 millimeter. They are really inelastic, and so you can get a very good compression, and people really used to benefit. And then there were studies published, comparison of the stockings, 4-layer bandages, and wraps in healing of the venous ulcer. So it was similar. So after that, in the last 3 years, the wraps really has jumped in the world in terms of wherever you cannot use stockings, you can use wraps. There are difficult situations. Now there are different companies who are making wraps, and in India we have 2 companies, one is Medi and one is Sigvaris. We used to use Medi for 1 year. Actually we used more than 100 pieces, and Sigvaris was not available in India at that point. So once the Sigvaris comes in, so we always try to see if this is better or not. But then you look into the portfolio, the Sigvaris has a huge portfolio. And actually it covered everything, and we found that the material was much, much better. And best thing is it was 15% cheaper. So we actually shifted from Medi to Sigvaris. I'm just, because it's such a vast topic, I'm just going to cover a small portfolio what Sigvaris covers. So basically these are the few things, and it covers the calf, the foot, the thigh, the knee, and the arm. So you get actually wraps, put in wraps anywhere where you can put in the stockings. And they are all synthetic, but they are washable and they really last long. So one of the patients who is caring for us from 2 years, he doesn't have to change the wrap. So they can really last very long. And if you look into the costing as compared to the stockings, most of the stocking, they don't last more than 5 to 6 months. So that's why if you look into the cost effectiveness, because we were, you know, when we started using them, we were not sure how long will they last. Will they be much more costlier than the stockings? But that's why, as we felt comfortable, we started using more and more wraps. All the wraps, they come with the liners. So what is liner means with the wraps is, there are 4 basic type of liners which you have available. So one is a very simple liner, basic liner, means let's say if you have a dermatitis, if you have a small venous ulcer below, so you can cover the ulcer with a dressing, put in a basic liner just to cover it up the whole skin, and then like a socks, and then put the wrap on. And the wraps can have the pressure from 20 to 40 millimeter mercury, so quite a high pressure. Let's say you want a pressure to be slightly more higher, means sometimes you got an isolated swelling in the foot and the ankle, not in the calf. So you can combine it with a transitional liner. Transitional liner will have 10 to 15 millimeter mercury only in the foot and the ankle. So they tell the patient to put in the transitional liner below and then put the wrap on the calf. Then we got a complete liner. Complete liner means you have a 10 to 15 millimeter mercury pressure both in the foot, ankle and the calf. So effectively you can take the pressure in the calf areas to 55 millimeter mercury. So actually more than the 4-layer compression bandages. So if you combine these things together, so depending upon how thick the skin is and how much the edema is and how much pressure you want and where you want, you can combine them together. Sometimes your skin is not good, then you want to put in a cotton liner inside, like especially in winter areas and where people want support below it over the period of over the dressing. They don't want to put in the wrap directly on the dressing. So you can put in a cotton liner below, but the cotton liner does not have any pressures. So there are various combinations you can use. So basically you can combine, mix and match. So you can decide what liner you want, how much pressure you want, and depending upon that, you can use a color. You want a gray, you want a black, the wraps comes in blacks. So, depending upon that, you can use what you want it to be used. You can also combine them with a foot wrap if you want a swelling on the foot, if you have a swelling on the foot. You can also combine them with an ankle, the knee and the thigh wraps. So depending on where exactly you want the compression, where exactly you want the liner to be, you can combine them together accordingly. Now this is the total portfolio they have. The first one, what they call, you must know the terminology because it is easier to communicate with the companies to order. The first ones, all of them, they are called as CompriFlex. So compression with a flexion, okay? So these are the basic name. And then you can say you want a calf and a foot, you want a knee, you want a thigh, or you want an arm. So the first terminology is CompriFlex, and then you can say what thing you want, and then you say what liner you want. So out of the 4 liner, you can choose 1 liner. So that's it. So that's how you order. Not one box, but it's a combination of the things what you can use, which really gives you a very nice thing. Now go to the most commonly used CompriFlex is the calf ones. And the foot one, thigh ones and arms are rarely used. But so that's why I'm going to concentrate on this. So there are a few things. One is you can see in the middle, there is an elastic band. So you just wore that, and that actually acts as a third hand. So the moment you wear it, because of the curve, it really holds on to the calf. So it doesn't fall down. So the patient has got free hand. So actually the moment you wear it, it will stick there, and because of the elasticity. And it can have an elasticity of around 10 to 20%. So there is a calf on the side, and on the side you can see the roll-ons. So these are the roll-ons are the straps. So when we tell the patient to wear, you make these straps roll on so that they don't keep on hanging down. And then the patient wears this like this, first the liner, and then this wrap, and then you adjust this wraps around. I have got a video from the company which I have borrowed them. So just so you can see in practically how we wear it. So this is like a third hand, the moment you wear it, it sticks there. And then you put in these straps. So there are 4 straps there. So you can wrap them around. So this is what we call as an AccuTab. Okay. So it's a very small thing. I'm going to show you how to apply that and what are the things you should be careful. So you can actually have the same wrap and you can have a compression of 20, 23 to 32, and up to 40. So basically, you can increase the compression exactly how you need it. So this is also very useful if you have a venous ulcer with peripheral vascular disease. So we have used it in few patients because you can keep the pressure up to 21. You can know exactly what pressure to keep. So that's a very big advantage what we have with the wraps. Okay, now this is an AccuTab. So you can see how do we apply this. Sorry. So it's a small thing. You need to apply this on every 4. So there are 4 to 5 of these which will be coming in with the box. You can exactly, so first you just make these straps just in the normal position, not stretch them. In the normal position, you put them on, then you apply the AccuTab, and then you stretch the flap accordingly how much pressure you need. So when you stretch it, the end of the strap should not cover the numbers. So there is a small line over there. I'm going to show you in begin. You can see the green number. There is a small green line. On the red, there is a red line. On the blue, there is a blue line. So you take the end of the strap up to that line, and that gives you the amount of pressure which this wrap is providing to the leg. So you will see the video, it will be much more clear. So now these are various studies which has been done with the PicoPress and shown that the resting pressure with this is around 20 to 30, and if you do the exercises and all, it really provides a very good working pressure. Now there is something called as strap extenders also. So we have used only twice and it was very useful. If your thigh, the patient initially had a very big thigh and you use the largest compriflex and you still need more. So you can use this extender and actually extend that by 10 centimeters to put the pressures on. So even in the very big thighs, you can use it. And once the swelling goes down, you can just remove this extender and use the wrap as a normal thing. So I'm just going to play this video. So this is around 1.5 to 2 minutes. And exactly you will know how to apply this. So you wear it just like this. So, it just sticks there. It doesn't fall down. And you see the straps on both sides, they are rolled over. So the patient has got very easy to wear it. So once you wear it, so then you just apply, you can see the straps, very gently you close them on the sides, just like that. Just open them up, wrap the straps around, and there should not be any gapping. So once you have done that, now you can take an AccuTab, and just apply at the end of each straps like this. It sticks really very nicely. And on each strap, so you can go up to very high pressures. It's very self-explanatory. Now you stretch the strap up to the prescribed dosage. Let's say you want 30 to 40 millimeter mercury, you just stretch it up to that point. But don't cover the numbers. So you need to stretch only up to that line. So the edge of the strap should be at the line of the AccuTab. So you can just do that. So it's very, very simple. So patients can do it themselves. And if you know that you're going to have only one pressure and these tabs, they don't look nice coming out of that, you can cut them and can have only that pressure what is required, just to make it look better on the leg. So it's just a simple thing. So, you can cover the whole strap and it's hidden behind and so you don't see it. So, the last few slides. So basically, Comproflex standard calf. You can use a liner. I'm just putting it again once again. Or you can use this calf one. You can combine it with the foot. So, calf and the foot can be combined together with the AccuTab. You can combine with a transitional liner. Transitional liner where at the ankle level, you need a higher pressure, but 10 to 15 millimeter mercury. You can also combine it with the thigh. And thigh is really very, very useful because no stocking stays there. And it just keeps on falling. So we have used thighs in really a lot of DVT patients. And because when they, had a massive legs and nothing works there, and these wraps have been really very useful. And then you can use it on the knee, and it also provides a good compression. So now we come to the last part, arms and all, whatever it is. Now, how do you take care of the wraps? So there are a few things which we have to give it because they are expensive. So the care of the wraps is important, and if the nurse can explain to the patient's attendants, so these wraps that can last much longer. So basically, you should close any loop tabs which are there. Always try to use a laundry bag if possible. Use a gentle cycle with a mild detergent. You don't use bleaching powders, and do the washing at a low temperature. And dry on a low heat and air dry. And, of course, we wash the liner after every use. Now, the last 4 slides are on the measurements. Now, this is an important concept. I'll go both the 3 ones, foot one, all the 4 ones. So let's see the calf ones. So there are 2 things which you have measured. One is the length and one is the diameters. Okay. So the length, all the measurement has to be on the lateral aspect of the leg. So not on the medial aspect. And there are 3 basic points which you need to know. So one is the fibula head, one is the lateral malleolus, and one is the gluteal fold. So this is like, you can see 2 finger behind, you can see the fibula head very easily, lateral malleolus is easy, and gluteal fold you can see very clearly. So these are the 3 things which are very important. So the length one, if you want to do the calf ones, it's between the lateral malleolus and the fibular head. And then you do these 4 measurements on the calf. So, at 5, 15, 25, and 30 centimeters from the lateral malleolus. So once you have these 4 diameters, once you have the length, that gives you what calf, wrap, what you require. Similarly, in the foot, you measure the A and the Y. A is at the metatarsal head, Y is at the ankle and the heel, and A1 is from A to Y points. So you have the lengths, you can see small, medium, large, extra large, what you require. Similarly, in the thigh, you need to have another point is top of the patella. So top of the patella, you just take it from here and do the measurements here up to the gluteal fold. So it's very straightforward, and then you require 3 circumference measurements at 5, 15, and 23 centimeters, and that gives you what thigh wrap you're going to use. Similarly, on the knee, from the top of the patella and the fibula head, just take 5 centimeter top and 5 centimeter below. So you've got 2 measurements that gives you what knee wrap, what you require for your measurements. On the arm side, do the measurements so you take it on the table and put your hand like this. And then measure at the wrist level, at this level, this mid arm, and at the axilla level. And then you can do the measurements up to mid axilla point where you have taken the measurements. So that normally gives you, there are 3 different types, short, regular, and long ones, and can give you a very good measurements for the arm. Now, just put in a few slides, just a thought process, putting in a stockings here. What we call as normal stockings, what you find in a box, circular knit stockings, you can't fit in. You can use either a flat knit wear, which I told you what it is, or you have to use wraps or the bandages. Now, another very difficult case, flat knit or wraps. In this case, I put in this picture because you can use both. And actually talking, if you don't have to cover above knee, then you can also use stockings In this case also, because it's not a huge amount of difference in the edema. So you can use 2 stockings to increase the compression because it's a lymphedema. So you can use 2 compression stocking, one over the another, to increase the compression if you have to. So these are practical patients of ours, clinical pictures. Severely arthritic old age guy, severely obese patients. Now this is a patient video which I made like a month ago. One of our patients who was so fed up with Velphor, he said, I cannot have a 4-layer bandage. He had a venous ulcer, post-PTS, and he said, is there any other way? So he ran away from us. 2 months later, he came back, doctor, is there any other way by which can use compression? So we gave him this, and he does it manage himself. So he comes after 3 weeks and shows the wound if anything's to be done. And, it takes like 5 minutes of training. He uses the wrap. He's been using it for nearly 2 months now. So you've given him an inner liner. And there is a venous ulcer below. So he takes care of the venous ulcer, wash it up, clean it up, take care of the skin, and puts in the bandage, puts in the liner, puts in the wrap. So basically, if the patient is from very far off, then it's very difficult for me to call him every 6 days for change of the 4-layer bandaging. And so these type of things for the patients who are, I'm not accessible or they are not accessible to me, wraps really works. And small venous ulcers, then 4 weeks later we do an online consult with them and they show us the photographs, and if we have to chase some medicines or wraps, it really works for us and for the patients. Thank you. Any questions there, please? Okay, if there are no questions, I hand. Sorry, sir? Yeah, yes, I agree with that, and we need to work on the scientific aspect of that. What Roy is saying that we should have Make in India wrap, and I think we need to work on that angle if somebody wants to work on it. Dr. Malay Patel, please. Yes. Yes. So we did one study in India with Professor Ul and Dr. Bengani. So that's the only study published from our country. Is there any difference in the foot and the calf of Asians, of the Indians, as compared to the Western people? And what we did, we took the data from Sigvaris, Medi, and one more company, and compared the sizing and the foot sizing what we have in our country. And we took 400 patients, random patients, males and females of various age groups, and did various sizings of the groups. Basically, in nutshell, in conclusion, what we found was more than 35% of the available on-shelf stockings which are available, they are not fit for our country. So, so this is the basic study. So definitely we need something to be done. Sorry? And the weather, of course.
Hi, sir. Regarding stockings, there are 3 problems that I have encountered. Problem number 1 is, as you rightly mentioned, putting it on. Problem number 2 is the size difference. North Indian patients also do come to me because I go to Cochin. The ankle size is very narrow. As you go up, it becomes a champagne leg. And the third and the most important problem that I have faced is nobody wants to wear it after 2 weeks.
After?
2 weeks.
Yeah.
Hi, sir.
Oh, sorry.
From this side.
Yeah. Hi.
So, when you use an isolated calf, this device alone, how often do you see pedal edema in patients, distal to the...
No, you don't get, na? Because basic concept is, if you put in an inelastic thing, you know, the foot edema will happen if the venous return is not good. So if you put in an inelastic, everything depends on the calf pump. Okay, so if your foot does not have encephaling, we are not talking about lymphedema now, we are talking about venous.
Yeah, but
So,
still, when there is a tight compression at your ankle level, there will definitely be...
no, where ankle level we don't have. This wrap comes only above the ankle.
Yes, distal to the ankle is what I'm asking. Distal to the ankle in the foot, do you see any...
No, you don't get. That's what I'm saying. So if you put in any inelastic bandages or any inelastic thing on the calf, and your venous returns becomes very good if you walk around, then you will not get foot edema. That's a basic thing, you know. Dr. Pataria, please.
Regarding that earlier question,
Yes, please.
it's a practical problem.
Sir, mic is not working.
Sorry. Yeah, so regarding the earlier question, I'll take it a little further. Yes, this problem of foot edema is quite prevalent. One, with stockings, secondly, with 4-layer bandaging or any other compression therapy.
With that, it happens.
The reason basically being that the pressure that we give at the upper edge of the calf is much more than the pressure lower down. And that basically impedes the venous return. We have some limited experience with the wraps. And the earlier times when we started with the wraps, we also realized we were getting a little bit of pedal edema on the dorsum of the foot. Then we realized that when they're actually making when they're tightening the Velcro, they should be taught that the Velcro should be tightened more lower down towards the ankle and slightly looser towards the upper part of the calf. This promotes the venous return easily and prevents ankle edema.
Yeah.
I pointed this out to the Sigvaris people also, and they said that the proper putting of that
AccuTab, yeah.
is very, very important.
Yeah.
Otherwise, if the same pressure difference is there between the ankle and the calf, then pedal edema doesn't.
Yeah. So basically, you see, one should, this lecture was very important for, I feel, the people who are using the wraps also, they don't know about the AccuTab. That's why I asked this question. Because anything which you want to use, please, you need to get trained in that. So if you're just going to pick it up and just start, it's just a wrap-like thing, and you will not go the science behind it, then you will have a problem. Sir.
Rahul, instead of asking self-application, we can do somebody to apply, because as my colleague said, keep the limb elevated for half an hour.
Yes, sir.
In that position, if they apply the angle pressure, angle tension will not be there.
Yeah.
So there won't be any pedal edema will be.
Yes, sir,
So
absolutely.
self-application.
Absolutely.
Second thing, you must, I recommend to Rahul, to have the price down, because the patients we get more is economically little lower down people.
Yeah, sir.
So this costs somewhere around 7,000 to 8,000.
Yes. So we also, that was the first reason we delayed for 1 year to use them.
Yeah.
So economics is a problem, and because unless you are convinced, you are not able to convince a patient. And actually patients forced us because to start using them, and when we start using them, then we realized that it can be cost effective, and because there were patients who were like from Himachal hills, they travel for 12 hours to reach us, and now for the 4-layer bandaging ulcers, now we don't see them for 3 months, 2 months, and so the traveling cost, one trip costs like 7,000 rupees, and 4-layer bandaging every 6 days if you put in for 1 month, so that costs like 7,000, 6,000 rupees. So if you calculate the costings like that, actually talking the wraps will be much cheaper. So that's why our uses in the wraps is going up and up, because we are finding, because we are ourselves trying to find where we can use them, and wherever the patients had difficulty, where the patients, we can save the money. Actually talking, we are working now the other way around. Yes. So like we are making the cheaper for the patients.
It's really a better process, but we must convince the patient.
Yeah.
Rahul, here.
Yeah, sorry.
Roy said 2 weeks. Actually, I used one of the crib bandages given in a conference, and I couldn't tolerate for more than 10 minutes actually.
Yeah.
And I remember one of my consultants when I used to work in UK, he underwent a varicose vein surgery, and he, is a very experienced man, and prescribing everyone stocking. He himself couldn't tolerate stocking for more than 2 weeks. So some of the questions I want to ask you is, one is, have you, one problem you said is, difficulty in putting the stockings. One way I found going around this is using the stocking applicators. Have you used stocking applicators?
Yeah,
Like
we got all of them.
the metal bed?
Yeah, of course.
I find it quite useful. That's
It's, but you see, it's not useless. We use it, and not everybody is able to find afford Sigvaris donors. But if you can afford, if you use a Sigvaris donor, the stocking goes on your leg like a seconds, and you also have to get trained in that. It's not that you just pick it up and you will be able to use it. No, but we regularly use Sigvaris donors, so it's very nice if you know how to use it.
Okay.
Sorry?
One leg which you showed, like the overhanging lymphedema.
Yeah.
They have this severe, the intertrigo problem. How do you, because whatever you try to do, that hanging piece of flesh is still there.
You see, that's what I'm saying. That's the biggest problem. And what we are using is, this lymphedema bandages, which we have that box. So in the initial part, I put in that statement. So in the initial part, we don't use anything. So we try to put in the steroid creams, clean it up, definitely, and put this bandage. And this patient comes every 48 hours to us to change the bandage. So they remove the bandages at home, wash it up, clean it up, dry it up, and then they come to the clinic. And then we do the bandaging again for 3 days. Within 10 days, we found the swelling goes down to 30%. And then we change either to wraps or stockings.
What is the lifetime of these wraps?
Lifetime.
How long do they last?
That's what I'm saying. One of the patients has been using wraps from 2 years. But we don't tell anything like that to the patients because he will start eating my head. But most of the patients has been able to use more than 8 months. We close. Yeah. Thank you. Sorry. Hand over the mic to you guys.
Thank you so much, Dr. Rao. We would now like to move ahead to our next session, but just before that, those of you who are participating in the nursing CME, which starts from 2 p.m. onwards, you're requested to carry your allied health papers right there and join us at Hall B. We would like to move ahead to our next session. I'd like to invite on stage our chairperson, Dr. Harinder S. Bedi, to please join us on the stage. Please welcome him with a round of applause. Looks like after lunch the applause has come down. I thought it would be better. Thank you so much. I'd like to invite our panelists, Dr. Hussain S.A., Professor M. Rajkumar, Dr. Chandrasekhar. May we have you with us. I'd also like to invite Dr. Pranay Pawar and Dr. Raja to please join us on the stage. I repeat, Dr. Pranay Pawar and Dr. Raja. Session 4 is on the topic, troubleshooting in thrombosis. Over to the chairperson. We'll hand over the coordinates if you want to.
Thank you. That's a very important topic we are going to discuss, troubleshooting in thrombosis. I call upon Dr. Majid for talking on treatment after DVT. Very important. What next? Dr. Majid.
Thank you for inviting me to this great meeting. I have no disclosure. First, anticoagulation after DVT is recommended for 3 months if the patient doesn't have any irreversible risk factor. But if the DVT is large or there are some residual symptoms, it is recommended to extend it to 6 months. And in 40% of these patients, the PTS develops, which is severe in 10%. And the Villalta scale is the best scale to assess PTS because it covers both symptoms and signs. And there are similarities between the signs and symptoms of DVT and PTS. Because of that, it is recommended PTS not diagnosed before 3 months. And there are some risk factors for PTS development. DVT location, I mean proximal or distal one, is not a reliable marker, but the persistence of residual vein thrombosis with can be assessed by ultrasonography, and also inadequacy of anticoagulation are important factors for development of PTS. And there are some models developed by some studies to predict PTS based on iliac vein involvement, BMI, and Civita-Villalta, but they need external validation. And residual vein thrombosis and reflux can be assessed by ultrasonography and has a role in they have a role in the prediction of PTS. And CDT, in comparison with systemic anticoagulation, there is no strong evidence to support that. But for DUAC, they are as effective as and safer than warfarin, and they are associated with lower incidence of residual vein thrombosis. So they may have a better prognosis in terms of PTS development. But rutoside and other herbal medicines, they doesn't work. Venoactive drugs have a role in the management of some symptoms nowadays, according to two reviews. Pentoxifylline has been known as an effective drug for venous ulcer, but its effect on other signs and symptoms is not clear. Elastic stocking doesn't work, highly controversial for PTS prevention. I mean, after DVT for prevention of PTS. But if PTS develops, it has a major role in the treatment of symptoms, especially edema, because edema cannot be treated by venous stenting. So according to reviews, compression in acute phase of DVT does not significantly lower PTS incidence, and long stocking in comparison with the below the knee stocking did not provide better protection, and they don't improve quality of life except during the first 9 days. They have some side effects which are not so important, but they have a major role in the treatment of PTS symptoms, especially edema after PTS development. And the last one is the venous stenting introduced by Professor Raju for CVD patients. They have both obstruction and reflux, I mean this valve dysfunction, and it is important to know that venous stenting or treatment of obstruction alone has any effect of the symptoms or the function of the valves. And to address this question, Professor Raju selected 32% of his patients with both of them obstruction and malfunction of the valves, and he saw iliac vein stenting alone significantly improved the clinical outcome in those patients, even though the deep reflux component was left uncorrected. Improvement of pain and ulcer healing was durable, but the effect of swelling, the effect of stenting on swelling is not significant, which can be treated by elastic stocking. So according to reviews, stenting in PTS is useful and can alleviate symptoms, and the edema can be tolerated by the patient if he or she doesn't have other symptoms like pain, and also it can be treated by elastic stocking. Conclusion, ladies and gentlemen, duration of anticoagulation should be based on risk factors and severity of residual symptoms. PTS not diagnosed before 3 months. CAP classification is the most common, but the Villalta scale is the best one for PTS assessment. DUAC are as effective as warfarin or maybe better in terms of PTS development. Venoactive drugs nowadays may have a role in the treatment of some symptoms. Elastic stocking play an important role in the treatment of edema after PTS development, but for PTS prevention, it's not clear. And venous stenting may have a role in those patients with obstruction or stenosis of the iliofemoral veins. Thank you for your attention.
Thank you, Dr. Majid. We'll have questions at the end, so if you can stay with us. I call upon Dr. Sukesh Chandran Nair to speak on dilemmas in thrombosis, dealing with sticky situations. So that's an interesting topic. The slide changer, please.
Right. Thank you. Thank you, sir. Thank you for the opportunity for the Venous Association of India for inviting me. We have a good peer group in India which do a lot of tests related to thrombosis. So some of them are highly revealing for you today. Suppose you have a result which is LA positive, and some of the thrombophilia markers come as positive, that is antithrombin is low, protein C and protein S is low. I can tell you that 90% of them are false positive. 90% of them are false positive. And the reasons for that, the lupus anticoagulation, there is a recommendation for doing the test. There is a phospholipid-based test like APTT is prolonged. Once it is prolonged, it can be because of many reasons, but to show that there is lupus anticoagulant effect has to be demonstrated. That is, you have to do mixing with normal plasma to show that the anticoagulant is also going to make the normal plasma abnormal. Then, of course, the confirmation is you add extra phospholipid and neutralize that. None of the labs in our country are doing mixing with normal plasma. None of the labs in our country are doing mixing with normal plasma. Now, the reason for increasing false positivity in lupus anticoagulant is because there is increasing false positivity. Then the issues are patient is on anticoagulation. We are not sure whether the information is provided to the lab to interpret the results. And there's something called the lupus cofactor phenomena. Now, the reason why a lot of false positivity is happening is because they don't do the second step. That is, the anticoagulant effect is not demonstrated, because most of the kits which come for lupus anticoagulant testing, they do not mention in their algorithm the mixing part. So the lab will do the first step, the third step, do the ratio and give the result. They will never demonstrate the anticoagulant effect. So if the patient is on anticoagulation, he's on warfarin, but the results for lupus anticoagulant will come as positive. That's because they don't do the second step. Now, we know that anticoagulants do affect lupus anticoagulant testing, like unfractionated heparin. Sometimes low molecular heparin can also affect. DOACs for sure they will affect. So that information is very important for the lab to have. Vitamin K antagonists, fortunately, they are only reducing the functional activity of the vitamin K dependent factors. So normally you can overcome that by mixing the patient's plasma with normal plasma, which basically means the second step is already happening. So that's what the recommendation. Even if the patient has got an INR of 3, you can still go ahead and do lupus anticoagulant testing. Because you may have been given a rule that do this test at this particular time, don't do this test at that particular time. So if the patient is on vitamin K antagonist, you can still do lupus anticoagulant testing. Then there's something called the lupus cofactor phenomena. So when you mix the patient's plasma with normal plasma, apparently the normal plasma will provide some cofactor. Maybe it is beta-2-GP1 or maybe it is prothrombin. Therefore, whatever abnormality you got in the first plasma, the abnormality becomes higher after mixing with normal plasma. So that means mixing with normal plasma is very good. So we are talking about abnormal becoming more abnormal. What if a normal can become abnormal and reveal the lupus factor? So how do you overcome this? We have in CMC, so thing is, this is a problem with our country. They are following kit algorithm. So we have started doing, let's start with mixing. Don't start with patient's plasma. Mix with normal plasma, let's start with that. If the mix test is abnormal, then you proceed. So once the data comes out, we'll publish the data and hopefully you will start getting less false positive results, not less. We'll eliminate false positive results for lupus anticoagulant. Now coming to the thrombophilia markers. Thrombophilia markers, we have repeated many thrombophilia markers which have come as positive in your patients. And when we do it, we find an opposite result. So there are a lot of pre-analytical issues, transportation issues, all those issues are there. But how can you overcome this sticky situation? It's very easy. Like lupus anticoagulant needs to be confirmed after 12 weeks to overcome all the transient lupus anticoagulant, you can only confirm a deficiency of a thrombophilia marker if the second sample also is low. So you cannot make a diagnosis of antithrombin deficiency on one test. On a repeat test, if antithrombin is low, then only you can say that this person is antithrombin deficient. And whatever said and done, thrombophilia markers have been proven to be not very useful in management of patients with venous thromboembolism. In fact, our brilliant Dr. Sunil Agarwal, he was probably the first person to stop ordering thrombophilia testing. So, would you have a test which can predict recurrent thrombosis? So, we all know this article, D-dimer, 1 month after stopping anticoagulation, if it is more than 500, this is a beautiful article, all of you have, and it's been reproduced many times. You stop anticoagulation, 1 month later the patient comes, you do the D-dimer. If the D-dimer is more than 500, continue the anticoagulation. So that was one particular lesson that was learned from this article. But the patient has to come 1 month later. Then this article came, which was a study was done over 15 years in Norway, where they said that D-dimer at presentation can also predict recurrent thrombosis. So this is the data on patients, good number of patients. So they divided the patient into 4 groups, more than 1,500, not 500. I mean, some people use 500, some use 0.5. Both are, obviously depends on what is nanogram per ml or what. Let's use 500 as a unit. So if the patient comes with more than 500, yes, chance of thrombosis is there. But if the patient belongs to the group more than 1,500 and the other which are really high, so they found that there was a higher incidence of recurrent thrombosis in those who had more than 1,500 D-dimer, especially in the unpro group and incident DVT group. Very high incidence. So it is very useful to do the D-dimer at the time of presentation. So this is you see all the top half is actually the more than 1,500 group and the lower half is the less than 1,500 group. So you have to do D-dimer when the patient comes. Why is D-dimer not being done? Nobody orders a D-dimer. Even, sometimes vascular surgery in our hospital, pulmonary medicine in our hospital, rheumatology, they don't order a D-dimer when the patient comes with suspected venous thromboembolism. You are denying a patient a chance for preventing recurrent thrombosis. Okay, there is a reason for not ordering D-dimer. It's not easily available. A good D-dimer is not easily available. In fact, an ultrasound or a color Doppler is more easily available than a D-dimer. But things have changed post-COVID. There was a target called D-dimer. It was a deviation, but not a specific target. Now D-dimer is available in our country. Before they start discarding the D-dimer from their labs, please start ordering D-dimer. Yes, they'll discard a lot of machines because after the COVID goes away. So then the other question is, why do a D-dimer? Anyway, it will be quite high. Anyway, high. But that high you must realize, whether it is 500, 600, 700 or more than 1,500. More than 1,500, you can benefit the patient by a slightly prolonged anticoagulation. Okay, yesterday Dr. Roy asked me about clot with high HP, therapeutic phlebotomy. But if the patient's white cell count and platelet count goes up high, then it's better to refer to a hematologist. The other information that came out during COVID is that many people were put on anticoagulation and anti-10A levels were being measured. There is something that you need to keep in mind when you measure anti-10A. In certain patients, you cannot use APTT to monitor heparin. You cannot use, like especially when the acute phase reactance is high, it will not respond to APTT. In obstetrics, you cannot use APTT. You have to do anti-10A. Even if you're doing anti-10A or heparin levels for heparin, for monitoring heparin, please understand the sample has to reach the lab within 1 hour. The sample has to be processed within 1 hour. Otherwise, you'll be underestimating the heparin. So that is one good thing that Vellore learned during COVID time. That is, yes, they will tell me that the heparin was given at this time, whether it was Clexane or whether it was unfractionated heparin, it was given at this time. The sample was collected between 3 and 5 hours after the dose, and the sample reached the lab at this particular time. So that was important for us to interpret. If that timing, that information is not available, we'll say that aapke haath mein. Now in CMC, anti-10A assay has become so good that we are not worried about it. Patient on Clexane developing bleeding. I think today there was a question for Dr. George Joseph. If the patient develops bleeding on anticoagulation, what do you do? Of course, you stop Clexane. But in our place, when they say that patient needs to be still on anticoagulation, and they call me and say that should we do an anti-10A assay, and we need to still continue anticoagulation, I said that why don't you change to dalteparin? Because dalteparin has lesser bleeding risk compared to enoxaparin. Because of this simple study which was done, came only as an abstract. They didn't allow the publication to happen. Clexane has higher anti-10A, which is a bleeding risk compared to anti-10A action, anti-2A action, while dalteparin has higher to anti-2A action rather than anti-10A action. So this is some advice that we give our patient. Thank you very much. I took a little extra time.
Thank you, sir. I call upon Dr. Pratap Kumar, thrombophilia in DVT management.
Good afternoon, one and all. I thank Vycon 22 for providing me with this opportunity. My topic today is thrombophilia and DVT. So, as you all know, thrombophilia is nothing but it is an inherent ability of a person to form clots inappropriately. That is the definition of thrombophilia. And the first major thrombophilic disorder was discovered in 1965. That was the antithrombin deficiency. But the most common abnormality is the factor V Leiden mutation. So this is a very important tableau column which shows the congenital, acquired, situational and combined forms of thrombophilia. What we have to understand is that the factor V Leiden mutations, the prothrombin gene mutations, antithrombin deficiency, protein C and protein S, they are all congenital thrombophilias and they are high risk thrombophilias. Whereas some thrombophilias like hyperhomocystinemia, they are classified as low risk thrombophilias because this has an effect on the management of such cases. The basic pathology is between an imbalance between a clot production and a clot breakdown. So all the congenital thrombophilias, there is a decreased clot breakdown, whereas in prothrombin gene mutations, there is a gain of function mutation. There is a prothrombin excess and there is going to be an increased clot production. And this is a very important point. Genetic thrombophilic defects influence the risk of a first episode of thrombosis. For example, if I have a factor V Leiden mutation, the chances of me getting a DVT for the first time, it is influenced by genes. But the subsequent or the recurrent DVT is not influenced by these genetic factors. That is the point of this slide. So as you can see, the prevalence of defects in patients with venous thrombosis, all the congenital thrombophilias that I was talking about, they have a relative risk of around 10%, whereas those with acquired or situational thrombophilias, it is around 5%. And you can see on this slide that the risk of recurrent venous thromboembolism in thrombophilia compared to VTE without a thrombophilic defect, it is reversed. That is the second risk, the risk of developing a recurrent DVT is not influenced by these genetic factors. The other predictors of recurrent VTE are idiopathic VTE, residual DVT, elevated D-dimer levels, age and sex. So some important points about this antithrombin deficiency, it is the most thrombogenic inheritable thrombophilia, and in protein C deficiency, you must remember that protein C deficiency causes thrombosis when the levels drop below 50%. Protein S deficiency, whenever there is an atypical presentation in any patient, for example, a migraine or a mesenteric venous thrombosis or a neonatal porphyria fulminans, suspect protein S deficiency in such cases. So normally, the normal coagulation pathway, it will produce thrombin. So the effect of protein C and protein S is to inactivate factor 5 and 8. So whenever there is a protein C deficiency or a protein S deficiency, this inactivation of factor 5 and 8 does not happen. So that is the basic pathology of any thrombophilic state. So as I already mentioned, factor V Leiden is the most common hereditary hypercoagulable disorder. It was named after the Dutch city of Leiden, and it was discovered by Bertina. And prothrombin gene mutations are very important because the mutations, they cause a 30% increase in the prothrombin levels. Antiphospholipid antibody syndrome is very common in thrombophilia testing, and as already mentioned by my previous speaker, it is based on the clinical criteria as well as the laboratory criteria, and you have a condition which is called as triple positive antiphospholipid antibody syndrome. In that case of a triple positive antibody syndrome, you will have arterial thrombosis as well. So these are the basic cells which are affected in the antiphospholipid antibody syndrome: the endothelial cells, the monocytes, and the platelets. And these are the clinical and the laboratory criteria for antiphospholipid antibody syndrome. The blood test, that is the venom, Russell Viper venom test, which was discussed by my previous speaker, and the APTT is usually prolonged in such cases. And patients with thrombosis, we need to maintain on anticoagulation with an INR of around 3. And anticoagulation is usually long term in such cases because the risk of thrombosis is 50% at 2 years after discontinuation. And thrombophilia in pregnancy is very important because it can cause abortions, intrauterine fetal deaths, and pregnancy-induced hypertension. And all these factors, they can contribute to the thrombophilia in pregnancy. When do you decide to test a patient with thrombophilia? So these are the guidelines for thrombophilia screening according to the American Venous Forum, which is given in all books. And these are the commonly ordered tests for thrombophilia, especially the factor V Leiden, prothrombin, protein C, and protein S. And this is a very important slide. So the congenital thrombophilias that I was talking about, they all have a propensity to cause venous thrombosis, whereas hyperhomocystinemia and lupus anticoagulants, they have a mixed arterial and venous thrombosis picture. So you have to stratify the thrombophilia into weakly positive or weakly thrombophilic patients and strongly thrombophilic patients. When the age of onset is going to be less than 50 years with a recurrent thrombosis and a positive family history, they are all strongly thrombophilic patients. So do we need to routinely screen all patients with thrombophilia? It is not justified, but the risk of subsequent thrombosis over a 5-year period in men with an idiopathic VTE is 30%. So the screening evaluation for strongly thrombophilic patients should include all these tests, whereas those with weakly thrombophilic states, you must test for factor V, prothrombin, the plasma homocysteine, and for lupus anticoagulants. The timing of testing is also very important. For protein C, S, antithrombin 3, and lupus anticoagulant, you have to wait at least 4 weeks after stopping warfarin, at least 24 hours after stopping rivaroxaban or apixaban, and at least 8 weeks after the most recent miscarriage. But it can be done anytime in cases of genotypic testing for factor V Leiden and prothrombin gene mutations. So as already mentioned, the samples should reach the laboratory within 4 hours. And the algorithms for screening is whenever the DVT is provoked by a trigger, you have no role for testing. But whenever there is an unprovoked DVT or DVT at unusual sites, or it is provoked by a weak trigger with a positive family history or a female in the childbearing age group having a thrombosis, you have to order testing. So what we have to remember that antithrombin 3 deficiency, protein C and protein S, they are not reliable in the presence of acute thrombosis and in the presence of anticoagulation. And the treatment basically is by means of anticoagulants, and there are parenteral and oral anticoagulants. Now this is the clinical scenario. If you have an acute thrombosis, you usually go for anticoagulation for 3 to 6 months. But in the presence of unprovoked thrombosis or a concerning family history with multiple inherited thrombophilias, a life-threatening thrombus in a male sex patient with atypical thrombus location, consider indefinite anticoagulation. And the use of direct oral anticoagulants in inherited thrombophilias has been extensively studied, especially rivaroxaban,
It has been studied in antiphospholipid antibody syndrome, in triple positive antiphospholipid antibody syndrome, and they have found that the use of DOACs was associated with a lower 2-year risk of VTE recurrence after anticoagulation discontinuation. And this is the last slide. They also suggested that DOAC use is or can be done in low-risk thrombophilias, especially factor V laden and prothrombin gene mutations, but its use in high-risk patients such as the triple positive APS or in the presence of arterial thrombosis is questionable. Thank you for your patient listening.
Thank you. We have the last speaker, Dr. Manish Rawal, speaking on a new entity, that is thrombosis in COVID. Lessons learned. Over to you, Manish.
Good afternoon, my colleagues. Thank you for inviting me for this talk, seniors and my friends. The subject that I'm going to talk about is the outcome of catheter-directed thrombolysis in COVID-19 associated deep vein thrombosis, our experience. So this was a number of cases that we treated during the second wave of COVID, and this was done in association with very esteemed and very good friends, Dr. Sunil Rajendran, Dr. Edwin Stephen, and myself. And it was done at 2 different places. And we analyzed the data, and we had some findings which suggested that, okay, we can manage deep vein thrombosis, COVID or non-COVID associated proximal DVT in a different way. So published evidence of venous thrombotic complications of COVID-19 is lacking. And India, as we know, we had number of cases or such high number of cases that we had no tool or no groundwork to prepare us for the study of the incidence of deep vein thrombosis in any way. This case series consists of 29 adult patients who were COVID-19 positive and treated for deep vein thrombosis during the second wave of the COVID-19 pandemic in India. Study was aimed at analyzing demographics of the patient with DVT and the outcome of catheter-directed thrombolysis in COVID-positive patients. We analyzed data of 29 patients who presented with DVT during a 3-month period, who were managed with either CDT plus anticoagulation or with anticoagulation alone. The experience and observations in this case series is shared while stressing on the need for compiling a larger series before drawing a definitive conclusion about the management of COVID-associated DVT. Patients who developed DVT while or after being COVID positive were managed between February and April 2021 at the institution of the first 2 authors and were included in this retrospective study. Demographic, clinical data, laboratory data, and treatment given were analyzed, and all patients were followed up for 3 months with a Villalta score. There were a total of 29 patients, 12 male, 17 female included in this study with a mean age of 47 plus or minus 17 years. Average time of presentation from being COVID positive was 17 plus or minus 3 days, and 1 patient developed DVT after becoming COVID negative. All but 1 patient had lower limb involvement, with 42 or 43% having proximal and 57% having distal deep vein thrombosis. All patients with iliofemoral and 2 off femoropopliteal DVT were treated with catheter-directed thrombolysis, and other 15 were managed with anticoagulation alone. No range thrombosis was observed in the thrombolysis group. Overall average Villalta score at 3 months was 10.7 plus or minus 2.1 with a score of 10.58 plus or minus 2.1 in the anticoagulation only group against 10.85 plus or minus 2.3 in the CDT group. This is the table showing, it's a very busy slide, but that reflects on the patients that we treated or included in this study. Again, this is a Villalta score of patients treated with anticoagulation alone and with CDT and anticoagulation. So what I wanted to talk about or discuss about, I don't know, in first wave or the second wave, we started seeing a bigger number of patients during the second wave, having deep vein thrombosis, proximal deep vein thrombosis, having complications of proximal pulmonary embolism and many other thrombotic events. So we understood that considering the use of CDT for all with COVID associated DVT, iliofemoral DVT, and those with femoropopliteal DVT who have significant edema or impending venous gangrene, if the bleeding risk is within acceptable limits, these patients can be offered CDT. We have a specific way of doing catheter-directed thrombolysis and the thromboaspiration. The technique has been developed by, in association with many colleagues, in association with even Dr. Malay Patel sir. So to conclude, COVID-19 seems to be an additional risk factor in the development of DVT. Outcome of such patients treated by thrombolysis appears to be similar to non-COVID patients. In this observational experience of the authors, we do suggest that CDT could be offered to COVID positive patients with a symptomatic iliofemoral DVT with good outcomes and an acceptable post-interventional Villalta score. We are happy that this study was accepted for publication in Vascular and Endovascular Surgery year 2020. Thank you so much for this opportunity. Thank you.
Thank you for the excellent talks on the speakers. Open to comments and discussions, firstly from my co-panelist.
Question is to the last speaker. Manish. Good afternoon, how are you? I would like to ask you, in what way the DVT in a COVID patient is different from the COVID in other non-COVID patients? DVT in a COVID patient, in what way is it different from DVT in non-COVID patients?
Manish, you are muted.
Really, but if I have...
Okay, we hear you now.
In COVID patients, there's in situ immunothrombosis. In other words, when the entire endothelium is inflamed, so they are more prone for DVT and even arterial thrombosis. So that's one of the reasons why we advise DVT prophylaxis even in a patient who's asymptomatic in COVID. We've been doing it in Chennai, and the incidence of course DVT is lesser. I wouldn't say it's lesser than non-COVID, lesser. So this is a different pathology altogether. This is what I wanted to tell you.
Yes.
Just a question to the hematologist from CMC Vellore. See, we all saw a lot of COVID-induced thrombosis. Some of them are accidental finding after a couple of weeks, a couple of months later. IVC thrombosis, iliac vein thrombosis. In these kind of cases, how long to give anticoagulants? The same like before, or is anything different in post-COVID patients?
Dr. Sukesh. Yeah.
Sir, we also know that COVID, the D-dimer levels are going to be slightly different from normal people. So nobody has done a study what should be the right cutoff. Arbitrarily, they said maybe 3,000, not 500.
So we are not sure about the ideal cutoff for in a COVID situation. So we are lost. That's right. Yes. So, yes. 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 So, sir, you can try the NEJM article. Okay, okay, fine. Yeah. Yes. So thing is, we can probably try the NEJM article. After 3 months, you can stop and try D-dimer. Maybe, there's no information. No, not clear. Not clear. Not clear. Not clear. Maybe at the time, after your regular time of recommended anticoagulation, maybe good idea to do a D-dimer. And if the D-dimer is not more than 500, we'll go down. Yes, for sure. We'll go down. But there are some people who the D-dimer doesn't go down. There are some people where the D-dimer doesn't go down. Yes. Yes. That's right. There is, in fact, the cutoff itself is not very clear.
Thank you, Dr. Sukesh. Yeah, probably the answer is indefinite. And Dr. Pranay.
Sir, I would just like to ask you one more question. So there was an excellent talk, sir. So one of your slides, so you had said that...
1 second, doctor. Let me explain. Extended thromboprophylaxis in surgical patients is very, very clear. But extended thromboprophylaxis in medically ill patients is not clear. The FDA has given approval only for apixaban and rivaroxaban over a period of 6 months period. But otherwise, extended thromboprophylaxis in medically ill patients is still under investigation. So this falls under that kind of case. COVID-induced thrombosis comes under medically ill patients.
So one of your slides, Heparin, you had said that APTT is not this thing reliable test to monitor it.
So there's something called laboratory resistance to heparin.
Acute phase reactants are high.
Like factor VIII is like an acute phase reactant. If the factor VIII is very high,
okay, you look at those
it will
levels.
bring the APTT down, even in a normal person also. So, I mean, it will be shortened APTT. So, obviously, when you try to give heparin and use APTT, it will not. In fact, the recommendation for COVID, if the patient is on unfractured heparin, was anti-10A assay, not APTT. It was very clear. And sir, medically, as you said, medically, this thing, for example, pregnancy, it is clear. The cutoff is not 500. It is, some places use 600, some people use 3,000. But that also, there is no uniformity.
Yeah. Thank you, Dr. Sukesh. Dr. Majid, are you there?
Hello?
Dr. Majid?
In all the in all the COVID patients.
I'll take your question. Dr. Majid?
Yeah, I'm here. Can you hear me, sir?
Yeah, you had shown us that compression garments after DVT do not reduce the incidence of PTS. So what is your current recommendation for compression garments post DVT?
You mean wraps or just elastic stocking? You're talking about wraps or just elastic stocking?
Yeah, what do you recommend? Should they use it or not use it?
Yeah, we just use elastic stocking for them just below the knee if the patient feels comfort, because we don't have any evidence to support using elastic stocking for all of those DVT patients. Just it's, it depends on the patient itself. If he or she feels comfort with below the knee stocking, we prescribe below the knee. For lung one, I myself, never prescribed the lung for DVT.
Thank you. Last question. Yeah.
In the indifferentiating with the arterial and venous thrombosis, the D-dimer was highly increased in all the COVID positive patients. That was my observation. We actually did 9 cases of arterial thrombolysis, catheter direct thrombolysis, and we had 6 cases, of which 3 were treated with anticoagulants. And the 3 patients came with, unlike to see that patient, because of the iliofemoral DVT, they came with gangrene. We did above-knee amputation for 3 cases. For other 6 cases, we treated conservatively. Today, actually, my colleague, interventional radiologist, is presenting paper in Goa in the interventional conference.
I thank the speaker and my co-panelist. Thank you.
Thank you to all our speakers for this session. We would now like to move ahead to our next session, which is led by our chairperson, Dr. Arvind Kohli. May we have you on the stage, please? Please welcome him with a round of applause. Looks like it's just the right side who are seated. They are applauding, but not people on the left. Hello again. Are you all doing great? Fantastic. I'd like to invite our panelists to join this session, and that is Dr. Velladuraichi, Dr. Shabnam Fatima, Dr. Chandrasekhar A.R., and Dr. Nupur Bit. May we have all of you joining us on the stage, please. This session is titled Unique Challenges in Anticoagulation. Unique Challenges in Anticoagulation. I'd like to request our chairperson to take this forward, and that is Dr. Arvind Kohli. Over to you, Doctor.
Good afternoon, and as the name says, it's unique challenges in anticoagulation, because we are going to listen from the speakers about the various subset of patients where all of us think many times before proceeding or maintaining anticoagulation. And straight away I'll invite Dr. Indra Agarwal. And approach to anticoagulation in children, very important. Please.
Okay. Good afternoon, and I'd like to thank the organizers for giving me this opportunity to speak amongst a forum of primarily surgeons, which is an unusual situation for me. So I think we go by that. Okay, I need to move slightly. So my talk will cover a few case scenarios, the definition of ETE, some epidemiology, clinical signs and symptoms, diagnosis, clinical management, and the duration of treatment. So I'll start with some case scenarios which we commonly come across. An 8-year-old child with poorly controlled nephrotic syndrome presented with a relapse. He had a previous history of a gastrointestinal infection just prior to admission, and the child was edematous, so he was started on diuretics. On day 4, he developed acute severe hypertension and a headache. When an MRI was done with A and V, this showed a severe extensive thrombus in the distal and the superior sagittal sinus, and which also extended to the transverse sinus and sigmoid sinus, and he was started on Clexane. The second child, a 9-year-old child who presented with a facial swelling, which was actually extending around the eyes and the neck, and was diagnosed to have preseptal cellulitis and a parapharyngeal abscess. The blood culture grew a methicillin-sensitive Staph aureus, so this child had disseminated sepsis, started on antibiotics, but on the 3rd day developed a lower motor neuron palsy. An MRI done showed cavernous sinus thrombosis. Another younger child, a 1.5-year-old child with a cyanotic heart disease, tetralogy of Fallot, also presented with a gastroenteritis and dehydration, and on the 3rd day developed left-sided seizures and decrease and paucity of movement in the left lower limb. He He had a very high PCV and a high platelet count, and an MRI done again showed cortical venous thrombosis. Another 10-day-old child came with sudden onset of anuria, and he had lethargy and poor feeding. On an examination, the child's kidneys were bilaterally palpable, and when we did a CT, we showed that there was extensive thrombosis of both the renal veins. So this child required a peritoneal dialysis and anticoagulation, but however, it did not improve. The anuria persisted, and this child was then went home DAMA with a suspected, probably inherited thrombophilia like protein C or protein S deficiency. So these are some of the common scenarios that we see in our setting in children, though not very common, but we do see them from time to time. So this definition is very well known to this august audience of venous thrombosis is the formation of a semi-solid coagulum within the venous system. And it may be superficial or deep, and of which the deep vein thrombosis is very common, and pulmonary embolism is another situation that we see quite commonly. Now, what is the difference in children? Incidence is actually quite rare. We don't see it very often, but the causative factors are often multifactorial. And the other thing is it has a bimodal distribution. It is common in neonates, and it is also common in adolescent children. And hospital-acquired VT is another situation which we see quite often associated with critical illness. And incidence, once it occurs, it increases the mortality, it increases the cost of treatment, the duration of treatment, and the outcome. And many other complications also come in, like limb ischemia, anticoagulation, associated bleeding, etc. But then why is it rare in children? Well, for one reason, they have good antithrombin activity. They have reduced thrombin generation, and there's an increased ability of the alpha-2 macroglobulin in inhibiting this thrombin. The other very important factor is that they have no endothelial damage, unlike adults who have lots of other chronic illnesses like diabetes, hypercholesterolemia, hypertension, use of OCPs, or even smoking, which would increase the risk. And unlike adults, in children, it is always provoked. So often multiple risk factors are involved. It's not only one factor that increases the risk. Amongst these, the most common is the use of central venous catheters, but along with them, there may be trauma, surgery, drugs, critical illness, immobilization, which may play a big role. Along with that, we also have congenital thrombophilias that may be there. And whenever the Virchow triad is any factor in this triad is affected, there is a risk for thrombosis. So something about CVC, central venous catheters and thrombosis, it's very common in children, especially newborns. It may be seen in 90% and 60% in older children. And the factors which predispose to this are things like chemotherapy, TPN, long-term antibiotics, and infection itself can damage the endothelium and increase the risk. And here anticoagulation is required, which is given through the catheter itself. And after 2 to 3 days of treatment, this catheter is removed and also requires frequent monitoring. The other situations that are common are infections like sinusitis, mastoiditis, etc., inflammatory disorders like SLE and rheumatoid arthritis, trauma, surgery, immobility, nephrotic syndrome, as I already gave an example, and cancer chemotherapy, where again multiple factors are involved. This is a clinical presentation which you see often acute limb ischemia is seen with swelling and discoloration. In neonates especially, it can be quite severe where there's associated thrombocytopenia, purpura fulminans, skin necrosis may be there, and maybe even loss of extremities in the formation of gangrene. Headache, visual impairment, and abducens palsy is another common presentation in older children. Inherited thrombophilias are quite common in children, and they may present either very early in life or in adolescence, and we suspect it if there is a history of, already a family history of such a condition. So some of this has been already spoken about. It could be a deficiency of the anticoagulants like antithrombin and protein C and S, or it could be an effect of a gain-of-function mutation of the procoagulant factors like protein factor V Leiden, prothrombin G2021-0A mutation, or the MTFHR mutation associated with homocystinuria. The clinical features may depend on which part of which area is involved, the duration of thrombosis, and therefore the severity of presentation may vary. As you can see, pain and edema are really the most common symptoms that may be present, and it is a high index of suspicion and the presenting limb, the risk factors that might help you suspect this condition. The complications that occur are limb ischemia. Pulmonary embolism is not very common in children but can occur from time to time, anticoagulation associated bleeding, and there may be the recurrence of clot, and clot progression may also occur. And you have also the post-thrombotic syndrome where there's pain, swelling, and various other chronic gangrene may occur. And when it becomes chronic, then there is really a reduced quality of life in these children. Investigations include the standard investigations of CBC and the PT-PTT. Dimer is already talked about. We don't really have good reference values in children, so it's not always so useful. What we commonly use is a Doppler ultrasound, but it is cheap, easily available, but probably often requires the cooperation of the patient, so sometimes it can be a little difficult in young children. So the gold standard for us, even CT venography is used and MRV is used. CT is good because it is a short exposure, but the risk of the nephrotoxicity of the agents are a thing to consider, whereas MRA and V is useful, but it requires general anesthesia as most children don't cooperate. So for the specific thrombophilias, as we said, mutation studies are available, and we can do functional assays of thrombin, antithrombin 3 and factor-laden factors. And for antiphospholipid antibody also, we talked about the ELISA test and doing the lupus anticoagulation. So coming to the goals of treatment, we want to make sure that there is no extension or embolization of a thrombus that is there, and to prevent recurrence or pulmonary embolism, and to prevent long-term complications. So the three modalities available to us are no very different from adults. We have unfractionated heparin, we have low molecular weight heparin, and you also have the oral vitamin K antagonists. The direct oral anticoagulant agents, really there are not much information on children and therefore are not commonly used. Unfractionated heparin it has to be given as a continuous infusion. You give an initial bolus of 75 units per kg, and then you follow it up with a dose of about somewhere between 20 to 30 international units per kg, depending on the age of the child. And if there is excessive bleeding, then the anticoagulant given is, to reverse bleeding, is protamine. The advantage is it is short-acting, so it can be given if acutely required in a child, and also if you need urgent surgery, it can be stopped immediately. However, it has some disadvantages, that it has unreliable pharmacokinetics and therefore has to be monitored very closely. There is a risk of osteoporosis, and there's also a risk of HIT, which can often, the heparin-induced thrombocytopenia, which we may see from time to time within a few days of starting treatment. In these situations, you have to stop treatment and then start the direct thrombin inhibitors like argatroban. The low molecular weight heparin, like Lexane, is probably the most useful. Just have a few more slides. The most useful drug that is used by us. It can be used both in the acute situation and in the chronic situation. And the advantage is that it doesn't require too much monitoring. It can, factor 10 assay levels can be done, but really not routinely required as much as it's required for heparin. And younger children have higher doses compared to older children. Vitamin K antagonists are also, warfarin is very, very often used by us. The biggest advantage is that it is given orally. You start with a low dose of 0.2 milligram per kg, but here again requires very, very close monitoring because you need to maintain the INR between 2 and 3. And if there is excessive bleeding, then we'll have to stop the drug, give vitamin K, and sometimes also need to give FFP. As I mentioned, direct oral anticoagulation, there's very, very little information available for us for children, so we don't really use it. And the duration of anticoagulation, as already was discussed in the previous session. So if it's the first episode, generally if it is reversible, it's a reversible cause, we give it for 3 months. If it is there's a chronic cause that it's associated with, we may have to give it longer, till as long as the risk factor exists, so it may be even longer as 6 months. And if it's a very chronic cause, the repeated exposures, then we may have to give it for 6 to 12 months. Similarly, for recurrent VTE, also we have similar guidelines. The transient risk factors would be things like central venous catheters and infection. Persistent factors would be things like nephrotic syndrome because there's risk of recurrence, or if the patient is on ongoing chemotherapy. And there's also idiopathic or unprovoked VTE where you need to give it for 6 to 12 months. So basically, we start with low molecular weight heparin in most situations and shift over to warfarin. But in some situations where you want very rapid reversal, you may use unfractionated heparin. And the duration for idiopathic is 6 months. For secondary, it may be 3 months. And if it is recurrent and idiopathic, then we may need to give it quite long, and including the possibility of using it lifelong. We also do use it for prophylaxis in some situations where, depending on the etiology, if there's adolescence, if there's a need for prolonged immobility, if there's the patient is on exogenous estrogens, there's a recent trauma, obesity, and poorly controlled SLE and diseases like that. Amongst these, the low risk, they may be stratified as those who have early and frequent antibiotics. The high risk are those who are need low molecular weight heparin. So the contraindications are active hemorrhage, thrombocytopenia, and hypertensive crisis, and also if there's a patient has been on having high intracranial and intraocular pressure. So our take-home message is there's a lot more to be still learned in this area. We need better drugs for children, and the children also have problems with frequent testing when we start the children on warfarin. So the pain that's involved with it, frequent testing, and they all pose a high risk of bleeding. So we really look forward to having better drugs with better efficacy, better safety for children, which is more also convenient for use in children. Thank you.
Thank you very much, ma'am, for an excellent presentation, and we'd like to have questions at the end of the session. Continuing, we'll have anticoagulation in chronic kidney disease. How much is too much? Dr. Pranay is here. Dr. Pranay, please.
Good afternoon. At the outset, I'd like to thank the organizers for inviting. And it's an excellent time to meet after 2.5 years almost. So I'll be talking about anticoagulation in CKD. It's an extremely, I think, unaddressed problem, and it's a major health issue. I've got no disclosures to make. So coming to the background, so we know that the prevalence of CKD is about 8 to 16%, and because of the associated illnesses, this is only going to increase. And the CKD 3, 4, and 5, there's about 6% prevalence in the world right now, and this is also going to see a market increase in the next few years. VT, atrial fibrillation, and arterial thromboembolism, these patients are at a higher risk than the general population. For example, there are 2 to 3 times risk of having VT rather than the general population. Atrial fibrillation in these patients ranges from about 20% in pre-dialysis patients to almost about 40% in dialysis patients. So there is going to be an increased use of oral and parenteral anticoagulants in these patients. And we will also be seeing these patients more and more in the coming few years. So it's very important to be made aware about the use of anticoagulants in this cohort of patients. So what are the challenges of using anticoagulation in CKD? As we know that CKD 4 and 5 are usually excluded from most landmark studies like the RELY, ROCKET, and the Aristotle studies. CKD 4 and 5 were not included in it. Coming to the various societies, there is no consensus among the various societies regarding the use of these drugs in CKD 4 and 5. There are many variables like the diseases. CKD is not an isolated disease. There are usually 2 or 3 other illnesses associated with it. Patient and treatment specific variables are also there. There are also significant drug-drug interactions as these patients are on numerous drugs. And there are no bleeding and thromboembolic risk scores which take CKD or renal failure into the scores as well. So there is a paradox of hypocoagulability versus hemorrhagic risk. These patients in the initial part of CKD are in a hypocoagulable state, and as we move towards the latter part of CKD 3, 4, 5, there are increased risk of hemorrhage. So the increased hypocoagulability is because of uremia, which leads to inflammation and prothrombotic changes like increase in von Willebrand factor, fibrinogen, and factor 8, increase in antifibrinolytic factors, and coagulation and platelet activation in extracorporeal hemodialysis. There are associated with hemorrhagic risks as well. As we said that as you go ahead to the more advanced forms of CKD, there is increased bleeding risks. They have a 6 to 7% risk of intracerebral hemorrhage. There is a reduction in platelet adhesion and aggregation. Anemia in this patient also predisposes to increased hemorrhage. There is frequent use of heparin in hemodialysis, and these patients are on multiple antiplatelet drugs as well, which can also cause interaction. So coming to, we'll go through the various drugs and just talk in brief about them. So unfractionated heparin is probably something we've used for a very long time. It's cleared primarily by the reticular endothelial system. But once that gets saturated, it's really excreted as well. So depending on the dose, it has a half-life of 30 to 150 minutes. And in patients who are in moderate to severe CKD 3, 4, 5 are more prone to over-anticoagulation. Even though it is not primarily a renal excreted drug. The ESSENCE and the TIMI trial, they basically showed that your creatinine clearance, if it was over 30 ml per minute, the bleeding risk was 1. percent, and if it was less than 30 ml per minute, so it is 6.6%. So this was both with unfractionated as well as low molecular weight heparin. So that has to be kept in mind. So the advantages are, it's a short half-life, and we have a reversible agent in hand, which is protamine sulfate. Low molecular weight heparin, enoxaparin, is the most studied drug out of the low molecular heparins in renal dysfunction. And we'll have to use a targeted anti-A level in these patients. So 1 to 2 if you're using the drug once a day, and 0.5 to 1 if you're using it in 2 doses during the day. These drugs have also, according to the stage of CKD, as you go down, you have to lower the dose of the drug. So if you're on CKD 5, you need to go to 0.3 to 0.4 mg per kg in these drugs. Dalteparin, there are no dose adjustment required till creatinine clearance of up to 30, but you have to monitor 10 A level. Not a lot of studies have been done in this drug in CKD patients, especially 4, 5, and on patients who are on HD. So vitamin K antagonist warfarin, this has been used for years. So this helps in individualized treatment, and you have to really pay attention to these things when you use this drug. So you'll need to use lower dose requirements. If your creatinine clearance is 30 to 59 ml per minute, you will need a 10% dose reduction. If it's less than 30, you would almost go 2 times of that to 20% dose reduction. So the labile INRs are very important. These patients have supratherapeutic INRs, which leads to greater bleeding. Warfarin calciphylaxis and warfarin-induced nephropathy is also seen in these patients, and that has to be kept in mind. And these drugs may have to be stopped if you find out that these entities are taking place. You would want to maintain a INR of 2 to 3 or a time and target range of more than 70% for these drugs to be effective if you're going to start them. So nowadays, these NOACs are being used. I would just like to focus on the renal excretion. As you see that dabigatran has about 18% renal excreted drug. So automatically that tells you that it's primarily not a very safe drug to be used in CKD patients. Rivaroxaban is about 35, apixaban is the least with about 25%. Apixaban is factor 10A inhibitor, and it was especially studied for creatinine clearance from 25 to 30 in the Aristotle subset which was done. And they also said that a 2.5 mg BD dose can be used if your age is more than 80, weight is less than 60, and your creatinine is greater than 1.5. A subset of the study, which I said, has fewer major and non-major bleeding events than warfarin. And in 2014, it was approved by the FDA to be started on patients on hemodialysis as well. So the only NOAC which has been approved to be started on patients on hemodialysis. Rivaroxaban also has a adjusted dose. You can come down to 15 mg per day for patients with creatinine clearance less than from 15 to 50 milliliters per minute. It is avoided in CKD5 and in patients who are on hemodialysis. Dabigatran, it is 80% renally excreted and is to be used with caution when the creatinine clearance is less than 30. However, it's the only NOAC which can be, if you can do hemodialysis, if you have overdosed on this, and it has a reversible agent as well, which is used. So just like to focus on this slide, as you come down to the creatinine clearances under 15 to 29 and lower than that, the only 2 drugs in which all these societies, which is the AHA, ACC, HRS, CHEST, and KDIGO, they agree on warfarin and apixaban only are the 2 drugs which can be used safely in the more advanced forms of CKD, and that needs to be kept in mind. In conclusion, I think there are more questions than answers in this. A lot of the data is from patients with atrial fibrillation and not with VT. So further studies in patients with VT need to be done. Further research is needed, and dynamic and individualized treatment with proper monitoring is the key in these patients. Thank you.
Thin balance between hypercoagulability and bleeding, that is the crux, and very nicely presented. Questions at the end of the session, please. We move on to the guidelines in anticoagulation in cancer. Dr. Singh will be presenting.
My topic is on anticoagulation in cancer. It all started with Professor Trusso's finding who found out that have always been struck with the frequency with which cancerous patients are affected with painful edema of the superior and inferior extremities in 1865. But it was an irony that he himself was diagnosed with gastric cancer and died soon after. But there was the breakthrough in the finding of deep vein thrombosis and venous thromboembolism in cancer. As you can see, about 20% of patients with venous thromboembolism occur in cancer, and of all the cancer patients, 20% will have symptomatic venous thromboembolism, and venous thromboembolism is the second leading cause of death in cancer. And you can see that the multiple factors which play a role in deep vein thrombosis and venous thromboembolism in cancer, starting with the stasis caused by prolonged bed rest with cancer patients, especially occurring in the later parts of their life in cancer, and the more procoagulant factors released from the cancer cells and the inflammatory process which goes on in advanced cancer, and along with that, the endothelial damage caused by chemotherapy, which can also lead to a higher risk of deep vein thrombosis, venous thromboembolism. And it is also related to the site of cancer, especially in gastrointestinal cancers like pancreas, and the histology of the cancers, and in biomarkers like the elevated platelet counts before chemotherapy or the high leukocyte counts before chemotherapy do play a role in the prevalence of deep vein thrombosis and pulmonary embolism. And the requirement of surgery, especially in advanced cancers, especially in gastrointestinal surgeries and pelvic surgeries for cancer, and patients who require hospitalization because of advanced cancer, or sometimes in some chemotherapy, which can also lead to a higher risk of venous thromboembolism. And patients who already have comorbidities, especially they have a very high BMI, they do have a higher risk of venous thromboembolism. And the new concept of cell-free DNA, which is generally released after treatment, and we find that in the blood of patients, do have a role to play in the onset of venous thrombosis. And there is a risk scoring system by Corona et al., and which has found that the site of cancer, especially in stomach and pancreas, do play a high risk for venous thromboembolism, and pre-chemotherapy platelet count, leukocyte count do have a role to play, and the hemoglobin of less than 10 grams has a higher risk of developing deep vein thrombosis, and a BMI of more than 35 does have a role of venous thromboembolism. And as you can see that the risk of venous thromboembolism starts lesser from the early stages of disease and then progresses as the disease advances. And there is a dual peak during the initial periods of hospitalization for chemotherapy, and they do have a higher risk, and again towards the end of life when there is a higher risk of metastasis and more metastasis, those patients are at a higher risk of venous thromboembolism. And as you can see that patients with pulmonary embolism picked up incidentally for a screening scan, or patients with symptomatic pulmonary embolism do have a similar poor dismal survival. So even patients picked up incidentally with the pulmonary embolism will require treatment for the pulmonary embolism to prevent complication. And as you can see, the venous thromboembolism and mortality does increase with the number of cycles of chemotherapy. And as you can see, there is a doubling in the risk for death among cancer patients with venous thromboembolism. And you can see the incidence of venous thromboembolism does increase even in ambulatory patients undergoing chemotherapy as the number of cycles progress within the first 3-4 cycles. And as you can see that the chemotherapy per se can contribute to the risk of venous thromboembolism, especially if the patient is on cisplatin or carboplatin chemotherapy, and if the patient is on L-asparaginase with ALL, even though they do have a low platelet count, those patients are at risk of venous thromboembolism. We should be careful. And patients who are on infusional 5-FU do have a depletion of protein C and increased thrombin activity, which does lead to a higher risk of venous thromboembolism. And breast cancer patients who are on tamoxifen do have a high risk of venous thromboembolism. And as you can see, in patients who have been operated for cancer, have a risk of venous thromboembolism even after going back home. So that is a very important factor to play. And as you can see, that pulmonary embolism is the single most common cause of death at 30 days after surgery for cancer. And as you can see, that patients who have been put on prolonged low molecular heparin do have a lesser risk of venous thromboembolism with the statistical significance. So we should consider extended prophylaxis with low molecular heparin for up to 4 weeks post-operatively, especially in patients with cancer who have undergone major abdominal or pelvic surgery. And ambulatory patients with cancer and chemotherapy, if they are at low risk for thrombosis as per the corona scale, we don't have to put them on anticoagulation. But if they are at intermediate or high risk, that is 2 or more features, we need to put them on either direct oral anticoagulation or low molecular heparin. But if these two are not accessible, even a vitamin K antagonist is enough, especially if we can keep the INR at around 1.5. And patients with myeloma on thalidomide or lenalidomide would benefit with the addition of low-dose aspirin or vitamin K antagonist. And what is the aim of venous thromboembolism treatment? One, it is to prevent fatality. Next is to prevent recurrence and also to prevent the thrombus extension and embolization. And the answer for all is anticoagulation. And as we all know, the old Clark trial did prove that low molecular weight heparin did reduce the risk of venous thromboembolism recurrence compared to vitamin K antagonist. It was also confirmed with the CATCH study where tinzaparin was compared with warfarin. And we all know with all the randomized trials that low molecular heparin was better than vitamin K antagonist. And what about the direct anticoagulants? The ones which act on factor 10A are rivaroxaban and apixaban, and on 2A is dabigatran. All these have been found to have a beneficial effect, especially in patients who've been admitted for treatment in hospitalized patients. But many of these studies which were analyzed, for the subgroup analysis, the Einstein DVT, Einstein PE, Einstein EXT, the Remedy and the Hokusai VT, all that did not have a high number of patients with cancer. The highest was around 6.8%. So most of them had less than 7% of patients with cancer. So even though there was some benefit, it was not really very catchy. And the Cassini and the Award were the main two studies which did find the benefit of oral anticoagulant compared to placebo with the occurrence of thrombosis, but they did have a slightly higher risk of major bleeding. So that has to be taken into consideration. But the most important factor which we need to consider in direct oral anticoagulation is the drug reactions with many of the chemotherapy drugs which we use. So we need to be careful in giving the proper drug and for the proper chemotherapy regimen which the patient is on. And the other factor which we need to consider is there are some ambiguities which are there with the direct oral anticoagulants with regards to tumor growth per se, because there are some studies where pancreatic cells were actually found to be hypertrophied, and some pancreatic cancer cells are also found post direct oral anticoagulation therapy in mice in the experimental mice. So that we need to consider. And there are some studies where lung metastases were also found to increase in mice vaccinated with melanoma cells treated with zimelagatran. So that also we need to consider before we decide on direct oral anticoagulation. But as of now, in clinical trials, it has not been found to be unsafe. It is reasonably safe, except for the drug interaction which we need to consider. So treatment of venous thromboembolism and cancer, we need to look at initial anticoagulation, which may be with low molecular weight heparin, like enoxaparin or dalteparin, or unfresh heparin, especially if the patient has renal dysfunction, and fondaparinux if the patient has a previous history of heparin-induced thrombocytopenia, and or rivaroxaban. And low molecular heparin, edoxaban, and rivaroxaban are generally given, especially in patients who have had history of venous thromboembolism for at least 6 months, and sometimes we can even consider it beyond 6 months if the patient is on active chemotherapy and has metastatic disease. So that we need to consider. Vitamin K and antagonists are generally inferior, but if both low molecular heparin or direct oral anticoagulants are not accessible, vitamin K antagonist is reasonably safe to use at lesser doses. So what we need to look at is the drugs which we give for hospitalized medical patients for prophylaxis of venous thromboembolism is either heparin or low molecular heparin. In surgical patients, again, it's either heparin or low molecular heparin. But in outpatient setting, we can also add rivaroxaban at 10 milligrams OD for prophylaxis. For treatment of established VTE, here there is heparin or low molecular heparin along with rivaroxaban at 15 milligrams twice a day for 21 days, and for long term, the rivaroxaban dose has to be reduced to 20 milligrams once a day. And like that, the other low molecular heparin doses are also modified for long term therapy. So to conclude, if the patient has cancer-related thrombosis and there is a high risk of bleeding, if the patient does not have a tumor originating from the digestive tract or urinary tract, and the patient does not have any gross drug interaction between the direct oral anticoagulant and the chemotherapy, and the patient is not, and the thrombosis is not related to central venous catheter or the vascular port, we can safely consider direct oral anticoagulants like rivaroxaban. Otherwise, we can safely put them on low molecular heparin, and if that is also not accessible, we can put them on vitamin K antagonist. And we have to continue if the cancer is still active and metastasized, and the patient is going to be on chemotherapy, especially on cisplatinum or carboplatinum or 5-FU or tamoxifen, we need to consider long-term oral anticoagulation therapy. And so with that, I conclude my talk on oral or on anticoagulation in cancer, and I thank the organizers for giving me this wonderful opportunity for having shared my views on oral anticoagulation in cancer. Thank you very much.
Very much, Dr. Deba Singh. I request you to stay around because the question session will be there. And to start with my co-panelist,
I thank all the presenters. It's a very good presentation. The topic also is very interesting topic. I thank the organizers also. These topics are very useful for our day-to-day practice. Thank you. It's very well presented by all the three presenters. Once again, thank you. First question to Indra Agarwal, Madam. Madam, you explained very in detail about pathophysiology in pediatric age group and adult age group. And management-wise, how pediatric anticoagulation, how it differs from adult patients, or what are the challenges you encounter during starting anticoagulation in pediatric age group? Please explain.
No, I didn't understand the question.
What are the challenges you encounter in the managing pediatric patients with anticoagulation when comparing to adult?
See, I'm not familiar so much with the problems you face with adults, but for children, generally we start off with enoxaparin and we shift over to warfarin quite quickly, is to avoid long-term use of, because it's a subcutaneous injection, and because of the risks of bleeding. We send the children home and we monitor the PT-INR, but that allows us to send them home for say 4 weeks, 6 weeks, and once we have established the INR. Sometimes it takes a little while to get the right level. So that is the most convenient method.
Okay, thank you. Thank you. Next question to Pranay. Anticoagulation CKD. Pranay, there are two entities, CKD on dialysis and CKD not on dialysis. Is there any difference in starting anticoagulation these type of patients?
Yes, ma'am. There will be a significant difference because many times you do the HD, that amount of the pro-drug or the drug which is used is actually excreted out and is removed out. FDA and according to all the other guidelines, ACCP, CHEST and all, so the approved oral anticoagulant is not warfarin in these cases. They actually found in 4, 5 and CKD5D, they found out that warfarin is harmful. Apixaban is probably the only one which is actually approved by all these places in these patients. Another thing, you have to repeat the renal profile of these patients often, every 2 to 3 months, and then after that accordingly adjust the dose. Most of these studies have used the creatinine clearance according to the Cockcroft formula. But what the nephrologists use, they use the CKD EPI for formula. So the clearances rates between the both of them are not the same. So that is also something which needs to be in mind as well.
Okay, thank you.
One small query for my knowledge.
Yes, sir. Yes, sir.
What is this new agent, denaperoid, which is coming for the management?
I have not read about that for that much.
I was just hearing about that, so I thought you have detailed.
So it's not approved in CKD for sure. These are the only drugs. Apixaban is the only one which is approved.
Can I have a question for Pranay?
Tenofovir is an antidiabetic.
There is a sort of a theoretical disadvantage of using vitamin K antagonists in CKD because these patients have medial calcification, and vitamin K is essential to remove this calcium and take it back to the bone. So what is your opinion on that?
So it's an entity which is there for sure, and they actually say that within 2 to 3 years of starting warfarin, most of the patients, they actually have warfarin-induced anaphylaxis. And when that happens and when you see it happening, there are skin changes and all, and ischemia can also happen. You need to stop it.
Okay, and switch over to the DOACs?
Yes, sir. Apixaban is the one which is the most
Because
often used.
I don't know what's the situation in most of the country, but at least in Ahmedabad, I can say that the orthopedic surgeons everybody is now prescribing vitamin K to their patients, K2, I mean.
Okay, sure.
So this is a change that I've seen over the last 4 or 5 years.
Sure, sir. Thank you.
May I get one question? My question is to Indira ma'am. Ma'am, I would like to know what was your protocol for COVID thrombosis in children? Was it any different from standard anticoagulation or the same?
We didn't actually come across too much of thrombosis in children, at least maybe as the ICU may have better statistics to give, because we were not directly involved. At least we didn't find many children who had thrombosis. In fact, most of our COVID patients that we dealt with were actually incidentally COVID positive. We didn't really have sick COVIDs with thrombosis. I don't really have that data.
Any other question, please? So if there are none, we conclude this session. Thank you very much, speakers, for all excellent talks, and it was very illuminating. And thank my co-panelists for being there. With that, we close this session. Good evening.
Thank you so much. A big hand to all our chairperson and the panelists on stage and our speakers who joined along. Thank you. We would now like to move ahead to our next session. I'd like to invite our chairperson, Dr. Malay Patel, and Dr. Prabhu Prem Kumar to please join us on the stage and take us through the next session, which is on international perspectives in venous practice. Post this particular session, we also have another interesting competition, and we would want all of you to join us back here. It's going to be exciting, it's going to be interesting, which is sponsored by Servier, and it is looking out for Young Researcher Award. So we will have young researchers who are stepping up and presenting, and it's a competition. I'm sure it's going to be exciting, and I'm looking forward for it. As of now, this particular session is on international perspectives in venous practice, and that's why I'll hand over to the chairperson on stage. Over to you, sir. Requesting the speakers to hold the mic as close as possible. Over to you, sir.
Good afternoon, everybody here, and good morning, good afternoon, good evening to our international speakers. And we start the international perspectives in venous practice. We have 5 speakers today, and we will start with Dr. Peter Subramaniam from Australia. So he's probably, it is late evening for him. And so can we have Dr. Peter Subramaniam begin his talk? Is Dr. Peter Subramaniam online?
Thank you for the opportunity to share the current Australian perspective on the management of venous disease. The Australian New Zealand Society of Vascular Surgery is appreciative of the invitation of the Venous Association of India for this opportunity. Like in most jurisdictions across the world, endovenous treatment of superficial truncal venous disease is increasingly represented in cases recorded on the Australian Vascular Audit. Although at 41% of total number of cases done in the last 5 years, this is likely to be an underrepresentation of the true breakdown of endovenous versus open treatments. This is because a large percentage of venous disease is treated as ambulatory, non-hospital-based care, and also in the private sector, where data is variably captured in the Australian Vascular Audit. Surgical ligation and stripping continues to be performed in many public hospitals, although this is increasingly a diminishing activity. Over 90% of endovenous interventions are of a thermal ablation nature, either with radiofrequency or with endovenous laser. In 2017, the Commonwealth Government of Australia commissioned a review of payment schedules for all services provided through Medicare, which is the universal health system which provides healthcare to all citizens of Australia. Data on 77,000 varicose vein services were analysed, and this confirmed a trend of a decrease in surgical ligation with a corresponding increase in endovenous procedures. Over 60% of procedures, however, were claimed for injection sclerotherapy. As you would expect in a country of our size, regional variations exist, with the expected preponderance of services in the more populous East Coast cities in Australia. Remote and regional areas are again underrepresented in cases managed by endovenous technique. The Australian and New Zealand Society for Vascular Surgery commissioned the development of a web-based national audit in 2010. The audit has matured in the last decade and provides us with the capacity to study and analyze the trends in management of vascular disease in Australia. Participation in the audit is a mandatory requirement for membership of the Society. Useful data is harnessed from this audit, and when we look at endovascular procedures, we are able to make some comment on the treatment of deep venous disease. What you can see here is the increasing numbers of venous stenting demonstrated in this graph, with annual case numbers noted. The increase coincides with the publication of the ATTRACT trial around the 2017 mark. Certainly, access to venous-specific stents, the use of IVUS, and the attendant significant interest by industry has seen the increasing numbers. However, it should be noted that a significant number of interventions performed in the private sector are not captured in the AVA, or the Australian Vascular Audit. Again, there's a preponderance of activity in the east coast of Australia, with a significant number of cases being performed in the private sector. That is not captured in this data. The pattern of deep venous intervention is consistent with the literature, with the preponderance of females and involvement of the left iliac system. Approximately 90% of interventions are elective, as reported in the national audit. A very, very high number, 72%, relate to the intervention for an underlying diagnosis of May-Thurner syndrome. Data capture does not allow us to make comment on the methodology of diagnosis of May-Thurner syndrome. 27% were conducted for claudication and ulceration. Of the 10.5% or so of semi-urgent and emergency cases, 18% was associated with catheter-based thrombolysis and 13% with the use of the AngioJet catheter-assisted thrombectomy device. The evidence base for venous stenting for non-occlusive venous disease, or so-called NIVLs, remains an active element of discussion in Australia. While venous stenting for patients with ulceration and venous claudication is generally accepted, the use of stents in minimally symptomatic or subjectively symptomatic May-Thurner syndrome remains an ongoing topic of debate. Certainly, vascular units in Australia with particular interest in venous interventions have developed excellent competencies in the use of intravascular ultrasound and the deployment of venous stents. However, the criteria for intervention and the subsequent follow-up continues to be a work in development. Cost associated with the intervention, together with the clinical improvement provided by venous stenting in cases of external compression, associated with chronic occlusive anatomy is justified in our view, especially in cases of gross post-thrombotic swelling associated with ulceration. Certainly, Australian vascular surgeons have been active and involved in research and publication in this area. With the innovative use of endovenous technology, sometimes endovascular technology, such as reported in a case study by my colleagues at Flinders Medical Centre here in Adelaide. The economic burden of chronic venous ulceration is no different in Australia than in other parts of the world, and certainly the driver to minimize post-thrombotic syndrome and treat ulceration remains a significant driver in this area. The evidence base for any surgical or endovascular intervention remains an important tenet of vascular and indeed any surgical practice, not just in Australia but around the world. The absence of an evidence base can lead to ethical and medical legal issues when late onset or delayed complications such as stent thrombosis occur. To summarize, as with the rest of the world, Australia has moved to developing ambulatory, minimally invasive thermal and non-thermal techniques for the management of superficial venous disease. The ANZ Society, through our subcommittees, are involved in the assessment of the development of specific identifiable reimbursable item numbers for ultrasound-guided truncal sclerotherapy. It is the Society's view that the endovenous management of superficial venous disease is appropriately and adequately guided by duplex ultrasound, and the use of venography is not required or only required in a very minimal number of cases. This is the position we've put to the government. Like all other parts of the world, the Society encourages its members engaged in deep venous intervention to contribute to the literature by the development, for example, of multi-center independent registries with focus on clinical outcomes, standardization of interventions, and measurements on IVUS and so forth, and also consider the cost effectiveness, both in the public sector, but also in the private sector, where a significant number of deep venous interventions occur. Once again, I thank you for the opportunity to present to the Venous Association of India.
Thank you, Peter. Thank you, Peter, for that illuminating talk.
Now we will move on to the next speaker, who's from Italy. It's Dr. Patrizia Puvai, who's been the past president of the Italian Phlebology Association, as we put it in English. So Patricia is going to talk to us about an international perspective from her viewpoint. And Patricia, you can please start your talk.
Good afternoon. My name is Patrizia Pavei, and I manage the Vein Center of the Day and Week Surgery Unit of the Padua University Hospital in Italy. And I will share with you our perspective in venous disease. In Italy, we have 20 regions, and each region has different rules for the reimbursement of the treatments for chronic venous disease. Nevertheless, the Italian health service has given some indication about the appropriate treatment and setting to be used, taking as a reference the suggestions coming from NICE clinical guidelines. As regards the setting, to be cost-effective, the management should be performed on an outpatient basis by a vascular service with a team who have the skills to undertake a full clinical and ultrasound assessment and provide a full range of treatment. Furthermore, following the same guidelines, the first choice treatment for varicose veins should be endothermal ablation. Ultrasound-guided foam sclerotherapy should be considered as second choice, and only as a third option, surgery. Despite the suggestions, you can see in this slide that in 2019 in Italy, high ligation and stripping was still performed very frequently, and in 4.5% of the cases, patients were hospitalized for more than 4 days. This is due to the fact that the venous disease is very often treated by general or vascular surgeons not experienced in this field. On the contrary, in Padua, we focused on the treatment of venous disease since the 90s, and in 1986 we started as an office-based surgery. Then in 1992 we became a day surgery unit, in 2000 a freestanding unit, and in 2014 we have been incorporated as a vein clinic within the multidisciplinary day surgery unit of our hospital. In our phlebological unit, we performed every kind of activity connected with venous disease. In the ambulatory setting, we evaluate the patients both from a clinical and instrumental point of view. Echocolor Doppler and plethysmographies are carried out by doctors, as well as ultrasound-guided foam sclerotherapy. The other endovascular treatments and surgery are performed on an ambulatory basis as a day surgery procedures, and we perform endothermal procedures, laser and radiofrequency, and among the non-thermal, non-tumescent procedure, we use cyanoacrylate glue. Only in selected cases, we still perform high ligation and stripping. How do we choose between the treatments? In summary, we prefer ultrasound-guided foam sclerotherapy for smaller veins with a diameter between 3 and 6 millimeters. In older patients, in women in childbearing age, or in patients with few branches involved, we use ultrasound foam sclerotherapy. And in these patients also cyanoacrylate treatment can be considered. For bigger veins, between 6 and 10 millimeters, affecting more with disease affecting more branches, we, with medium to strong reflux, we suggest glue or thermal ablation, while for advanced disease, we use thermal ablation or, in rare cases, traditional surgery. In most of the cases, we use more than one technique. For example, when treating big recurrent varicose veins, we associate ultrasound foam guided sclerotherapy with phlebectomies. Glue and endothermal ablation can be combined with sclerotherapy or phlebectomies, and high ligation and stripping can be associated with sclerotherapy. So, which is the best treatment for venous disease? In my opinion, it is a balanced choice taking into account clinical guidelines, international guidelines, evidence-based medicine, advantages and disadvantages of each method, considering the experience of the doctor, and the preference of the patient, and keeping in mind that our treatment should be cost effective. We can conclude with the sentence of Bo Eckloff of a leading article published in 1988, who said, "The modern surgeon treating varicose veins should have a Doppler in his pocket with a knife in a hand and a syringe in the other." In other hands, we can say that our vision is to perform a tailored treatment. Thank you for your attention.
Thank you, Patricia, for that overview and the final message that goes through. It is very clear to almost all phlebologists or anybody who is treating varicose veins or superficial venous reflux, as we call it in general terms, that a combination of therapies works best and tailor-made therapies work even better. So thank you, Patricia. And we now move on to the next speaker, who is Dr. Javier Zaralde from Mexico, or Mexico as we call it, but Mexico as they call it. And Javier, very, very good morning, because I think it is 3:30 a.m. or something like that for you. And we are very happy that you have chosen to stay awake or wake up to talk to us. Please go ahead, Javier.
Hello to everybody, I'm Dr. Javier Zaralde from Mexico City. First, I want to say thank you for the invitation to me. In this moment, I want to tell you about how to understand the pelvic venous disorders. Well, I don't have any conflict of interest about to talk this topic. When we decide to understand what happened with the venous pelvic congestion, it's mandatory to understand the definition, because this is the increase in intrapelvic venous structures in number and caliber. It has the varicose and tortuous morphology with the flow alterations. And it's very important to remember the chronic pelvic pain more than 6 months is the main symptom in these cases. About the incidence of the pelvic venous disorders, in 2019, the UAP published the consensus, and they can identify the pelvic chronic pain in 39% of the women. The pelvic congestion syndrome is estimated in approximately 30% in the patients with pelvic chronic pain, most commonly in the reproductive age between 20 to 45 years, and the risk factor is the more pregnancy, more incidence. And the true real prevalence of the pelvic congestion syndrome is still unclear. About the backgrounds and reviews we can get in the Cochrane Library, only 32 trials and 2 reviews in the last 4 years. Speaking about the pelvic venous disorder, how to get started to understand the pelvic venous disease? We need to use the 3 points. The first is to know the abdominal and pelvis venous anatomy, the second to understand the venous pelvic pathophysiology, and the third is to identify the symptoms and things in venous pelvic disorders. Speaking about the first point, the pelvic venous anatomy, we need to identify the inferior cava vein, the gonadal veins, the common iliac veins, the external iliac veins, and the internal iliac veins with the extrapelvic and intrapelvic branches. The main part is to identify the branches from the internal iliac vein, because we can identify the extrapelvic branches like to the gluteal veins, ischial, internal pudendal, and obturar veins. And in the intrapelvic branches, the most common affected veins are the uterine and vaginal veins. Speaking about the venous pelvic pathophysiology, it's mandatory to understand that in this pathology we can identify the venous pelvic hypertension. Can be produced by the reflux syndromes, for example, the gonadal and internal iliac veins. It's possible to produce the pelvic varicose veins with the real pelvic congestion syndrome. On the other hand, if we can identify the compressive syndromes like Turner syndrome or Neutral-Keikle syndromes, we can identify the incompetent pelvic floor and the leaks to the lower limbs. In this case, we can identify the bulbar and atypic varicose veins of the legs. Speaking about the collaterality between the pelvis and the lower limbs, it's mandatory to understand two branches. The first is when we can identify the first problem provided from the gonadal veins, we have identified the insufficiency in the wrong ligament vein. In this case, we can identify the bulbar varicose veins. The other part, we can identify the main problem from the internal iliac vein. We can identify insufficiency in the internal pudendal vein, obturator vein, and the inferior gluteal vein. In 3 cases, we can identify the atypical varicose veins in lower limbs. When we can appreciate the problem and the insufficiency from the gonadal veins, we can view damage the wrong ligament veins. In this case, we can identify the varices in the inguinal and anterior thigh. When we identify the problem from the extrapelvic branches, we can identify, in this case of the internal pudendal vein, varicosities in the inner thigh and vulva region. From the obturator vein, we can identify the veins in the pubic region, inner thigh, groin, and perineum areas. And when we have problem in the inferior gluteal and ischial veins, we can identify the typical veins in the posterolateral aspect of the thigh and infragluteal region. About the clinical data, when and why need to think in chronic pelvic venous disorder? When the patient has the chronic pelvic pain more than 6 months, aching or draining pain on sitting or standing, and the deep dyspareunia with another symptoms and things. About the diagnostic and treatment, it's very important to identify the chronic pelvic pain. In these patients, it's mandatory to perform the venous ultrasound in the abdominal and the leg area, and it's so important to perform the transvaginal ultrasound. We can complete our study with angiotomography or magnetic resonance, and the best part of the study is to perform the phlebography, because this is the gold standard. When we can identify the leaks, we can treat with cold embolization. And on the other hand, if we view the compression and thrombosis, we can treat with stenting. As a conclusion about the pelvic venous insufficiency, I want to say to you that the pelvic congestion syndrome has a 30% of prevalence in the population. This is an underdiagnosed disease. All of the patients with chronic pelvic pain need to be studied. Increase the teamwork with the gynecologist. The transvaginal ultrasound is mandatory, and the phlebography is the gold standard. About the treatment, the endovascular treatment, cold embolization, or stenting are the best therapeutic strategy. Anyway, this is all to me, and thank you very much for your attention, and this is the invitation to our next international meeting in Mexico in September, and don't forget the next 19th Pan American Congress of Phlebology and Lymphology in Ecuador. Thank you.
Thank you, Javier, for that difficult topic that you did try to make us understand much better. And we now move on to the next speaker.
Before we go on to Sandeep Raj Pandey, can I just request the tech team tell us who all are logged in from the speakers? All of them. Excellent. Welcome, Sandeep. We look forward to your presentation on the internet venous perspectives from Nepal.
Namaste, I am Dr. Sandeep Raj Pandey from Nepal. Thanks for introduction and thanks for invitation by BICON 2022. Hope I could have done it physically, but due to recent years travel, I plan to do it virtually, and I have also some local events in Kathmandu. So my talk today is surgical management of venous malformations. Among vascular malformations, the predominantly venous malformations represent the majority of cases. They form a clinical entity and therefore need clear concepts concerning diagnosis and treatment. See one venous malformation in forearm, just before nearby wrist. So surgery is indicated in isolated symptomatic venous malformations or the following sclerotherapy to improve form or function. Appearance. So surgical results are a function of the size and location of the malformations. Recurrence following surgery is more common with different malformation and when excised is incomplete. In general, surgery or sclerotherapy is more successful when dealing with pure venous malformation than when dealing with combined malformations, AVM or lymphovenous malformation. A study by Kang and work involving 109 patients with slow flow venous malformations determined that total excision could generally be carried out in venous malformation, but that only partial excision was typically possible for lymphatic and combined vascular malformations, with lymphatic malformation in many cases not being operable at all. According to Hamburg classification, predominantly venous malformations are categorized into truncular and extratruncular forms, with truncular forms distinguished as obstruction and dilatations, and extratruncular forms as limited or infiltrating. This is the type 1 truncular forms, where the marginal embryonic vein was involved. This is a marginal lateral embryonic vein, which is a persistent fetal luminant vessel forming the failure of normal involution. This is surgically exposed marginal vein along the lateral aspect of knee and lower thigh before the surgical excision to control the venous hypertension due to severe reflux caused by avasculosis condition. This is the type 2 extratruncular venous malformation with the lesion in the right inguinal region. The lesion is a cluster of primitive vein tissue in infiltrating condition to the surrounding soft tissue without direct involvement of the main venous trunks. Mainly surgically exposed lesion which complies with N-butyl NVCA glue. So there are also intramuscular venous malformation, often erroneously called intramuscular hemangioma, which present to pediatric orthopedic surgeons as a different diagnosis of tumor or as a cause of muscle pain. So this is the intramuscular venous malformation in the calf. You can see on the MR. Surgical approaches utilize different tactics and techniques that are adapted based on the pathologic form and type of malformation. One is operation to reduce the hemodynamic activity of the malformation. 2 is operation to eliminate the malformation. 3 is reconstructive operation. A staged surgical treatment is also required in some selected cases. As for type 1, a type of tactic is the operation to derive the venous flow into the total or partial removal of the venous malformation and demonstrated subdivided into 3 different techniques. In this way, the infiltrating as well as the limited forms can be treated. An additional technique is dedicated to the treatment of marginal vein. Approach 3 involves the treatment of venous aneurysm, where a variety of techniques have been successful. This is a venous malformation in the right lower limb involving persistent embryonic lateral marginal vein of leg. So results, long-term follow-up demonstrates positive results in 90% of the cases. This was a young man, waiter, KT syndrome with venous malformation. I did several steps of embolization, sclerotherapy. Then further I also excised some malformation because he was having painful. And finally he got leg before the treatment and after treatment few weeks, and he is doing good today. This is another lymphovenous malformation which I directly excised. Another beautiful lady with KT syndrome having venous malformation in leg and foot. So leg was sclerotized, but foot was even painful after sclerotherapy, so it was excised. And I see her now, beautiful foot. So this is another boy, a student, 20-year male, who has this big venous malformation on left side, just above knee. And I did several steps of sclerotherapy and also embolization with polycanal and this lipidol. But he was telling no, he is again having pain and doesn't look good. And we did again the angio, and it was like 90%, more than 95% thrombosed. So with the help of plastic surgeon, we totally excised it, take it out, and he was very happy. So this is the staged one, no, the venous malformation in right lower limb treated by stage surgery with good results, multiple time, before and after. So this one is also on the one hand, before sclero and excision. Just be happy, you know, excised and good lips. So as a conclusion, I would like to say venous malformations should be treated according to the principles developed during the past decades in vascular surgery, intervention treatment, and multidisciplinary treatment. The days of preemptive conservative treatment should be relegated to the past. Especially skills and experiences are necessary to carry out appropriate surgical strategy, and the required operative techniques should be dictated by the location and type of venous malformation. Surgery, when performed by a surgeon with appropriate experience, is an effective first-line treatment for painful intramuscular venous malformation, offering pain relief in the majority of cases. The majority of lesions are resectable, meaning they can be removed with a margin removing a functional limb. Sometimes resection of whole muscle is required. Thanks, Vacuum 2022. All the best for Vacuum 2023. Thank you.
Thank you. Thank you, Sandeep, for giving us a perspective, your perspective about treating predominantly, vascular malformations that are predominantly venous and with good outcomes. We will now move on to the next speaker, who's Alan Davis from London. And Alan is probably, it's a little bit good time, better time for him. So welcome, Alan. You've been here most of the times. We didn't see you this time, but that's, hybrid is good in that way. So please move ahead and give your talk.
Thank you very much for the very kind offer to talk about an international perspective from the UK experience. We have to consider patients with varicose veins, ulcers, and various forms of thrombosis. We undoubtedly know that the burden of vascular disease, venous disease, is becoming more common. If we look at this data, you can see that the number of procedures being performed are increasing, and also the number of patients presenting with VTEs increasing. This is also very important because we know that venous disease affects quality of life, and certainly within the UK healthcare budget can account for 3 to 4% of the budget, and that patients with venous disease are more likely to be depressed and anxiety. We also know that it has a significant global impact, and it was predicted that $400 million would be spent on treating veins in 2021. So I'd like to think about talking about 3 particular areas: the optimal management of venous ulceration, the merits of superficial venous intervention, and something about VT strategies. We're all very familiar with the leg ulcer. Probably the key thing is the pathways that we use to do it. There's a lot of data that has come out of the UK, such as the ESCAR trial, the various venous trials, all looking at the role of compression and also surgical intervention. The ESCAR trial was the first major study that came out and showed that there was a benefit with respect to leg ulcer recurrence and heat recurrence. Then it was the EVERA trial that came out very clearly with evidence that not only was there benefit with respect to leg ulcer healing, but there was also a benefit from leg ulcer recurrence, and the long-term data out to 5 years showed a benefit with respect to ulcer healing, reduced ulcer recurrence rate, and that it was a cost-effective strategy. And very bluntly, we need to be looking at having a global pathway, a bit like a cancer pathway, which is a 2-week pathway where patients have their diagnosis, they're treated in the community with compression, they're then assessed by vascular surgery, and then they have their venous intervention. And this has certainly become something that has even reached the members of parliament and being implemented. There are many myths about the management of varicose veins, and I think it's very important that we are well aware of what these myths are, and we should know how to discuss them with our patients. Firstly, one of the major issues is what are the symptoms of varicose veins, and there is interesting data from the Edinburgh Vein Study that actually itching is probably one of the most important symptoms that one needs to think about. And what is also important is to note that there is probably a 1 to 2% progression of venous symptomatology in a year. In the UK now, it's rather old data, but in 2013, NICE guidelines were published, and what is interesting to note is that these were in full concordance with those of the USA, Europe. And the key thing is that all patients who have bleeding varicose veins should be referred to a vascular service, but the key thing is that patients with symptomatic primary or recurrent varicose veins should be referred, as should leg ulcers, patients with superficial vein thrombosis. If we look at what has happened since the publication, we can see that there's been no real referral in the pattern of referral of C6 disease, but certainly there has been an increased referral patterns of people with lower class and also an increase in endothermal ablation. However, this is an NHS-funded healthcare service, and what is interesting is you can see that we have guidelines which are commissioned, and it's only those areas in green that are following these guidelines, whereas other areas are restricting the use of interventions to maybe C4, 5 disease. And I think what is really quite important is that there is a hierarchy looking at endothermal ablation first, then foam sclerotherapy, then surgery, and the key thing is that you should not offer compression hosiery to treat varicose veins if treatment is suitable. And looking at the NHS data, this has happened. There have been recommendations now for the newer techniques of endovenous mechanical ablation and glue that are now standard recommendations by NICE. NICE came out with various research recommendations, and you can see that the COMETA trial and the AVOLS trial and the Michigan PA trial have sort of looked at the cost effectiveness of the role of hosiery in the treatment and also the role of phlebectomies, but there are some key questions there to which there have been answers to date. We're all familiar very much with the various treatment options for endothermal ablation, and we know that actually they are all cost effective, but some are more cost effective than others, and it would seem that laser ablation is the most cost effective. There are many truths that no technique is perfect. Surgery may be better for some. Endothermal ablation techniques are probably the same, but the important thing is to manage the patient expectations. In the UK, there is now a further thing called the Evidence-Based Intervention Programme, and they have fully adopted the NICE guidance to get the various payers to pay for intervention. However, this has been interrupted by COVID. If we now move on to look at various aspects of deep vein thrombosis and emboli, we all know that VTE is a significant healthcare burden, particularly in the hospitalized population. And around the world, there have been programs so that we can look at patients' risk and see if we can identify high-risk groups and offer them appropriate prophylaxis. This is an example of the UK Department of Health questionnaire and also of the Caprini score that is often used in the United States. Venous thromboembolism is often a problem, and certainly in the UK, we rely a lot on the use of blood compression stockings, and we spend around about £64 million on them. However, they are often poorly fitting, and there's often poor compliance. We've previously shown that actually there is no adjuvant benefit in surgical patients of adding in stockings if the patients are receiving molecular weight heparin. There are various other studies that need to be formed looking at graduate compression stockings to see if there is any adjuvant benefit in the emergency patient, in those who are receiving prolonged chemoprophylaxis, and for those patients who are deemed to be at low risk, I have no risk factors, is there any benefit of graduate compression stockings? And these are all subject to ongoing trials. The post-thrombotic syndrome is again another thing that is often pertinent and is managed in different ways. We know that the standard of care is good anticoagulation, and what is also important to note is that the use of DOACs early can actually reduce the incidence of PTS and increase quality of life. What is the role of thrombolysis? NICE recommends it's something that we should consider, whereas the CHEST guidelines very much suggest it is something that you should not do with a grade 2B recommendation against it. If you look at the data from the CAVA and the CAVANT and the ATTRACT trials, you can see very clearly that there really is no benefit in terms of PTS other than at 5 years in the CAVANT trial. There has been, following the ATTRACT trial, there's been some discussion as to whether it reduces severity and decreases symptoms early on. However, what are the medical legal implications? Because there's certainly in the UK, as there's no really proven benefit, should you actually offer it as a... We did a survey and people felt that actually it was medically legally justifiable to use thrombolysis. But is it cost effective? That is something we yet really need to know, and probably it is a treatment option that will be dominating. If we look at mechanical interventions such as the use of stockings, both NICE and the chest guidelines recommend against the use of compression hosiery for people with DVT, and this is based on the SOX trial, which showed no clinical effectiveness. However, there were many people who have suggested that there are many trial problems with this. This has led us on to go and perform what is called the CHAPS trial in the UK, which is similar to the SOX trial, and this is an ongoing trial at present. If we then look at the post-thrombotic syndrome and the role of iliac vein stenting, one of the questions is this actually a cost-effective treatment? There are really no good evidence in favour. A review that we conducted suggested that it may be of some value, but we really do need some good RCT data, and you can just about speculate that it may be cost effective in treating patients with leg ulcers. So there are many challenges ahead, and I think it is important that we think about these. What is also important is how we actually deliver care, and we need to think about this very carefully. And what do we think about personalised medicine? Personalised medicine is something that is undoubtedly new and is here to stay. There are various avenues with respect to research, and I think it is important that we think about where the next steps with respect to research, and that venous disease is very similar to atherosclerosis inflammation. And there are lots of things that are being done with respect to the genome and the genome. Who should deliver venous care? Well, the answer is it should be a team who can conduct a full clinical and duplex assessment and offer a full range of treatments. What's important is the vascular surgeons actually need to take on the management of venous care and maybe not leave it to other people. It's interesting to note that if you look at vascular interventions, venous interventions are far more common than arterial interventions. It's also important that we should all be recording the outcomes of our interventions. And how should we train people? As I've said, in the UK, it's very much a vascular surgical speciality, but around the world, it is evidence that many other specialities may actually be offering treatment for patients, and the key thing is everybody is appropriately trained. You'll all be well aware that there was a international collaboration looking at who should or should not be treated during COVID, and there were guidelines that were developed which I think were applicable to many healthcare systems. Thank you very much for your kind attention.
Thank you, Alan, for that overview and explaining what we all need to do, what we're doing, and it's all ultimately comes down to doing something that's tailor-made and based on quite robust evidence. And we will now take the questions from the audience. And is there any question from the audience? If there's any question, please come over to the speakers there. All those who have presented are present online, and if there are any questions, yes, I see Deepak. Please go ahead.
I have a question for Alan, and actually we've been missing you here, Alan. This is probably the first Venous Association.
Sorry, Deepak, question is for?
Sorry, this is for Alan Davis.
Alan,
we're missing you here. We're probably the first Venous Association of India conference that you're not attending in real time. Okay. Thank you so much for coming in the virtual mode. I have a question for you. Is there a policy for preemptive prevention of varicose veins in women who are pregnant? You know what I mean? is there data that says that if you have, say, wear class 1 or class 2 stockings in the first or second trimester of pregnancy, they can actually prevent varicose veins? Because most of the varicose veins that we see in young women is postpartum. So is there any preventive role? Is there any evidence for that? Thank you so much.
Alan, you are muted. Alan, could you unmute yourself and talk?
As I know, I am unmuted. Can you hear me now?
Yes, we can hear you now.
As far as I am aware, there really is no evidence to suggest that prophylactic measures in pregnancy do anything to reduce the chances of the development of varicose veins or venous incompetence. However, I think there is some evidence to suggest that ladies do get some symptomatic relief during their pregnancy through wearing the stockings. So I think that, to the best of my knowledge, that's where the evidence is. NICE very clearly suggests that hosiery is the one treatment option that is available to pregnant ladies. And just to comment on that, I'm very sorry that COVID and all the various travel arrangements have actually stopped me from coming on. I know things are getting better, and I sincerely hope I will be able to come and join you all in person next year.
Thank you, Alan. The question for Peter. Peter, thank you for joining us. I know you're busy with the AVT. Are you seeing a decrease in the number of open varicose veins operations in the public system?
Yeah, I think we are, but I think it's not gone completely. There's a lot of push for, funders in both the public and private sector to try to reduce funding for, surgical ligation, stripping, but there still is a role. And I think the society, the ANZ Society of Vascular Surgery, is really keen to ensure that, and I think all your speakers have reflected this, that there are specific indications for those techniques. If those techniques disappear, then I think we are the poorer for it. I think if our concern is not so much about the reduction in open surgery, but rather the high numbers of venous stenting that's occurring. And I think Alan Davis has already mentioned the evidence is sparse, but the pressures for using venous stenting to try to minimize post-thrombotic syndrome without evidence is a big problem. It is a problem that I think countries like Australia, where we have access to venous stents and IVUS, etc., we have to take responsibility. The evidence base must be there. But surgical ligation, Prabhu, still remains an operation that we do.
Right. Peter, are you seeing an increase in venous stenting for NIVL, for the May Turners, as compared to the post-thrombotics?
So I think that's the troubling data we've seen from the Australasian Vascular Audit, that, a significant percentage of data recorded in our audit is for May Turners, NIVLs. And the criteria for diagnosis of May Turners remains, uncertain when we look at the data. So yes, Prabhu, I think that is a concern. Our concern also is the fact that this is occurring in the private sector, where there's less data capture. So as I said in my talk, I think, regardless of the procedures you perform in whatever specialty, there has to be a strong evidence base. It has to be focused on outcomes. And I think the work that NICE guidelines and CHEST, which Alan has published, are really the sort of thought leaders in terms of us appropriately using, these expensive technologies.
Thanks, Peter, because we've just been doing the same thing. The discussions have been reducing the frequency of venous stenting. So thank you, Peter. We have one more question from the floor. Ilya Kumar.
This question is for Dr. Javier from Mexico. Excellent talk, sir.
One small question. In the evaluation of this patient with PEBD, that's the term what we have this pelvic venous diseases. Your investigation of choice and any diagnostic criteria you strictly follow, that was the first part of the question. And patients with asymptomatic, particularly pregnancy, those pregnant women who come to you with these problems, will be your line of management, including a diagnostic criteria if you have?
Hello. Okay. In do you think in pregnancy patients?
Yeah, having pelvic venous disorders. When we begin
Okay, we have the patient in pregnancy state. We can offer to the patients the compressive therapy. After to the pregnancy, we can study to the patient and we can offer another kind of treatment because we need to be so invasive with this patient.
Yeah, thank you. But the first part of the question still remains. What is your investigative modality in normal patient with pelvic venous disorders? You prefer imaging, like perineal ultrasonogram, or?
Okay. The first study is to perform the ultrasound.
And do you have
The
any
transvaginal
ideas for
ultrasound
those?
is the best option to these patients.
Thank you.
Last question to Patricia. We noticed in your presentation that women seem to get more foam sclerotherapy and men get intravenous ablations. Is there a reason for the difference of treatment between men and women?
Yes. In our experience, we saw that we have better results in women than in men. And I think this is due to the different kind of vein wall. Especially in young men, you have much more the muscle part of the vein represented than in women. And that's the same reason why we prefer to perform sclerotherapy also in bigger veins in the older patients, because these patients has normally really very thinner vein wall. So they respond really very well to the this kind of treatment. This is our experience.
Thank you.
I know that there is not a really a scientific explanation in this. We have some work by Whiteley in which we see that if you can obtain a completely destroyment of all the three layers of the vein wall, you can obtain better results in sclerotherapy. And I think that the difference stands in this. You have much more muscle layer in men than in women. In the vein work.
Thank you for that.
So I thank all the 5 speakers, Peter, Patricia, Javier, Sandeep, and Alan, for being here with us today and giving an international flavor to a conference that usually would have seen you in physical presence, but that's all the more better to have it this way too. So please, thank you again, and thanks for being with us. So good night.
Thanks very much to everybody. Bye.
Bye. Bye-bye.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Thank you. With all my pleasure. Bye-bye.
Bye-bye.
Very much.
Thank you so much to our speakers. Thank you, Dr. Malay Patel and Dr. Prabhu Prem Kumar, the chairpersons of the session. Well, we'd like to move ahead to our next session. I'd like to request our chairperson, Dr. Sanjay Desai, to please step forward. Ladies and gentlemen, this session is very, very important. It is brought to you by Servier. We are looking out for Young Researcher Award. It is a competition. It is where the actual action begins. We have about 10 participants who are participating in this particular session, and the lookout is to figure out who the Young Researcher Award winner is going to be. And this entire session is being curated by Dr. Sanjay Desai. We've been waiting for this, and this is the moment, very, very important. I'm sure this is getting excited. And I'd like to remind our participants that the time limit per participant is 7 minutes only. 7 minutes only. We have our judges seated around the room, and we are about to begin this particular session. Over to Dr. Sanjay Desai.
Thank you. Can we have a small announcement for anybody outside to come in now, please? I think there are a lot of them on the stalls, so if we can request people to come in.
And to our presentation, presenters, please make a note. The time limit is 5 minutes for the presentation, and the last 2 minutes, the floor is open for Q&A. 5 minutes is the presentation. Last 2 minutes, the floor is open for the Q&A.
Yeah, so good evening. I think this is one of the sought after or most looked up sessions in the VAI. This is definitely an encouragement for the young training surgeons. It has really added value to their training because I've seen a lot of them who have participated in this, and they put quite a bit of effort, and any award or a reward, whatever it is, makes a lot of difference. It's like we all know, it's not what is behind it, but the recognition which comes with it. So we should be starting in some time now. Just to let you know, this is going to be judged. I am here to chair this. I'm one of the judges, and we have another 6 judges in the audience. A lot of them, I myself don't know who are judging, so you have people in the audience who will be judging you. And the questions can come from the audience. Anybody who is interested, at each end of each paper, you could ask the questions. The judging will be done as usual. We have divided into 50 marks, and 10 will be on the study design and the statistical analysis. The other 10 marks is for background methods, methodology, and the discussion. Timing of presentation carries 10, so I think everybody please take note of that. So your timing is important. If you go beyond time, there is some deduction. And contribution to innovation, how innovative is your topic, your research method, and the idea makes a difference. And of course, question and answers. Just for the young trainees and who are going to present, question and answers, please don't get bogged down whether you're right or wrong. You're trying to do a research work. You are trying to find out what something is better or may not be better. So please be frank, please be bold enough to answer the questions with what you know. Ignorance is not something we are here to know. If you don't know the question, you can always ask for clarity, or you can always tell what is your idea with this. That's how research grows. If we don't question, research never grows. So if everybody is ready, Prabhu, we can start. We can start? Okay. So we just have a little bit shift in order of presentations. I think by the time we get organized with the other presenters, I will call upon Dr. Nivedita Vitta to present. I think she was number 3 on the list. All judges, please note, this is Nivedita Vitta. No, sir, that's why I said there's a change in order. So on your list, kindly make a note who the presenter is. Yes, there was Piyush. Piyush we are just getting organized with his presentation, so that's why I said all the judges just make a note as and when the presenter comes. It is not on the order in which it was given before.
Good evening, everyone. I'm Nivedita from Ramaya, final year MCH student. So my topic is the modifications that we can make to 4-layer dressing to further benefit the patient. So as we know, venous ulcers are one of the most common causes of leg ulcers, and there is a very high recurrence rate which is associated with that. And 4-layer dressings have proven to have revolutionized the treatment of non-healing venous ulcers. So these are the basic principles of using a 4-layer dressing. Basically, for ambulant patients, a high pressure dressing is required, more so in case of associated lymphatic drainage. And sustained compression is required not only to empty, but also to avoid refilling. And current evidence shows that 4-layer dressings are the most effective and also cost-effective method of preventing recurrence and also in healing. So to prove the efficacy, we undertook a prospective study in Ramaya, and this included 70 patients. And our study showed that a maximum number of patients were in the age group of 41 to 50 with a moderately big ulcer. So this shows that it was a burden to these patients and their families, not only in terms of reduced work hours, but also the financial liability of the same. So with regular 4-layer dressings, we saw that these wounds healed much faster at 4, 8, and 12 weeks. So again, coming to reiterate the fact that conservative treatment with 4-layer dressings has shown to bring down the ambulatory venous pressures and helped heal these ulcers. So what can we do to make this better? So I propose the use of probiotics and specifically lactobacilli to improve the wound healing. So the proven mechanisms that are understood behind this are that lactobacillus or probiotics are non-pathogenic in nature. They have also been found to not interfere with the normal commensals, and it's supposed to bring down the edema and erythema associated with these ulcers. Another important factor is that it prevents infection. This is by creating an acidic medium in the site of the ulcer. So a neutral or an anaerobic medium which actually propagates the growth of other bacteria is taken care of by the application of these lactobacilli. And prevention of, and also another factor is the anti-inflammatory role. That is, they are seen to replace all the active inflammatory products with interleukin 8, which also helps in the elastin and the collagen deposition and improvement of wound healing. A major role of these proposed in the, by these lactobacilli is the prevention of biofilms. Biofilms are considered a major problem in healing of venous ulcers because of the large size of these venous ulcers and the associated multibacterial flora. So this is the definition of ideal wound dressing, and I would like to state that application of lactobacilli or probiotics does not interfere with the ideal wound healing dressing. So the aims of our study are basically to assess the effect on wound healing, to assess the effect on wound bacteriology, to negate the need for antibiotics, to bring down the overall financial burden, and as a corollary to also study the effect on specific bacteria, in this case Pseudomonas. So our inclusion criteria are venous ulcers, exclusion criteria are patients with peripheral vascular disease or other immunosuppressive diseases, and people who are not compliant. So the study design is that it would be conducted over a period of 1 year plus 1 month of follow-up. Patients would be randomized as odd and even, and tissues or swab culture with ABI will be taken at the initiation of treatment. Application of a generic probiotic or lactobacillus will be applied at each change of dressing after a generous and thorough wash with saline. And a 4-layer dressing would be applied by a trained professional. The ulcer size would be measured at every change of dressing, and a tissue swab or a swab culture is taken at every 4th, 8th, and 12th week or change of dressing. The time taken for wound healing would be measured, and whatever data is required will be calculated from the patient records. So these cards would be given to the patient, the green one for the patients on lactobacillus, the red one for those who are not, and as and when changes occur, those will be added to these cards. We anticipate a few confounding factors like use of antibiotics, whether oral or IV. This is during the study or 1 week prior, surgical or endovenous treatment that is associated lymphatic disease and specific bacteria. Endpoints of the study would be wound healing, that is these patients would be called back at 1 month and then assessed and termed wound healed. All standard of care will be borne by the patient and product used and culture will be by the study person. So these are my references. As we can see, it's been established use in burns and in chronic ischemic ulcers, also in fungal because most of these are in the lower limb, so associated fungal infection is possible. And apart from that, it is also seen to have multiple other uses. Most importantly, I would stress on replacing antibiotics is a possible outcome of use of lactobacilli. Thank you.
Thank you, Nivedita.
Thanks.
Any questions? Yes.
Excellent study.
Thank you, sir.
But are you comparing it with any other modalities like a 2-layer bandage?
So actually we looked into that, and what we found is that because of a prior pilot study that we did, most of our patients have a big ulcer with high exudative wounds. So we would prefer a 4-layer dressing over a 2-layer dressing, and as a study protocol we are including only 4-layer dressings, and the only variable would be lactobacillus application.
The second is, how do you document the improvement in the ulcer size, healing, and how long do you like to follow up this patient after they heal? The problem here is recurrence.
Yes, sir. So the size of the wound would be measured at every change of dressing, sir. For this, we would use a plotting graph, and based on that, a measurement would be done, and that would be kept in the patient records, a separate file for each patient. And the second question, sir?
How do you follow up these patients after they get healed? How
Yes,
long
sir.
do you want to keep them?
So one was the definition of a wound healing at the end of 1 month after epithelialization. And the second thing is, even though it is not part of the direct part of the study or our aim, these patients would be in our records and we would be following them up at a regular basis, because one extended study could possibly be if lactobacillus prevents recurrence or has any outcome on that. Because it has been shown to have a general well-being effect on the patient's healing.
And any topical antibiotics you are not planning?
No, sir. No, sir. That is the thing. If at all, IV or oral antibiotics.
Dr. Edwin.
Thanks, Sanjay. Nivedita here to your
Yes,
left.
sir. Yes.
Yeah, thank you for that study.
Thank you, sir.
In the abstract that you have presented, you had 145 patients. What is the number that you need to say that this is going to be effective or not effective?
Yes, sir. Sir, there was actually a little variation because of the submission criteria. But the thing is, we are taking over a period of 1 year, sir. So there are no acute numbers that we have calculated yet. But the thing is, over a period of 1 year, plus 1 month of follow-up, sir. So statistically, we haven't calculated the number of...
That's it. Well, no more questions. Thank you, Dr. Nivedita.
Thanks, sir.
One moment, sir. We do have Dr. Piyush who's joined us virtually. Dr. Piyush, if my voice is audible to you, you are requested to unmute and speak to us and let us know that you are ready for the presentation.
All the colleagues and seniors.
Over to the chairperson.
I'm sorry, I wasn't able to hear. It's echoing here. So it's Piyush's. Okay. So is he ready? Okay.
Yes, I just shared my screen.
Yes, Piyush, please. This is, just to note, this is Piyush. Piyush, we are...
Good afternoon, everyone.
We are audible to you?
Yes, sir.
All right.
You are.
Okay, Piyush, you can start.
So I am Dr. Piyush. I work in vascular surgery department in Fortis Hospital, Mohali. Today, I am going to present the initial outcomes of 1940 nanometer diode laser in the treatment of the epiphyseal veins. As we all know, endothermal laser ablation is now recommended as the first line treatment of varicose veins. And out of these veins, epiphyseal vein treatment with laser in itself is a new challenge because of its anatomical location. So this study is to find out the outcomes of treatment of epiphyseal veins with 1940 nanometer laser and using infinite fiber. This was a prospective observational study. We treated 25 patients, out of which 16 were females and 9 were males. and they had incompetent SFJ and with epiphyseal veins. We used 1940 nanometer diode laser and infinite 5-ring fiber to ablate these epiphyseal veins. We used this ringed fiber 1470 nanometer because it has proven to be having advantage over the other wavelengths. So the laser power was again set to the 5 watts with a mean linear endovenous energy density of 40 joules per centimeter. Also sufficient amount of tumescent anesthesia, around 300 to 400 ml, was put around properly around the epiphyseal vein. So we were looking for the closure rate, the post-operative pain, post-operative bruising, cord formation, and thrombophlebitis after the treatment of these epiphyseal veins with the laser. So after the 6 weeks, closure rate was 100%. And the VAS score was recorded intra-op and post-op, which was around 5 and 0.65 respectively. And also after 10 days and 6 weeks of the treatment, which was around 0.8 and 0.47 respectively. There were some complications which we encountered, and they were thrombophlebitis and bruises in approximately 18% of patients. There was no case of endovenous heat-induced thrombosis, but there was cord formation which was observed in 8 patients. So in conclusion, the 1940 nanometer laser and infinite fiber at 40 joules per centimeter showed satisfactory initial outcomes with less pain and fewer complications. We think that it can be a good alternate to foam sclerotherapy and phlebectomy. Also, this epiphyseal vein treatment should be done with utmost care, but further studies are required to find the efficacy of EVLA in epiphyseal veins. During my search, I could find a study which was published in July 2021 by Dr. Park, in which he treated these veins with Clarivane. Also, only thing which was feared was hyperpigmentation after such treatment of epiphyseal veins, but I could not find any study including laser treatment of the epiphyseal veins. Thank you.
Thank you, Piyush. Any questions from the floor? Well, Piyush, before Edwin reaches the mic, I'll ask you a question.
Thanks, sir.
Yeah, can we see Piyush, please? Piyush, you can stop sharing your screen.
Right, sir.
Just your video. Okay. We are audible to you, right?
Right, sir.
Yeah, Piyush. Just towards your conclusion, you said further studies would be needed to confirm your findings or make it a definitive treatment as an alternative. How would you intend, or is there a plan to have, what would you do if you had to further this study?
Basically, we have to find an appropriate treatment modality for the epiphyseal veins. Like we can use, as in the study by Dr. Park, he used Clarivane, that MOCA technique. Simultaneously, we can use just sclerotherapy or the laser treatment, and we should compare the outcomes with these modalities, at which modality is best for such kind of veins. So in our study, we used laser treatment to see the results, how it goes, because it is the standard for the other veins. So we thought that putting a good tumescent anesthesia and this 1940 nanometer laser fiber, using 5-ring and infinite fiber, we can get some good results. So we can compare these treatment modalities and come with the best treatment modality.
So you want to do a direct randomized study comparing head-on with the other alternatives?
Yes, sir.
All right, Piyush. Dr. Edwin.
Hi, Piyush. Thank you. Good study. A couple of questions. The first one is, what was the indication for treating the epiphyseal veins in these patients? What was the indication? Number one. And number two is, you found almost, what I would say, more than 15% of cord formation. So do you think wattage was a bit high? Would you recommend a lower wattage?
Sir, coming to this, the indication for treatment of these epiphyseal veins were like, these were the main veins which were leading to the varicosities, and those were directly linked to the vein leading to the SF junction, which was incompetent, leading to the main vein filling the varicosities. So that was the main indications that we should close these epiphyseal veins. And course of the GSV was in some cases partially intrafacial and partially epiphyseal. So we had to close these veins epiphyseally. And sir, could you repeat the second question?
You had about 15% or more of cord formation. So do you think the wattage was high?
It may be high. So we tried with the 5 watts and lead of 40 joules per centimeter, and putting a good anesthesia, we got this cord formations. But we think that yes, lowering the watts can result in a better result and non-formation of these cords. So we were just starting with this analgesics.
Piyush, can you just clarify what you mean by epiphyseal? Is it treatment of other varicosities apart from the long saphenous vein? Because I'm not clear what exactly you mean, what veins you are treating here.
So epiphyseal, the truncal vein which becomes epiphyseal, it's a GSV which becomes epiphyseal after the mid-thigh,
So
and leading to the distal varicosity.
And you combine it with other procedures like stab avulsions or on-table sclerotherapy or what?
Yes, sir. In addition, we do from sclerotherapies.
Sclerotherapy or stab avulsions?
Sclerotherapies.
You don't do stab avulsions?
No, sir.
Not even bulky varicose veins?
No.
So what percentage of foam you use, and how much is the volume you can use?
So like in each leg, like around 8 ml of foam, like 2 ml of liquid.
That's sufficient to
in each leg.
close all these veins, big veins?
So we try when we fix this truncal insufficiency. So we hope that most of the varicosities, they will reduce by themselves because of the closure of the truncal reflux. And most of them, yes, with 2 ml, we can close them, yes.
And you mentioned 300 to 400 ml of this thing, saline infiltration. What do you use, hand infiltration, or do you use a pump?
So we use a Klein pump, and usually 300 and 400 ml, it's the maximum because it totally depends upon the technique, how you put the tumescent anesthesia. So when you are very good at it, and you can just manage with like 100, 150 ml, and with a good formation of fluid tunnel around the vein.
What anesthesia do you use?
We use Ringal lactate and with lignocaine, 2%.
So no regional anesthesia or GA?
No regional anesthesia.
Thank you, Prakash. Thank you, Piyush. I see you're working, you're holding fort there, and thanks for joining us, and you can get back to work.
Thank you, sir. Thank you, sir.
All right. Are we on order now? Okay. So, Manohar, the next speaker will be Manohar. Dr. Manohar? Yes.
Good afternoon, everybody. I'm a vascular radiologist working with vascular surgeon in Western Maharashtra.
Requesting speakers to please come closer to the mic while speaking. Over to you, please.
My topic is ultrasound-guided suprafacial laser ablation of perforators. ULE is a well-established treatment for chronic venous insufficiency. There is strong evidence that interruption of the incompetent perforators minimizes the long-term sequelae of chronic venous insufficiency and reduces the recurrence of venous stasis and ulcerations. Objectives of our study are, it is logical to assume that definitive ultrasound-guided perforator ablation will yield similar results as that of ACPS. We are presenting our largest study about the ultrasound-guided suprafacial laser ablation of perforators with saphenous veins in single setting by ULA. This is a prospective study to determine whether ULA could be used solely to treat perforators above the fascia. Materials and methods. From January 2019 to November 2021, in 350 patients, 3,880 perforators were treated by ULA under spinal anesthesia in single center by team of radiologist and vascular surgeon. Inclusion criteria: perforator diameter equal to or more than 3.5 millimeter. Reflex on Doppler. CAP class 2 to 6 were included in this study. Exclusion criteria, that is thrombosed perforator, known case of DVT with partial thrombosis of perforator, local infections. Based on the locations, in thigh we have ablated 64 perforators, in the leg 3,709 perforators, and in the foot 107 perforators. All the patients were treated under spinal anesthesia. Logic V5 ultrasound system was used for localization and guidance for the puncture of the perforator. Perforators were punctured with 16 gauge Gelco under real-time ultrasound guidance. 1470 Vela system was used with bare fiber. This is the first image is normal competent perforator. In second image, the perforator is dilated with reflex on Doppler. Please play the video. Please play the video. This is how we are doing the puncture of the perforators. After putting the Gelco in the perforator above the level of fascia, the fiber was passed, this sheath was withdrawn. Saline infiltration was done around the perforator. Then we started the ablation. Please play. This is a residual perforator after ablation of the GSV. Please play the video. Again, same technique. The advantage of perivenous infiltration with ablation above the fascia is the fumes which are generated, they are going in the superficial veins instead of deep veins, with additive effect on the ablation. All the patients were admitted in the hospital for 1 day, and follow-up is done after 2 weeks. This is the ablated perforator with absent flow in the perforator. The second image is the flow is there below the level of fascia, and the flow is absent, that is thrombosed above the level of fascia. So results. In all the patients, single puncture was sufficient. 250 to 350 joules of energy was given depending on the diameter of the perforator. Treatment was successful in 3,635 perforators in single setting. That is about 93%. Residual perforators were treated in second setting during same session, resulting in 100% obliteration. After treatment, ultrasound surveillance within next few days confirmed that perforators were all occluded. Bruising noted at the site of perforator. There were no late complications. There is no published data about the suprafacial perforator ablation. So we have compared our study with recently published article by Gibbous et al. In 2020. We are having better results than this study about the perforator treatment. And why laser? Laser gives similar results as that of ACPS. Ultrasound-guided puncture of the perforators causes less trauma to the adjacent structures like muscles and nerves. Significant length of the draining superficial vein can also be ablated during the same session. Why suprafacial perforator ablation. There is safe distance from the deep veins in case of direct perforators. Perivenous infiltration disconnects the perforator from the deep veins temporarily. So the fumes will go in the superficial system and there will be additive effect. We can treat any number of perforators, postulating the risk of compartment syndrome in case of treatment of multiple perforators. This is safe technique. Adjacent muscles and neurovascular bundle get less thermal energy. In conclusion, all the disease perforators can be treated by ULE along the saphenous veins in all the cases above the fascia without any significant complications. It is safe, cost-effective with comfortable recovery while maintaining minimally invasive treatment. This is promising technique which will require more research and more practice. These are the references. Thank you.
Thank you, Manohar. Dr. Harinder?
Yeah, Dr. Manohar, thank you for the presentation. Now, you mentioned that you have treated C2 onwards.
Yes.
Treating perforators C2, C3 is not currently, the standard of care. And number two, you mentioned about the use of spinal and admission. So is that the usual for your hospital, that you admit all your patients?
Yeah, we are doing GSU ablation perforators in the same setting.
No,
because
no, I'm asking if you are supposing not doing the perforator, would you still admit and give spinal?
Yes, sir.
So that is the standard of care?
Yeah, we are doing...
So why are you treating C2, C3 perforators?
C1 patients, usually we advise conservative treatment or foam sclerotherapy for C1 patients.
No, but C2, C3 perforator doesn't need to be...
No, if there are incompetent perforators during...
Incompetent perforator, C2, C3, you don't need to do anything.
Yeah.
It's only when it is pathological. And you didn't mention about the duration of reflux. I presume you forgot. You mentioned about the size, but you did not mention about the duration of the reflux.
Okay. Yes.
Manohar, just on an average in a patient, here Manohar, Manohar to your left, here. On an average in a patient, how many perforators were done?
Around 8 to 10 patients in single limb.
In the single limb, yeah. Okay. Because I see that it says the largest number of
Yes.
what you are presenting.
Yes.
So we have about 350 patients and about 5,800 perforators.
Yes, sir.
So that will roughly amount to about 20 perforators per limb.
No, I'm talking about single limb, 7 to 8 perforators in single limb in bilateral cases.
So you're talking about 700 patients.
Average is about 15 to 20 perforators.
Per limb. Per limb.
So, can I ask you, so 15 to 20, so how much time do you take?
For surgery or perforator ablation?
No, like laser ablation.
Laser
and plus perforator.
For single limb, around 60 to 80 minutes.
You see, my thinking is what we have observed in the last 21 years, the more you do in these patients, the more complications patients has. Okay? And I really don't know that you need to close so many perforators in any limbs. And like, I think we should, now if you have stopped the study, then in future you should randomize the patients. In one limbs, you do maybe nothing. And then close 15 perforators, if you're closing maybe 7 to 8 perforators per leg, and then follow up these patients at 6 months to 1 year.
Yeah.
And then see, is there any benefit of closing so many perforators? Because at present, we need to know that what we are doing to the patients, it's not about only closing the perforator, is it helping the patients or not? Because there are a lot of studies which have shown that if the perforators are not incompetent, and if you close the main veins, the refluxing veins, then you don't need to treat the perforators in the follow-ups because of the venous hemodynamics. So, and also I personally am very against putting the spinals and putting 60 minutes to 90 minutes on one leg. If you're doing 2 legs, it means 2 hours of venous surgery. And definitely that will increase the incidence of DVT. So there are a lot of ifs and buts to my mind. I don't know, but what do you think about it?
The problem of our practice is we are practicing in remote areas. So there is one problem of cost. The other one is patient never come to follow up at design time. So whenever they come to us, they came with complications. This either the residual veins are thrombosed or there is ulcerations. So they want treatment, all the treatment in single setting.
All right, thank you, Dr. Miles. Sorry, we'll keep your question for the next. Okay, we'll move on to the next presenter. This is Dr. Gaita. Yes.
Good afternoon, everyone. This is Gaita Al-Mahrouqi, surgical resident from Oman Medical Specialty Board. Before I start my presentation, I would like to take the opportunity to thank the organizing committee for giving me the chance to present in today's conference, and I would like to thank my mentor, Dr. Edwin Steffen, for his guidance and support. The title of my study is Does a Patient Information Brochure Affect Willingness of Omani Women with Varicose Veins to be Examined by a Male Surgeon? It's a prospective randomized single-blind study. I'll start with a brief introduction. So varicose veins are not uncommon among Omani women. And what inspired me to proceed with the study is the fact that we don't have a female vascular surgeon in Oman. And it has been noticed in our outpatient clinic that the majority of our female patients are reluctant to be examined by a male surgeon, and therefore a management plan cannot be made. The main objective of the study is to assess the effect of an information brochure on patients' attitude, acceptance, and willingness to be examined by a male vascular surgeon in the presence of a chaperone. So the study was conducted over a period of 6 months, and we ended up having a total number of 100 Omani women. These patients were randomized into 2 groups using ODE and even medical record number. The experimental group received a booklet, and the control group did not receive any brochure. We looked at the age, the marital status, parity, tribe, occupation, and the sleep classification, and these patients were reviewed a week later by a male vascular surgeon who was blinded to this process. The booklet contained information about definition of varicose veins, risk factors, symptoms, classification of varicose veins, and the different diagnostic and treatment modalities. So out of the 50 patients in the experimental group, 74% of them felt that the brochure had influenced their acceptance to be examined by a male vascular surgeon, whereas the majority of the patients in the control group refused to be examined by a male vascular surgeon. And the p-value over here was less than 0.05. Unmarried women in both the groups were willing to be examined by a male surgeon. Age, number of parities, tribe, occupation, place of residency, and the sleep classification did not affect patients' decision to be examined by a male doctor. In conclusion, I would say that an information booklet about varicose veins is effective as a tool to improve level of acceptance toward examination by a male doctor among Omani women. By this, I reach to the end of my presentation. Thank you for listening, and I would like to invite you to visit our beautiful country, Oman. Thank you again.
Thank you. Should I ask?
Yeah.
Thank you. Just wanted to ask you, is in the booklet, do you mention that you will be examined by a male vascular surgeon? In the information booklet, do you mention anything like this, that you will be examined by a male vascular surgeon?
Thank you for your question. We did not mention that in the booklet, but we actually informed, like we got a consent from these patients, and therefore we informed them that, that they will be examined by a male surgeon, and they were told about the idea of the study.
Fine. And why do you think that after reading the booklet, the people are okay to be accepted by a male vascular surgeon? Like, why male? It could be, they would be, after reading the booklet, they could be more prone to be examined by anybody. Why you're saying by male vascular surgeon?
Felt that the knowledge actually would affect their willingness to be examined by a male vascular surgeon. So when they know about varicose veins and their complications and the consequences associated with the delay in the management, they would actually be more prone to be examined by a male vascular surgeon. So we wanted to look at the knowledge part of the study, the knowledge part of these patients and whether it would influence their acceptance if they were more knowledgeable.
Thank you. May I?
You mentioned about tribe as one of the, is there any particular tribe which is more prone for varicose veins?
Sorry, could you repeat the question again? I
Is
did
there
not
any
hear it.
particular tribe which is more prone for developing varicose veins?
No, we did not find any association between a specific tribe and the incidence of developing varicose veins.
You presented very well, Gaita. Thank you for that. But I'm not clear at all why information booklet about a disease should affect the patient's acceptance. Was the initial counseling done by a male or a female when the patient came to you?
Because the thing is that the culture in our country is a bit different. So most of the females won't agree to be examined by a male surgeon, and therefore a management plan would be delayed. So we thought that actually whenever we distribute those brochures and booklets, their knowledge about the varicose veins and the disease itself would actually improve, and they would know about the complications associated with the delay in the management of varicose veins, and therefore they would actually agree to be examined by a male vascular surgeon.
No, I understand that, but the logic behind knowing about a disease and deciding about the male or female surgeon escapes me. But thank you, you presented very well.
Thank you.
Thank you, Dr. Gaita. I think this is a point for all of us to note. I think research does not stop at just clinical work. I think part of this also forms a very much required aspect for a practitioner. So I think a very bold initiative. Congrats, Edwin. I think I know it must be your idea. So thank you, Dr. Gaita. So we'll move on to the next speaker, Dr. Samuel Prabhu. Yes, Dr. Prabhu. He's got a very short title, Veena Ed.
Respected teachers and my dear friends, my topic for the research proposal is to develop a calf pump stimulator which can be powered by a cell phone to aid in the treatment of venous diseases, and I would like to call it as the it's not working. And I would like to call it as the Veno-Aid. The presentation of venous diseases can range from asymptomatic to lifestyle-limiting limb edema or non-healing venous ulcers. Often the primary treatment, namely surgery, often addresses only a part of the problem. And most of these patients are advised long-term compression therapy, either in the form of compression bandages or stockings, manual lymphatic drainage, or pneumatic compression therapy. However, compression therapy has got its own limitations, as these cannot be used in patients who have got significant peripheral arterial disease or in heart failure, active infection, peripheral neuropathy, or as most of these patients are elderly who need some assistance to use these compression garments. And also definitely cost is also a major limiting factor. So the aims and objective of this present project is to provide a reliable alternative to compression therapy for the treatment of venous diseases. And the objectives are to develop a cell phone powered calf pump stimulator and to make it affordable and easily available alternative to compression therapy. So the calf pump stimulation has long been studied initially in the treatment of prevention of deep venous thrombosis with the help of these bulky instruments called thromboprophylaxis. And later on, when the calf pumps, significance of calf pump has been studied, it has been shown to correlate with the severity of the venous ulceration and also its significance in the role of lowering venous pressure in the lower limb. This is the cross section of the leg showing the 4 compartments of the leg, the anterolateral compartment being supplied by the common peroneal nerve. And once the common peroneal nerve is stimulated, it acts as a stimulant to the calf muscle pump, and it has shown to improve venous blood flow and reduce stasis in the lower limb. And it has the same concept as we used to reversal of the lower limb edema, and there has been with the usage of plethysmography. So there have been few instruments which have come into the market recently. This device is called a Gecko, and this also works with the same concept of stimulating common peroneal nerve. It has shown to accelerate the healing of the venous ulcers as well as in the edema. So what's the need for the present project, as already these devices are available? So they are not commonly available. And the second thing is a cost. The present device which I have shown, it costs around 3,000 rupees, and it works for 24 hours or 1 day. After that, it becomes dead and we have to replace the instrument. And why cell phone? So I thought cell phone would be a most accessible and a compact power supply to the device. So I would like to make use of the commonly available instruments like peripheral nerve stimulators used in anesthesia or transcutaneous electrical nerve stimulators and modify them according to the specified purpose. This is a tri-mode which a mode in coordination with physiotherapy as well as engineering method, where a TENS probe has been taken and modified it to be connected to a cell phone. And it has shown to give some initial promising results which are yet to be developed. And once a device is ready, we would like to do a randomized control trial, and with a sample size of 180. And there are inclusion criteria with patients of C3 to C6 disease, and exclusion criteria being the patients with significant arterial disease and acute deep DVT and patients who cannot understand how to apply this device. And outcomes would be either subjective by measuring the venous clinical severity score before and after using the device, and objective by measuring the limb girth and ulcer surface area. But the best would be a plethysmography. However, the feasibility and availability is not available. So there is a simplified flow chart where the patients would be diagnosed with C3 to C6 disease, and they would be assessed subjectively and objectively, and they would be randomized either to the calf pump group or as a routine compression therapy, and they would receive at least 50 milliamperes of current for at least 15 to 20 per minute for at least 4 hours per day. And once they have done this treatment, bi-weekly assessment would be done for at least 4 weeks, and then they would be assessed for 3 months, and then the data would be analyzed. So my conclusions are: calf pump stimulator, it can act as an important adjuvant in the treatment of venous diseases, and affordability, availability are the main limiting factors in its use. And the present project, if developed appropriately, can benefit a significant group of patients consulting vascular surgery. Thank you.
Thank you. Yes, Edwin.
Hi, Sam. Very nice presentation. Like the innovative side of it. With the nerve stimulators, you would have, it would be something that the patient would have to introduce, whereas the TENS can be applied over the skin surface. So are these patients going to go home with the electrodes? That's question one. How are you going to measure the amperage that you showed on your second last slide, I think it was, or the third last slide, that they would do this much time with this much wattage or amperage, because cell phones would have different battery
Yes,
lives. And the third question, lastly, in your pilot study, how long did that battery last on a cell phone when they were using it? How frequently did it need to be recharged?
Third question, sir.
The cell phone, how frequently did it need to be recharged?
Okay, sir. The first question, the patient will be given normal ECG electrodes, sir. You have to use the normal ECG electrodes, so I will give some ECG electrodes for him for use. And second question is the data which of the 50 milliamperes, and two studies. One study has done 5 hours per day for at least 5 days per week, sir. That's, they have done a study. I have not proposed a exact measurement. This machine which we have developed, we still don't know what is the current is producing, but we just known that the TENS cable can be connected to the cell phone and it's working. We are yet in the process, sir. And third question, sir. Charge depends on the cell phone only, sir.
this an Apple i13 or not? Okay, tell me something. Have you seen somebody using this in their routine practice?
Not routine practice. I used it on my grandfather, sir. Even myself, I just used it.
And why do you think we are not using it?
It was, you don't see them often, sir.
Why? Just think, like why we are not using it routinely? There is a Gico device available.
But multiple studies have shown even in arterial disease, they increase the capillary recruitment, and they have shown even in peripheral arterial disease it's useful, sir. But I'm just limiting. But I'm not sure, sir. But,
so what's the drawback of the compression stocking? So what's the advantage of this over compression stockings?
advantage being it can be used in peripheral arterial disease if you have significant arterial disease and heart failure, infection, and it can be a very portable thing, sir. It can be carried anywhere. And main thing, I find the patients who has a fixed ankle and very old people don't have any relatives with them, don't have money even to buy this. They have to change the stockings. They don't have. But this one, just a wire only, sir. That's all.
But you have to use it for 4 hours. So patient has to be lie down on the 4 hours?
No, sir. We can use it on work also, sir. During work also. I have used it myself also. It doesn't cause much of
but it causes the tingling, right? Yeah.
Yes, sir.
Have you used it on yourself?
Yeah, yeah.
It's a very bad feeling.
But only a few minutes it was bad, sir. Otherwise, we get accustomed, sir.
Thank you, Rahul. One quick question from
How
Prakash.
much is the cost of the device?
Which one, sir?
The watch you showed.
Watch is 3,000 rupees, sir. It comes as a 2 set, sir. Set of 2. It costs around 5,500 or 5,600, sir. It works only for 24 hours. Otherwise, it becomes dead.
24 hours?
24 hours. It's already set in. The battery works for 24 hours and after that it shuts down.
So for 3,000 rupees just for 24 hours?
Yeah, we have discarded.
It works for 6 days then?
24 hours, yes, sir. Yes, sir.
Thank you. Thank you, Samuel. All right, we have had 5 research papers down and we have another 5. Before we continue 5, we'll give the judges a small break. We'll just interrupt this for a launch of a book. I would invite on stage Dr. Rahul, Dr. Harinder Bedi, and Dr. Gurjit, please. This is just a small interruption. We'll continue with the papers.
I'd like to invite Dr. Harinder Bedi, Dr. Deepak Selvaraj, Dr. Sanjay Desai, Dr. Gulshan Jeet, and Dr. Raul Jindal to please join us on the stage. We are releasing a magazine which is going to be a pioneer that is launched by Wycon, and this particular magazine will be distributed across all the corporate hospitals in India, and the magazine is titled as Venus and the magazine is titled as Dialogue. We do have with us Dr. S. Maruthu Durai, State Coordinator, Tamil Nadu Accident and Emergency Care Initiative, National Health Mission from Tamil Nadu, joining us here today. Pleasure to have you with us, sir. A round of applause to all our dignitaries on the dais. And to all our dignitaries, I'd now like to request to launch the book. And I'd like to request Dr. S. Maruthu Durai to lead it through.
I'll give a very short introduction.
Yes, over to you.
March, sir, as you, I'm sure you are more aware than us, is DVT Awareness Month. And this is after the journalist, Mr. Bloom, David Bloom, who died. And this is the aim of all vascular societies, to create awareness about a disease which is so easily preventable. And we are really honored that Dr. Durai, who is the NHM Director for the Government of India, is with us. So over to you, Dr. Durai.
I am at my home in this vascular surgeons conclave, and I am very happy to present to the President of Venous Association of India a government order enacted by the Government of Tamil Nadu, observing October 13th as the World Thrombosis Day, commemorating the birthday of renowned Sir Rudolf Virchow. this has been issued as a GO, and this is example of government's commitment to the cause of spreading awareness on DVT, as well as adopting top priority to this killer disease in Tamil Nadu health system. So on behalf of National Health Mission and the mission director, I present the GO to the President of Venous Association of India. Thank you.
Thank you so much to all our dignitaries on the dais. I would like to request all of you to pose for a group photograph.
Just like to share a few words here. We are honored to have Dr. Marudhu here. He is one of the senior vascular surgeons in the Tamil Nadu Vascular Society, and he has been a role model to all of us, and not only as a person but as a father, as a parent, as a vascular surgeon. And he has told us how vascular surgery is to be done and how we should look at vascular surgery in the future. Now, we have brought up this magazine because the consortium of accredited hospitals all over the country want to implement venous thromboembolism prevention in a big way. And that is the only reason that we have brought out this magazine in the DVT month. This is March. March is the DVT month. And it has order set tables and everything, including Crapini score and Padua score, and which will probably be implemented in the next few months or in the next year or so across hospitals all over the country. And it will tell hospitals when a patient comes in, medical or surgical, what kind of DVT prophylaxis that you are supposed to give. And we are trying to implement this from the top, from a NABH, and we are hoping the National Health Mission will help us in this as well. Thank you.
Thank you. Once again, a round of applause, please.
We will continue with the sessions now.
We will. Thank you once again to all our dignitaries. We would now hand over the stage to Dr. Sanjay Desai. Once again, over to you.
Thank you. While they take positions back. All right, I think we'll have the sixth paper. Dr. Athirit Reddy will be talking about cephalic vein distensibility. Dr. Athirit. Is he virtual?
So he's coming virtual. There is a small technical glitch. So can we go on to the next presentation and we'll have him in the last.
Okay, so. Okay, by the time Reddy gets, we'll get another Dr. Reddy here, if he is here. Dr. Gnanendra Reddy, please.
Good evening to all. I'm Dr. Gnanendra Reddy from the Department of Vascular Surgery from CMC. My research topic is objective assessment of improvement in health-related quality of life by surveillance in patients with complex vascular malformations. Vascular malformations are rare structural anomalies of the blood and lymphatic vessels. They have been classified by International Society for the Study on Vascular Anomalies, which was last updated in June 14. They include venous malformations, lymphatic malformations, arteriovenous malformations. They are present at birth and can appear in childhood or in adults. They can cause diverse problems to the patients like chronic pain, anemia, disfiguration, recurrent infections, coagulopathies, organ dysfunction, or even death. Patients can present progressive clinical symptoms and worsening quality of life. Traditional therapies include interventional, such as embolization, sclerotherapy, or surgical. However, extensive and infiltrating lesions are not available for such treatment. In these patients, sirolimus mTOR inhibitor was proven effective by studies in case series. This is a prospective monocentric study which was published in 2008. In this 9 patients were administered sirolimus on continuous daily dosing and then subsequently followed up. Sirolimus was found to be efficient in these extensive vascular malformations that were refractory to conventional treatments and was well tolerated. Another study was a retrospective review of 41 patients who were treated with sirolimus from January 2011 to December 2015. There was a successful response rate of 80% in improvement in both radiological imaging and reduction of symptoms. The recent study is a performance trial which was published in 2021. This is a multi-center observational randomized controlled trial which was performed over 11 tertiary hospital centers in France over a period of 3 years. Overall, sirolimus had positive effects on brain, especially for combined malformations around bleeding, oozing, synthesis efficacy, and quality of life. Sirolimus has been proven to improve the health-related quality of life in these patients. Health-related quality of life does not deal only with health-related matters, but also non-health-related areas such as job, family, friends, and other situations in life. It includes both objective and subjective components. There are no studies in India as yet to assess the improvement in health-related quality of life in patients receiving sirolimus for complex vascular malformations. The purpose of my study is to assess the improvement in health-related quality of life in these patients with complex vascular malformations who are receiving sirolimus in our tertiary healthcare center. The objectives are to assess improvement in health-related quality of life using available questionnaire. Here it is SF36 is used to assess safety and efficacy of sirolimus in complex vascular malformations. Inclusion criteria are patients age greater than 18 years with symptomatic slow-flow vascular malformations that were refractory to or are considered unsuitable to the standard care. Exclusion criteria include severe concurrent or uncontrolled diseases like cardiomyopathy, diabetes, hypertension, infection, HIV, gastrointestinal disorders that might modify sirolimus absorption, pregnancy or lactation for women, surgical resection or sclerotherapy within the peer 4 weeks, and the peer use of mTOR inhibitor. The study will be a prospective observational study in the Department of Vascular Surgery at CMC level. The study will be conducted over a period of 1 year with a target sample size of 30 patients. Suitable patients will be initiated on sirolimus at 0.8 mg per square meter per surface area. After 1 week of treatment, sirolimus level is measured and daily sirolimus dose is adapted to reach the blood level between 1 to 50 nanogram per ml. It will be followed up every month for 3 months and 3 months thereafter. HRQOL improvement is assessed using the SF36 questionnaire at 6 months and 12 months. SF36, as the name implies, is an application 36 questions. This will be handed over in a printed or in a digital format to the patients in the language they can understand. The results will be assessed using the appropriate statistical analysis using SPSS 20 software. This is the basic format of the SF36 questionnaire. Sirolimus is proved to be effective treatment modality in patients with slow-flow vascular malformations. SF36 is widely used questionnaire to assess the health-related quality of life, and it can be used to quantify the effectiveness of sirolimus in these patients. Thank you all for your attention.
Thank you, Dr. Reddy. Edwin? Okay. Can we have a mic with Edwin, please? You can pick that, Edwin.
Yeah. I'll take this one. Thank you, Gyanendra. Good study. My questions are you going to give this to patients post-intervention or those who are not suitable for intervention? You're muted, I think.
It will be given to the patients who are not suitable for interventions. These patients usually come initially to our OPD and we will send them to the intervention radiology team. So many patients undergo the diagnostic angiogram or minogram, and it seems like very extensive or due to any other cause, they seem we communicate with the radiology team, and when they say that it's not suitable for sclerotherapy or any embolization, then we can straight away start sirolimus starting the sirolimus in these patients. And in some patients who are receiving the sclerotherapy in the initial episodes, and then after the few sessions, they might not get benefited much with sclerotherapy. So in also these patients also we are starting the sirolimus.
And how do you plan to monitor adverse effects? Any blood tests or anything that you'd be doing?
Sir, at the start, at the baseline, before starting, we are doing the lipid profile and platelet counts, and to see for the bone marrow at the baseline value, and also the liver function test. And after that, we'll be checking after starting the sirolimus. At the initial 1 week, we are repeating these tests, and we are following thereafter every monthly for 3 months, and then after 3 monthly to follow it.
And finally, what's the duration of sirolimus you're going to give for these patients?
Actually, there are such many studies, but there are no any studies which have given the finite period for this sirolimus duration. But many patients may require the long-term duration, maybe even the lifelong, and we should monitor for any adverse effects. In which case, we might need to modify the dose also.
So, what dose you are going to use? So, what are the doses you are going to use in this?
So we are starting off with 0.8 mg per square meter body surface area, and then we are monitoring after 1 week with the sirolimus serum values of sirolimus. And then we are if the values doesn't reach in that level, and then we are going to increase to 1 mg per square body surface area.
Yeah. If some patient is found to have a high sirolimus value, what will you do? Will you stop and restart, or completely what's your strategy in this patient?
So we'll see for if the patient is developing if the patient is developing any complications, and we'll again mainly the clinical profile and investigations, if he's having any bone marrow depression or any high lipid profile abnormality or liver function test we are seeing. And if it is too high, then actually we didn't encounter much, but the literature they say that we can stop the sirolimus for some days, and then we can repeat the sirolimus values, and again we start again the sirolimus. But we have not encountered such high levels of any sirolimus.
It comes as tablets, is it? Because I've not used before. I've only heard of propranolol. What strength tablet does it come, sirolimus? Tablet or a solution? How do you give it?
It comes as a tablet.
What strength?
It comes as 1 mg tablet. It comes.
It's also available as a syrup.
Thank you.
We have used it in the kids.
Thank you, Dr. Gnanendra.
I just have one question.
Sorry, Deepak has got a question. One last question. Yes,
Narendra
Deepak.
is my trainee, but anyway, I want to ask him a question. Narendra, what is the molecular basis of using sirolimus in venous malformations and AVMs? What is the molecular basis? Why are you using sirolimus then?
Sirolimus actually, it is anti-proliferative agent, sir. It acts on, it is a mammalian target of rapamycin inhibitor, which inhibits the PI3K and APT pathway, which is responsible for the proliferation. So these vascular malformations, even though these are not proliferative tumors, other like vascular tumors, but it is seen that the sirolimus has shown good improvement clinically and also radiologically in these malformations and slow flow AV malformations. But it is not effective in high flow AV malformations.
Thank you.
Thank
One of
you.
the concept is to treat AVMs and huge VMs as tumors, vascular tumors. So that's where you're bringing in sirolimus and all this gene modulation and all these things. So that's where you have to make a distinguish between normal venous malformations and venous malformations which are very large in AVMs, which have genetic ramifications. So that's where you are introducing sirolimus. So you have to be very clear on which patients you can use sirolimus and which patients you can not use sirolimus. So are you doing any genetic testing on these patients prior to using sirolimus?
So these patients we are referring to hematology, and we are doing the we are following up with the hematology, sir. We are integrating with hematology, and we are doing the genetic testing in these patients.
So recalcitrant tumors, recalcitrant patients with AVM, and patients who have ulcers, and patients who we are not able to treat by standard operating procedures and standard procedures, we are referring them to hematology and getting an opinion and then doing it. You have to be very clear on what you are trying to say. Which
All right.
patient you are using, which patient not using.
Thank you, Deepak. Is Dr. Adirath ready now? Sam? We're going to Ankush Sharma. So judges, please note, I think we're going to Ankush Sharma. This is paper 7. Dr. Ankush Sharma.
Am I audible, sir? Good evening, sir.
Yes, Ankush, you're audible. Your slides are visible. Yes. Number 7.
Good evening,
Number
everyone.
8. Yes.
Good evening, everyone. I'm Dr. Ankush, a surgery resident from the Banaras Hindu University, Varanasi. Today, I'm going to present a gene expression study in venous ulcer. Regarding the background, as we know, there is a necrosis of the extracellular matrix. Previously, the things which were included, that matrix metalloproteinases, specifically 1, 2, 8, and 9, which play a significant role, and also the cytokines various like vascular endothelial growth factors and TNF alpha. In this study, I have considered 4 genes, that is E2F1, RAD21, NIPBL, and VACMAR1 gene. Regarding the E2F1, this hinders with the skin wound healing by suppressing the vascular endothelial growth factor expression, also the neovascularization and macrophage recruitment. The RAD21 and NIPBL gene, both of them play a significant role in the sister chromatid cohesion and during the mitosis process. The VACMAR1 gene, this gene plays a crucial role in the keratinocyte migration, and the deficiency of this protein impairs the wound reepithelialization. The aim of the study is to analyze gene expression. That the genes undertaken are the RAD21, VACMAR1, E2F1, NIPBL in patients with venous ulcers. It is a prospective, observational, analytical, hospital-based study. 30 patients were taken into consideration. Inclusion criteria: patients diagnosed with venous ulcer between age 18 to 50 years. Those were excluded were having arterial insufficiency, lower limb filariasis, pregnancy, and diabetic foot ulcers. Wedge biopsy was taken at the start of the treatment in all the patients, and second sample was taken after 50% reduction in size of the healing ulcer or after 2 to 6 months in non-healing ulcers. This is the gene sequence for the primers of the genes undertaken from the standard NCBI database. Tissue sample collected was stored at -80°C, thawed and dissected into small pieces. Standard RNA extraction protocol was followed. The integrity of the RNA was assessed using 1% agarose gel, and the RNA was analyzed by one-step RT-PCR, and the control gene was taken as the beta-actin gene. The CT values were collected and assessed. The RNA, this is the gel electrophoresis showing the intact RNA, that is the ribosomal RNA 28 and 18S in the different samples. The statistical comparison using GraphPad Prism version 8.0.2 and the p-value of less than 0.5 considered significant. The RAD21 gene expression was significantly increased in the healing as compared to non-healing ulcer, and also in the treated patient after treatment, and the same as that of NIPBL gene, the expression has been significantly increased in healing ulcer as compared to non-healing, but not significantly increased, though the expression were increased after treatment. There were no expression seen of the E2F1 and VACMAR gene. This is the bar graph showing NIPBL and RAD21 gene related to the beta-actin gene post-treatment. This is the crux of the study, in which the RAD21 gene expression increased significantly in tissue sample from venous ulcer patient post-treatment. The NIPBL gene follows the same, but the VACMAR1 and E2F1 were noticed without any expression in pre or post-treatment part. As we know, venous ulcers were slow to heal and cause significant morbidity and impact on quality of life. The gene expression studied for ulcer healing are therefore important in helping to identify the potential slow healers who might benefit most from the newer treatment options. These genetic expression profiles displayed here may have implications for the development of the novel therapies for venous leg ulcers, or the expressions may act as the prognostic indicator for the venous ulcer healing. The interpretation I've already told, RAD21 and NIPBL gene in healing venous ulcer were relatively expressed more as compared to the non-healing ulcer. The future points can be these genetic expression can act as a potential point for the targeted therapy to promote healing and also the prognostic factor. Thank you.
Thank you. Dr. Edwin again.
Didn't get his name. So, sorry, very nice study. Thank you. Something new. You said that this could act like a predictive or a prognostic factor. How? Because it's only after the intervention that you know that the expression of a certain gene signature has become more visible.
Sir, we have collected the sample before giving foliar compression therapy to the patient, and the expression were noted, and then after giving treatment, that is foliar bandage in healing, or 2 to 6 months after in non-healing ulcer, we have again checked the expression of these genes, and then we have compared whether they are significantly increased or not. We are checking the expression both pre-treatment as well as post-treatment.
May I know what the cost of the test is?
Sir, it is an experimental thing, sir. It has been totally under the surgery department of Banaras in the university, sir, actually.
So did you do a cost analysis roughly? I mean, some idea how much it might cost? No.
Sir, in 30 patients, it cost overall around 60,000, sir.
Okay. So
pre and post treatment.
So basically, the patient has to do the test before intervention, then another test after that, for us to know whether it will benefit or not.
Currently, yes, sir.
Okay. Thank you.
Thank you so much. I just want to say that this is a very wonderful study that you have done, and
thank you.
Gene expression in venous ulcers has been of a lot of interest to the Venous Association of India. And especially RAD21, is it? That's the gene that we're all very interested in. And why do some people have venous ulcers and some people with completely blocked veins? They have no veins at all. They are deep veins. There's no deep veins, but they don't have ulcers. I've had several patients who have no deep veins, but they don't have ulcers. They have symptoms, but they don't have ulcers. So there's a lot of things that we don't understand in venous disease, and I'm really grateful that you brought something very important, that there's a genetic component to all these venous ulcers. And I think you should actually take this forward and make it a multicentric study.
Yes. Sure, sir.
Excellent study. One small doubt, how specific is this gene to venous ulcer? One. Another is, do you simultaneously look for the FOX gene? There is supposed to be one of the genetic gene expression in varicose veins. Since you are already investigating, do you have a subgroup study or something like that in this?
So regarding the first question, this specificity of these genes, actually these genes has been studied earlier in the mitosis process and the cell cycle process, and in relation to the other ulcers, but no previous surgery study related to the venous ulcer has not been anywhere in the journals regarding these genes related to the venous ulcer, and I have not underwent any other genes. Only these 4 genes has been studied in these studies. No side genes were studied.
All right. Thank you. Thank you very much, Ankush.
Thank you, sir.
Thank you. So we will move on to the next paper, Dr. Vishwanath Etria.
Good evening, everyone. I am Vishwanath from Care Hospitals, Hyderabad, and I shall present our work on prevalence of deep vein disease in patients with chronic venous insufficiency and a comparative study between MR venography and IVUS. Chronic venous disease affects 5 to 20% of the global population. Management of patients who develop CVD secondary to deep vein lesions remains a clinical challenge with respect to patient selection, diagnosis, treatment, and prognosis. There are very few studies regarding prevalence of such lesions in CVD patients, and there is no published Indian data in this regard. Our aim was to study the prevalence of non-thrombotic deep vein lesions in patients with chronic venous insufficiency using MR venography and to compare MR venography to IVUS, which is considered the gold standard. So we conducted this prospective pragmatic study with 132 patients in our department from November 2019 to September 2021. We used descriptive statistics and used Microsoft Excel for data analysis. The mean age of our study group was around 50 years, with most of the patients in 6th and 7th decades of life. Majority of our patients were male and were overweight with a mean BMI of around 30. About 40% of the patients had either left-sided disease or bilateral symptoms each, and half of the patients belonged to stage C4 of the SEEP classification. GSV reflex was the most common pattern of reflex seen in our half of the patients, and about 37% of the patients did not have any reflex on their duplex scan. All the patients underwent 2D non-contrast MRV time of flight imaging in supine position. About half of the patients had stenotic lesions, while 6% of the patients had occlusive venous disease. 42% of the MRVs were normal for deep vein disease. Left common iliac vein stenosis was the most common lesion found in about 40% of our patients. Prevalence of deep vein disease was high in patients younger than 30 years, those with a normal BMI compared to the obese, those with left-sided symptoms, in patients with venous ulcers, and in patients who did not have reflex on duplex examination. All these groups had a prevalence of around 60% or more. About 1/3 of the patients with recurrent varicose veins had deep vein lesions on MR venogram. 25 patients among these underwent IVUS examination of their deep veins with Phillips Volcano system. 19 patients had a positive IVUS and 3 had a negative IVUS for deep vein disease when they had a positive MR venogram. 3 patients had a negative MR venogram as well as IVUS. So when MRV was compared to IVUS, it had a high sensitivity and a negative predictive value, but not very high specificity for deep vein disease. So the limitations of our study are a small sample size when comparing IVUS to MR venogram. Ours is a pragmatic study and results may not reflect the true prevalence of deep vein lesions in patients with chronic venous insufficiency, but they do reflect what can be expected in a daily clinical setting. We did not follow any set criteria to select patients for MR venogram. It all depended on clinicians' intuition and patients' acceptance. So there is a selection bias in our study, and limitations of MRV are inherent to our study. So there are 4 studies which reported prevalence of deep vein lesions in CVD patients, and all of them reported a prevalence around 20 to 60%. One study that compared MR venogram to IVUS reported a similar high sensitivity of MR venogram in diagnosing proximal deep vein lesions. So to conclude, within the limitations of the study and MR venogram, the prevalence of deep vein disease is high in patients with chronic venous insufficiency. MR venogram has an excellent potential as a screening tool in diagnosis of these lesions. Patients with venous ulcer, recurrent disease, absence of venous reflex on their duplex scans, left-sided symptoms may benefit from evaluation of deep venous system before intervention. Thank you.
Thank you, Vishwanath.
Thank you, sir. Can you hear me, sir?
Yes, we can.
Yeah.
Okay. Yeah, before that, just one question. What deep venous disease or insufficiency are you looking for in your MR venography?
We were looking for proximal deep vein obstructive or stenotic lesions, mostly stenotic lesions.
So mostly stenotic or obstructive lesions?
Yes, sir, in the islet veins.
So not looking at reflux?
Reflex we anyways evaluate in the with the duplex scan in our clinic.
Okay, so what you're trying to say is that you're selecting these patients as a non-invasive module before you take them for IVUS. Is that
IVUS, yes,
what
sir.
is your
Yes.
conclusion? So,
Yes,
and
yes.
obstruction is what you're looking for?
Yes, sir.
All right. Edwin had a question? No, okay. Any other questions? Dr. Doraraj, sir?
What was the status of the valves in IBS findings? Were they competent or just incompetent valves?
We did not look at the, we did not report the nature of the valves on IVUS, sir. We were looking at the cross-section areas and the diameters. That is what we are looking on IVUS.
Chronic venous insufficiency major may be due to valve reflex or valve insufficiency or hypoplastic valves.
Yes, sir, that is true. But when Dr. Raju and Neglin, when they reported in them, they told that the correction of obstruction will itself correct the reflex itself, and there is no need to look for reflex specifically. So we did not look for deep vein reflex on IVUS or the valve status. We were looking for stenotic lesions only.
Good evening. Excellent study. But one small doubt is, do you have any scoring systems before taking up this patient for such an invasive modality of investigation 1?
Yes, sir.
And 2, do you just randomly choose, because you yourself said there is a selection bias, right? So what stage of clinical disease, or if it is a PTS, what is it, moderate Villalta score or a severe Villalta score? Those patients you take it for
No, sir.
invasive?
We excluded all the patients with DVT or previous history of DVT because that will skew the results towards a higher prevalence. Because when you have a PTS, we obviously are going to find more deep vein lesions because of the residual thrombosis or so. So we are not looking at lesions in patients who had a history of DVT. This is for patients with pure venous disease without a history of DVT.
So NVIL you are looking at, is it?
Yes, sir, NVIL, yes.
All right, thank you so much.
Thank you, sir.
We'll move on to the next paper. Okay, Dr. Hanish Kataria, please. He's going to talk to us about feasibility study of virtual management of venous ulcers.
Good evening all. I'm Dr. Hanish Kataria, MCH Registrar in Department of Vascular Surgery at CMC Vellore. And topic for my research proposal is feasibility study of virtual management of venous ulcers. I don't have any disclosure or any conflict of interest. As we all know, venous ulcers, they account for approximate 70% of lower extremity ulcerations. And they are often recurrent and they can persist for weeks to years. And despite low prevalence of 1 to 2%, they have a significant socioeconomic impact due to the cost of the treatment involved and the patient loss of working days. So assessment of any ulcer is based on the quantitative and qualitative evaluation. So in clinical practice, acetate dressing is the standard technique used for measuring the wound surface area. However, it is not possible to use in daily practice due to the non-availability of the material and contamination of the wound, and it is time consuming. Then the digital photography with the post-processing software have been developed for the wound assessment, but this is possible only in the either the institutional setting or in the hospital practice. So then recently the planimetry techniques which are developed with the mobile health apps, they are used to overcome these difficulties. So in a study published in Journal of Vascular Surgery Cases and Innovation Technique 2021, 85 wound assessment were done and using the smartphone-based app, and they were compared with the digital photography and the post-processing software. And they analyzed, they concluded that there is a smartphone-based app, they have excellent accuracy in measuring the wound surface area using these methods. However, there are no reported studies in India for management of chronic wounds using the smartphone-based technology. So purpose of this study is to assess the feasibility of the venous ulcer management using smartphone-based app and telemedicine facility at tertiary level care center. So objective is to assess the ulcer healing in patient with a primary venous insufficiency and to assess the willingness to use technology and patient satisfaction using the client satisfaction score 8. So all the patients with active venous ulcers who had undergone either the endoablation or sclerotherapy or undergoing conservative management will be included in the study. And patient with the post-thrombotic limbs or ulcer with the circumferential shapes or patient without smartphones will be excluded from the study. Now this will be a prospective observational study in the Department of Vascular Surgery at CMC Vellore, and with the target population of 40 patients and with the time limit of 6 months. And willingness to use technology will be assessed by a simple questionnaire during the first visit at the hospital. This is a specific questionnaire which is about the usability or availability of the smartphones and the usability of the smartphones for the patient. Then wound assessment will be done by healthcare professional at first visit using the ImitoMeasure app, which is available free of cost on the iOS and the Android platform. And this app has an inbuilt photographic technology, and wound area will be assessed after taking the photograph, and basically you can encircle the wound with the finger and you can take the circumference and the area of the wound. After the initial assessment by healthcare professional, rest of the assessments will be made by the patient or relative. They will be given the proper training for using the app, then measuring the wound area at home. And standard care of treatment will be taught for each patient after appropriate intervention or about the conservative management. Then wound report will be shared via email every week, and patient will be consulted once or twice weekly via teleconsult facility for the follow-up. So patient satisfaction will be assessed by client satisfaction score, which was used in Middle East for wound assessment in the hospital settings, but because of the simplicity of score, it can be used in the virtual setting also. And healing rate will be assessed every week for 8 to 12 weeks. Now, rationale for the study is this mobile health app, particularly ImitoMeasure, have been already validated, and it is a reproducible app and have been assessed for the wound in different scenarios in the West already. And regarding the patient usability of the smartphone application, it has been found in one study that it took only 4.7 minutes on the training and 5 minutes to complete the session. And 56% of the patients were able to complete the app independently. So the patient who are attending the tertiary level care center, they are basically from far away states. So it is difficult to come for the patient, and this study is basically to make the treatment of venous ulcer cost effective and to decrease the loss of working days. So in discussion, I'll say that smartphone incorporating high definition cameras are already available and can be used for clinical applications, and they can be used as a point of care tool for assessing the healing of venous ulcers. And this study will help us in the development of wound assessment app for the Indian patient in near future. Thank you.
Thank you, Anish. We have had very serious problems with these apps and the digital photography measurements, which we have used the actual cameras, not the apps. And every time you mark, the cursor tends to move away. And there is a human component in it because you are the one who are pointing out and telling where the edges are to be measured. So how do we get over that problem?
Definitely, sir. This is like the ultrasound. It is also a operator dependent. It is also app. So it's operator dependent. That's why the training will be given and it will be seen for every patient or the relative. If the patients are not cannot use the smartphones properly, then one of the relative like son, daughter, they can use it effectively. And we have already tried on 2 to 3 patients which are sending by WhatsApp messages. And initially 1 or 2 times we have some different, that area has come more or less. So, but with every week, we are seeing a change that the reports are, means it is correct measurement is done.
No, definitely. I mean, I'm not telling you, because this is a problem with digital, because we have seen over the last decade, it's always been a problem measuring. One of the ways to get over it is to have it blinded. You know, get the photograph to a third person who's blinded and he does the marking. So
Okay,
that's the best way to have a authentic research.
Yes, sir.
And analyzed.
So first, basically, we are first. There is no study for published at least for use that whether we can use or not. So this is a feasibility study for assessing that whether we can use these app in our Indian patients. So after that, definitely, first we will check the feasibility, and then second will be to compare it with the conservative, with the patient who are coming to hospital. So that will be the second step. And along with that, if it is feasible, then we can develop an app for the Indian patient, because only 1 or 2 apps which is available free of cost. Rest are all like in West, they have associated with the particular university or like that, so you cannot use them.
Yeah, there are a lot of challenges,
Yes, sir.
including the distance you take the picture,
Yes, sir,
how
yes, sir.
far you're taking
Definitely,
it,
sir.
what light is there. So there are a lot of issues, because we
Yes,
have
sir.
gone through this. It's still refining.
Yes,
but, good to know that there is an app. What's it called? Imito.
Imito
app.
Measure.
Imito app.
Yeah.
Okay. Yes, Edwin.
Thanks, Anish. Moving with the times, that's good. What was the reason or the basis behind dropping out patients with post-thrombotic limbs or ulcers with circumferential shapes?
First, so patient with the post-thrombotic limbs, the ulcers, they are difficult to heal and they need further assessment and maybe other intervention. So that's why we have not included those patients. And with the circumferential shape, obviously if we are taking photograph, we will not be able to take the photograph of a circumferential shape of the circumferential ulcer which is present all around the leg. So it is difficult to measure the area. That is the reason behind.
I think the second one completely acceptable, but if your app is meant to only assess whether there is healing or not, how does it matter whether a post-thrombotic ulcer doesn't heal or does heal?
Basically, sir, the rationale I told you, because patients are coming from the faraway area, and like for patient to CMC who are coming there from West Bengal, Bihar, Jharkhand. So sometimes the patients in which we can make it cost effective, that's why we have included the patient with a primary venous insufficiency. While the patient like with a post-thrombotic limb, it may not be possible that those ulcers will heal with the conservative management which like with the management they are doing at home, and if they require further assessment, they have to come to the tertiary level center again. So that's why just to make it more effective, so we have included only patient with a primary venous insufficiency.
Thank you. One last question. What made you reach that number of 40?
Sir, it is basically a feasibility study, so it's kind of a pilot study. So in the pilot studies, it's like the number should be more than 30. And it's based on the different previous studies done. So minimum requirement is 30, and then or in each arm can be 12 patients in each arm, and some studies says it can be 50 also. So it is according to the previous studies published that how much sample size is required to do this feasibility or pilot study.
Okay, thank you, Dr. Kataria.
Thank you, sir.
Do we have Tirath ready? Yes, we do. So the last presentation, Dr. Reddy, you are ready?
Am I audible, sir?
Yes, very much. You can start your presentation.
Good evening, one and all. I'm going to present on cephalic vein distensibility as a predictor for AVF maturation. I'm from SRMC Chennai. Coming to the introduction, hemodialysis is the commonest modality of kidney replacement therapy, and AVF is recommended as the best permanent vascular access among all due to its prolonged patency, increased longevity, and minimal risk of infection. And large vein diameter has proven to have a decreased failure rate and associated with a better patency. Of all the features, dilation of the vein is an important feature which occurs because of increased blood flow and consequent shear stress after creation of the fistula. Coming to the objectives of my study, we hypothesized that sufficient venous distensibility contributes to fistula maturation. Therefore, this study was done to assess the influence of cephalic vein distensibility on fistula maturation. The study was conducted from Feb 2021 to Feb 2022, and all the patients who were having end-stage renal disease and undergoing a new radiocephalic fistula were included in the study, and patients with severe vessel calcification and who were in hypertension and central venous stenosis were excluded from the study. Coming to the materials and methods, baseline demographic indices were noted, and a duplex ultrasound examination was done preoperatively and postoperatively at 2 weeks and 6 weeks after the surgery. The diameter of the distended cephalic vein was measured by application of a tonic-wet and 3 minutes after the inflation of the tonic-wet. And we calculated the distensibility and vein distensibility ratio. Distensibility is calculated by the difference between the post-dilatation and the pre-dilatation, and the distensibility ratio by the dividing post-dilatation diameter by the pre-dilation diameter. Later, the AVF was done, and we have considered the vein AVF to be matured by noting the flow volume, which was greater than or equal to 500 ml per minute, and if the vein diameter was more than 5 mm. Coming to the results of my study, the mean age group of the study population in my study was 52.32 years, and most of them were between 51 to 60 years. And most of them were males, which accounted for 55%, and females of 45%. 72 patients were found to be hypertensives, 52 had diabetes, and 22 had a history of coronary artery disease. The mean duration of CKD in my study was 19.45 months. And coming to the cephalic vein and radial artery parameters, 46 patients had a diameter pre-dilatation between 2 to 3 mm, and post-dilatation 52 had between 2 to 3 mm, and 72 patients had an increase of about 0.1 mm to 0.9 mm. 50 patients had a distensibility ratio of 1.2, and radial artery diameter, 54 patients had between 2 to 3 mm, and post creation of fistula, the vein diameter at 2 weeks was 3 to 4 mm for 48 patients, and between 5 to 7 mm for 50 patients. And 52 patients had a flow rate above 500 ml per minute, that was about 65%. And after comparison of all the variables, we found that there was no statistical difference in maturation for the below parameters like age in years, BMI, and duration of CKD. And there was also no statistical difference with respect to the various comorbids like hypertension, diabetes, and CAD. But there was very significant difference between the maturation and non-maturation group with respect to the dilated cephalic vein diameter, distensibility vein ratio, and the distensibility of the vein, where the p-value was less than 0.05. Coming to the discussion, maturation failure following radiocephalic AVF formation is an important but unresolved issue. Other parameters like females, diabetes mellitus, diameter and compliance of the artery and vein are all found to influence the maturation failure. We considered vein distensibility to one of the factors. Various studies have documented that patients with large vein diameter have a decreased likelihood of fistula failure. Our study revealed no relationship between fistula maturation and cephalic vein diameter, but preoperative vein distensibility significantly affected the AVF maturation. So I would like to conclude by telling that cephalic vein diameter cannot be considered as the only independent predictor for AVF maturation. Degree of distensibility also has a role in determining the fistula maturation success. We also would want to assess AVF maturation success in patients who have small diameter but elastic veins which are deemed unfit for fistula creation. Thank you.
Thank you, Aturit. Just to get a clarity on what you're presenting, so you dilate the vein or you put a tourniquet after a fistula is created and measure the vein?
No, sir. Before the creation of fistula, we assess for the distensibility of the veins. By preoperatively, we apply a tourniquet and see the distensibility of the veins.
So you measure the cephalic vein after you put the tourniquet?
Yes, sir.
Okay, before
We
the
inflate
fistula.
it and before the fistula is created.
Before the fistula is created. And you spoke about shear stress on the distensibility. So what are you trying to prove from this study?
We're just trying to tell that few veins might be having a very small diameter before, sir. But if they are really distensible, by the application of a tourniquet, we can still attempt doing that radiocephalic fistula. Because the kidney patients, chronic kidney disease patients will require so many access. We just can't eliminate that the radiocephalic vein diameter is less, and we can't
Okay, I'll put it the other way.
exclude from not doing the radiocephalic.
Okay, have you heard of any studies where they put a tourniquet after the fistula is created, an intermittent tourniquet is put after the fistula is created? Have you heard of anything
no,
like that?
sir.
Not heard of that.
I'm not aware of it.
What are the features for maturity? What are the factors which causes the vein to dilate?
One is the vein should be really elastic. It should be distensible.
Okay, let me again put it different. Is it an inward remodeling or an outward remodeling that happens in a vein?
So outward remodeling which happens in a vein.
Okay, what induces this outward remodeling? No, this has to do with the tourniquet because I was trying to understand the study. So, you know, what really causes the vein to distend eventually after fistula is created? Whether you put a tourniquet or not, there is increased shear stress when you connect the vein to the artery. So there is increased pressure which is on the vein, and that starts acting on the vein wall.
Yeah, but if the veins are not found to be too elastic, even if the vein diameter is big, then there might be a failure of the fistulas.
Okay. Any other questions? Okay, Atrit, just since there are no questions, see the remodeling happens invariable. It's not the elasticity which matters. It is the amount of nitric oxide which releases, and that triggers the remodeling. So you can have an outward remodeling, you're right, that's the outward remodeling, but that doesn't have anything to do with the elasticity. Okay, there is some amount of pressure, the shear stress, how it acts on an artery, there is something similar which acts on a vein. All right, thank you, Atrit.
Thank you, sir.
So that's the last paper. We have had 10 wonderful presentations, and the judges have done their job. I think you will have the results tomorrow. So I'd request all of you to be there tomorrow towards the close of the session to know the results. Thank you, judges. I know there are quite a few of them. Thank you, all the participants. Thank you.
Thank you so much, Dr. Sanjay Desai, and thank you to all our judges. Let's give them a round of applause, please. We'd like to move ahead to our next session, which is a debate session. Our chairperson is Dr. R. Sekhar. May we have you on the stage, please? Dr. R. Sekhar. May we have you on the stage? And this session is titled as Controversies in Venous Practice. Controversies in Venous Practice. This session is chaired by Dr. R. Sekhar. The stage is all yours, sir. Over to you. May we applaud for Dr. R. Sekhar here. Thank you so much.
Yeah, good evening. So this being the last session for the day, I feel this is probably the most interesting session for the day. Two topics which are extremely relevant to our day-to-day practice. Controversies in venous practice, absolutely appropriately named. So we start with the first of the two debates. First one is thrombolysis in iliofemoral DVT, very controversial. We have two speakers. Dr. Sairam will speak for, and Dr. Prakash Ramamurthy will speak against. I'll share with you the rules of the engagement. 8 minutes for each speaker, followed by 2 minutes each for rebuttal, and then we'll have about 5 minutes for discussion. So without wasting much time, I would invite Dr. Sairam on stage. He'll be speaking on thrombolysis in iliofemoral DVT. He'll be speaking for the motion.
Thank you, sir. So at the outset, thanks to the CMC team for inviting me for this talk. So almost 50% of patients who have iliofemoral DVT and are treated with standard anticoagulation tend to develop post-thrombotic syndrome. Almost 1 in 4 of them will have pretty bad symptoms, and almost 6 to 10% can develop venous ulcers. So that's probably because standard anticoagulation tends to leave a lot of thrombus behind, and hence the trend towards trying to open up the vein. So there are various ways by which the vein is opened up. So it usually involves some amount of thrombolysis along with different thrombectomy devices. And then there are endovascular adjuncts such as angioplasty and stenting. All of these are aimed at keeping the vein open. So overall, if you look at all these different strategies, they are all pretty effective with more than 80% success. And most are safe. The newer trials describe risk of bleed of only about 1.5%. So why are we debating here? The whole crux of the debate really is, do these interventions prevent PTS at all? So our knowledge comes from 2 large trials. The first is the CAVEN trial. So this was published in 2012, 209 patients. This is basically CDT versus anticoagulation. And their mean CDT time was 2.5 days, which is pretty long. And hence they had a 9% risk of bleed. But most of the bleeds were all just related to the access site. And no endovascular adjuncts were used for this trial. So in the CAVEN trial, they looked at PTS at 24 months, and they showed that there was a 14% absolute risk reduction for the group which had CDT. So the same cohort then underwent a 5-year follow-up, and in the 5-year follow-up, there was a 28% improvement in risk of developing PTS. So obviously what they've shown is that if you follow these patients long enough, you will then start identifying more and more PTS in the control group, and hopefully less PTS in those who had intervention. So the CAVEN trial concluded that you could use additional CDT for those who have proximal DVT. Then came the ATTRACT trial. The ATTRACT trial was published in 2017, and here they basically used anticoagulation versus PMT. The ATTRACT trial, however, also included the femoral and popliteal DVT patients along with the iliofemoral ones, and there was a 24-month follow-up. So in the ATTRACT trial, the primary efficacy outcome was to look at overall PTS, and in that the trial could not show benefit for the PMT arm. But if you look at the other bit of data from the ATTRACT trial, they showed clearly that in terms of symptoms, the PCDT group had much improved scores compared to the control group. Also, even the PTS group, the moderate PTS, that was statistically significantly less in the PCDT group compared to the control group. So the ATTRACT trial showed that intervention might not prevent mild PTS, but it does prevent the worst forms of PTS. So, but the ATTRACT, in the initial publication included FEMPOP as well as iliofemoral DVT. Then they did a subgroup analysis on the iliofemoral DVT patients, and the results were quite similar. So again, if you look at PTS overall, it's not different. Definitely severe PTS as well as symptoms are much better in the PCDT group. So ATTRACT tells us that with intervention, you can actually prevent venous ulcers and bad symptomatic PTS. So, but this is about 25% of PTS. So we probably should be looking at the group which is going to be at high risk of developing this amount of severe PTS, and then concentrating our efforts at intervention for that group. So there have been various trials on that, and they've tried to identify factors which could influence the PTS severity. One of them is younger age, and then how severe the symptoms are when the patient presents to us. Also probably how the patients respond to your initial anticoagulation. These are all factors which might influence this patient's further course. So in those where we identify high-risk factors, we should probably go in for intervention. When you do the intervention, you get excellent veins, but you don't get the same kind of statistical correlation with PTS prevention. Why is that? So the one main problem is we don't have scoring systems which identify PTS very well. The ones that we have tends to overdiagnose mild PTS, and most of the trials end at 24 months. So you need a longer study. 5 years is probably minimum, and we don't have that yet. So is there a need for intervention in acute ileofemoral DVT? Definitely yes. Do we have safe and effective techniques to intervene? Yes. And does intervention prevent bad PTS? It definitely does. So we should offer CDT or PMT for ileofemoral DVT, especially to the young and fit patients, those who have low risk of bleed, and those who probably have high risk factors for developing severe PTS. Thank you very much.
Thank you, Dr. Sairam. That was an excellent presentation. Dr. Ramamurthy, please come on stage. You can have it.
Good evening, everybody.
Speaking against thrombolysis.
Good evening, everybody. I'm going to purely talk from an Indian perspective because I think most of the data we are presenting here is from the west. It's always west. In the Indian scenario, the logistics are different. The pressure on the treating physician is totally different. So we have a lot of other factors to think here. And I'll just quickly go through. See, for thrombolysis, we need a correct patient, the appropriate level of suitability for thrombolysis. Then you need the patient to come at appropriate timing. See, most of the time the patients come quite late, they may not be suitable. Then affordability, because basically one factor which Sairam has conveniently mentioned, not mentioned, is the expense. It's a very, very expensive procedure with, repeated trips back to the C-arm and imaging and repeated this thing. And acceptability. See, I think one thing which we are not very, very truthful in the patient, towards the patient's attender, is we are not telling them all the complications. You may say, the risk of bleeding is only 2%, 3%. The thing is, this person may be the one which falls in the 2%. And if you tell them all the risks, I don't think anyone will be really willing to go for thrombolysis, actually. Okay, can you have the first slide? Oh, I can. So, as Sairam has also already mentioned, when successful catheter-directed thrombolysis can relieve obstruction, maintain valve function, preserve QOL. Just to mention, I do refer patients for thrombolysis. I don't do thrombolysis myself because of various, I'm a freelancer and I don't have the time and patience to sit in one hospital, tracking these patients. I offer thrombolysis only when the patient is in phlegmasia. Otherwise, I don't go for thrombolysis. And if it is left side, definitely yes. Because most of the time after the patient has had a thrombolysis, you may probably uncover a iliac vein stenosis which may be suitable for stenting. So my criteria is very, very simple. If the patient is in phlegmasia, then definitely yes. If the patient has got a left-sided phlegmasia, definitely yes. Just to say that I'm not against thrombolysis. I do send patients for thrombolysis to one of my interventional colleague in one of the local hospitals. So, as mentioned, the factors against thrombolysis, the technique has been associated with prolonged infusion times, large doses of plasminogen activators, and potential for bleeding complications. So, the bleeding complication, as mentioned, can be very simple, like local hematomas, or can be... Slide is not moving. Yeah. And another factor which I think all of the other modalities of intervention to be combined with thrombolysis is becoming more and more. So you have thrombus aspiration models, then percutaneous thrombectomy. So all these additional procedures add to the time and cost. And another thing which the high risk of pulmonary embolism, and definitely all these patients who are going to undergo thrombolysis for a major clot burden, they'll definitely need a placement of IV filter. And this must be removed as early as possible. Again, putting filter one cost and another cost. So all these factors in the Indian scenario is very, very, very crucial, because we have, even without any of these modalities, patients can spend, so much money. And when you take up these patients for thrombolysis, the amount goes higher and higher. Again, safety issues. I'm just quoting a paper which actually studied many other papers, and compared with anticoagulation, catheter-directed thrombolysis shows a significant increase in the occurrence of complications. This is one of the important findings from this study. And significant bleeding risk. So 3 studies reported minor and major bleeding, and pooled results showed the same results, that catheter-directed thrombolysis has a significant increase in the occurrence of minor and major bleeding compared with anticoagulation. So we've been using anticoagulation for many, many years, and patients have been doing well. So is it really useful? The latest antithrombotic therapy for VT chest guidelines notes the balance of risks and benefits with catheter-directed thrombolysis is uncertain. So we have been used to the, treating these patients with anticoagulation, and of course, the patients do develop, post-thrombotic syndrome, and as Saira mentioned, whether thrombolysis really prevents post-thrombotic syndrome in the long run is something which is not yet clear. So taking all this into consideration, is the procedure safe? I would say the procedure definitely not safe. Is it cost effective? No. Especially in big cities like Mumbai, I don't know what the bills run into. And mostly important, is it something which you can suggest on your friends and family? I definitely wouldn't go for this thing. So the question I would want to ask the audience is, will you suggest it to your family if a patient comes to you? Keeping in mind, any patient out of 100, only 1 or 2 patients can develop fatal intracranial hematomas. That could be your particular patient. And the question I want to ask Dr. Shekhar, if Aishwarya Rai came to you tomorrow with major DVT, will you advise her catheter-directed thrombolysis? So with these questions, the main concern is bleeding. That's the main thing. Expense, of course, leave. In the Western model, everything is paid for by the insurance. In the NHS, everything is paid for by the NHS. But here, everything is paid for by you, if you don't have insurance, or by the insurance companies. And so all this you need to take into consideration. And the main thing, we don't want to cut a sorry figure. We have had patients, die, and, attenders blocking the road, attacking the hospital. So this is my main worry. I want to sleep peacefully at night, and I don't want to, go for the all the risks associated with thrombolysis. I would rather put the patient on anticoagulation and sleep peacefully at night. And of course, all these patients, if you think they have a high risk for pulmonary embolism, definitely you can put an IVC filter, which is not a very, very dangerous procedure. But thrombolysis, no. Thank you.
Okay. So thank you, Dr. Ramamurthy. We'll have 2 minutes rebuttal from Dr. Sairam.
Right. So thanks, Dr. Prakash. So a few things. Cost, yes, obviously is an issue. So if someone's going to sell the property and get this procedure done, I don't think it's really worth that. But if someone can afford it and is young and fit and fits the other criteria, then we should offer them intervention. Bleeding risk from CDT, especially when you add PMT techniques to it, is actually exceedingly less, 1% or slightly more. So it's not more than that. Fatal bleeding does not occur, and no trial has actually reported fatal bleeds. So bleeding risk, I don't think is an issue. IVC filters are not required for CDT if you're doing it for iliofemoral DVT, unless there is thrombus in the IVC, or if you're using angiojet, then probably there is a need for putting in IVC filters. But otherwise, IVC filters are not required. Friends and family, if it's a 30-year-old cousin, then yes. 60-year-old uncle, then no.
Right. Thank you. So before we actually go into discussion, just for the sake of interest, I'd like to, let's have a show of hands. We have a limited audience, but how many of you at the end of this debate, or, even before, would be for thrombolysis in iliofemoral DVT? How many of you would be for iliofemoral DVT, thrombolysis, for thrombolysis? Okay, and how many of you would be against? Yeah, and how many are you? How many of you are maybe? So basically, I think there is a trend towards being more in favor. But we'll have a discussion. So anyone who would like to put their point of view around, Dr. Malay.
The thrombolysis, basically, if we break it down into, reduction of the thrombus burden, and then thrombolysis, or simple thrombolysis, catheter-directed thrombolysis, which is the simplest form, or you want a reduction in thrombus and then short duration thrombolysis, like some of you know that we in Gujarat, most of us follow a short duration thrombolysis after thromboaspiration. So it all depends upon how you take it and how you do it. As far as IVC filters are concerned, we've almost never used it. I haven't heard anybody from Gujarat use it. So that's one point. So as far as the ATTRACT trial is concerned, it being quoted the most as so many flaws. In fact, they had even one stent that was 14 millimeters placed inside the vein. It was an arterial stent placed inside the vein, got thrombosed, and of course then you're going to have the poorest of the poor results. So, probably it's not a good baseline to say, well, somebody else may have a similar viewpoint or a different viewpoint. Of course, Shekhar may also have his own viewpoint. I think he has to use his privilege as the chair at the end of the concluding remarks.
Dr. Ilekma here.
Yeah.
Continuing with what Dr. Malay Patel said, ATTRACT trial had its flaws. One major problem with the ATTRACT trial is the short period of follow-up. That is 1 to 2 years. That is a very short time for evaluating for PTS. As we know, most of the PTS, majority, occurs beyond 2 to 5 years, right? So that was one of the drawbacks and flaws that was inherent in Vedantam's ATTRACT trial. So probably they have an extended follow-up, then probably we know whether it is really beneficial in preventing PTS.
Yeah, correct. Dr. Pinjala, any opinion on thrombolysis?
I think everybody comments on that track saying that there are flaws in it, The people who conduct the trial would definitely have gone through all the details. The only problem I see with the track trial is they have combined iliofemoral with femoropopulatal venous thrombosis segments. They should have been separated.
Yeah.
Probably the analysis could be done separately to assess exactly iliofemoral, the results are better. But at this moment, unless we do more trials, we cannot recommend to the large population thrombolytic therapy.
Yeah, I think if I have to conclude, Dr. Malay. Yeah?
No, I just, looking at, ATTRACT trial was done after some internal games were played, and then they started the trial. So basically, this is the inside story. Anyway, so what does intuition tell us? Intuition tells us that the clot burden has to be removed as quickly as possible. How you do it is in your safest hands. Sometimes, it defies logic, like Evra trial. Now, aren't we taught all along medical school that treat the pathology first or as soon as possible so that the ulcer heals? So you have to do an Evra trial to do that? I don't say this on international fora, but it just makes common sense to, sometimes do that.
Yeah.
At this moment, we do not choose the anticoagulant based upon the clot burden. Clot burden can reduce with rivaroxaban also. They have done a trial where they compared large clot burden, minimal clot burden. The response to rivaroxaban was just the same. So based upon the clot burden, we don't have trials to say, choose this anticoagulant, choose that anticoagulant. Clot burden can be dissolved with any type of anticoagulant.
Yeah, I think the only thing is the period which it takes to reduce that clot burden. I think the whole essence of thrombolysis is to try and preserve the valvular function. So that is, I think, what is the basic funda of that. But I think, at the end of the day, I think we can keep debating this till the next conference. As they say, till the cows get home. I think the jury is still out. As Dr. Sairam has said, there is an interesting study which says that the quality of life study which they have done says that doing a thrombolysis at the end of the day doesn't improve the quality of life. But then he has put his justification saying that probably the ways in which we evaluate quality of life have not been validated. So that really, it's a kind of a googly which he has thrown. So I think, as I said, the jury is still out, and we'll keep debating this till probably the next couple of meetings. Thank you very much for both the speakers. I think we have had an excellent kind of a session. I hope. Thank you.
Keep the same debate after 2 years.
Yeah. So we quickly get on to the next debate on perforator incompetence in CVI, to treat or to wait. So before we start, let's have a show of hands. How many of you, when you see perforator incompetence in CVI, how many of you would treat right away? How many of you would wait? How many of you would treat right away? You have a CVI with perforator. Yeah. So, right. Okay. So, yeah, I presume, yeah. Anyway, we'll get to the talk, and then probably we'll get the justification for doing or not doing. So for the motion, Dr. Bedi, please come and deliver your talk, 8 minutes.
Good evening, everyone. Thank you for making the two of us the last speakers. I'll be speaking for the motion, perforator incompetence in chronic venous insufficiency. No disclosures. Now, that's one of the earliest incompetent pathological perforator that I treated. This is more than 20 years back, and now we no longer. You can see what an angry-looking lesion it is. So that is what an incompetent pathological perforator looks like. And actually, what is it? This is the clear-cut definition, size, and the duration of reflux, which we all know, plus if it is located near a healed or an active ulcer, that makes it a pathological perforator. So why treat perforators? There is substantial evidence of the role of incompetent perforators in advanced CVI. 2/3 of these patients will have a pathological perforator, and the treatment of such a pathological perforator is now recognized that for C4 and to C6 disease, it definitely helps in quicker recovery. And it should only be offered to those patients, obviously, where the symptoms can be attributed to the incompetent perforator and not just the presence of the perforator. So one of the earliest trials was the SCHART trial, which indirectly, not directly, did tell us that treating a reason for incompetent perforator, although there were very limited cases, would help you in ulcer healing. And after that, there were a large number of trials, beginning with the open surgery, which I showed you earlier, followed by SCPC, the subfacial endoscopic perforator surgery, which was very successful. I'll quickly go through these trials because all of them show the same results. So this is so many trials in the Journal of Vascular Surgery, European Surgery, Phlebology, and basically all of them tell us that the healing of the ulcer is better and recurrence rate is lower if you treat the incompetent pathological perforator. Similarly with foam therapy, which is also quite effective. And then we moved on to RFA endovenous ablations. Number of trials, RFA, laser, and even with glue. And again, all of them show the same thing. This is a combination of trials, about 13 trials, which show that if you treat that pathological perforator, ulcer healing is improved from 50 to 100%, ulcers will heal, and recurrence will happen much less, that is 0 to 23%. And so there is, at the moment, no convincing evidence for the role of treatment of even a pathological perforator in C2 and C3 disease. And in C5, C6, for conservatively if you want, then you should treat it only after the truncal reflux has been treated. And this is a trial which, a study which compared all three endovenous ablations, laser, RFA, and foam, and recently even glue has been tried, but not in large numbers, and all of them showed the same thing: quicker healing, slower recurrence. Open surgery and SCPS are no longer done. So basically what are we doing is basically a spot welding. So there is a small area which is, and the treatment procedure is very, very standardized, whether you do RFA or you do laser. And I'll so, rather than debating, I'll just tell you what I feel should be done, how I decide to ablate a refluxing perforator. Please understand, I'm emphasizing on a pathological refluxing perforator, not just you see a perforator on ultrasound, you don't straight away go to treat it. First is that it should be pathological, and we've classified what you call a pathological perforator: size more than 3.5 and refluxing for more than 500 milliseconds. And if it is located near a ulcer, that makes it very, very pathological. So even if it is pathological, but the patient is asymptomatic, obviously we don't treat that. In symptomatic patient with a pathological perforator, I would first treat the correctable source of reflux, correct the truncal reflux, reassess at 4 to 6 weeks, and then if it is still not recovering, the ulcer is not healing and the perforator is still there, then we would close it by whichever technique we are comfortable with. Except primarily if the ulcer is very large, which is subjective, it's recurrent, and if it's medial, and it remains, you've already treated the truncal reflux and it's still there, so there you would be straight away going and treating the perforator. Also, you must see the overall picture. Is there associated edema or inflammation, obviously ulceration, and a treatable truncal reflux, if it is there, that should be factored into your consideration for deciding the line of therapy. So there are some hotspots, there are some technical points for treating a perforator, and the treatment is very standardized, the hardware is very standardized. Some additional points that you should watch for adjacent artery, that's very close to it. Ensure, of course, that the deep system is patent. There is always a fear of creating a DVT, which is slightly more than if you don't treat it. So that one has to be careful about that. And of course, if there is an open ulcer or an infected area, you should not go through that infected area. So choose the patient carefully, treat the truncal incompetence first, and then you have multiple options, whichever you are comfortable with. Open surgery and SCPS is no longer done. And you must also understand the physiology. That is, these perforators are not appendixes, they help maintain the hemodynamic balance, and you should treat them only when they are pathological and they are contributing to the disease. So in advanced CVI, I would treat an incompetent pathological perforator. Thank you.
Dr. Ilay Kumar, 8 minutes.
Okay. Good evening, once and all. First of all, I like to thank the organizing committee for giving me this opportunity to present this topic. I have no disclosures to make, except for the fact that I heard someone say that the best way to win an argument with Dr. Bedi sir is to avoid one. So he has made my job easy. I think it's not. Can you move this? Green, okay. Right. So, as we know, perforators connect the superficial with the deep system. We have the whole lot of perforator groups, above knee, below knee, medial, lateral, anterior, posterior. And we are taught that when we ablate the GSV, the perforators along particularly the medial group, will spontaneously disappear, while the lateral group as well as the posterior group do not, mostly. And looking at this article by Resek C, it looks at the impact of the calf perforators on the venous hemodynamics in primary varicose veins. Here, in case of saphenous reflex, the bidirectional flow within the calf perforators has a distinct inward vector towards the deep veins. So this inward component is more pronounced the more larger the saphenous reflex. So incompetent perforators do not cause ambulatory venous hypertension. So exactly the opposite happens. So the size of the calf perforators is determined by the amount of saphenous reflex, and if the saphenous reflex is abolished by any procedure, the enlarged calf perforators should diminish. So keep this article in mind. So why should we routinely do a perforator ligation? Is it necessary? This paper by Robert Mendes from the Journal of Vascular Surgery 2003 looks at some retrospective data, and they also looked at certain hemodynamic profile in these patients who had superficial venous reflex, like they did in APG, and where certain parameters like venous volume, filling index, everything was noted. And then they ablated the saphenous vein, and also they did phlebectomy also. They found postoperatively, when they followed up the patients, the superficial and perforated incompetence, there was an improvement in the hemodynamic parameters, and the clinical symptom score also improved after superficial ablative surgery alone, suggesting ligation of the perforator veins can be reserved for patients with persistent incompetent vessels or with abnormal hemodynamic parameters. This is another paper by M.S. Goel. He is a co-author in the ESCA trial. So he recruited a patient from the ESCA trial, same treatment, compression bandaging alone, or compression plus superficial venous surgery. So the ESCA trial, like that, similar results like in the ESCA trial, they came to the conclusion that after surgery, the presence of an IPV doesn't have an influence on the ulcer healing rate as well as recurrence. So adding any procedure like SEPS to your superficial ablative surgery doesn't improve the quality of life nor prevent recurrence. This is another topic by another study by Thomas Donnell in the Journal of Vascular Surgery 2008. They looked at various trials, and again they found two trials was analyzed here. In this trial, GSE ablation alone compared with compression, and this was continued as the Dutch ulcer trial, where surgical treatment of IPV was also done, resulted in 83% healing with 22% recurrence rate of the ulcer, while compression alone gives 73% healing and 23% ulcer recurrence. They found no level 1 evidence to support IPV treatment alone affects ulcer healing or recurrence. And so, can phlebectomy be deferred? Like Dr. Rahul said, yes, this study was also done, where varicosities were marked. RFA was done for the GSV alone. They left the varicose incompetent perforators, followed it up routinely with duplex examination. And they found that complete varicose vein resolution was 41% in the above knee and 25% below knee. For the above knee varicose vein, 88% were located medially, so highlighting our previous wisdom. And all the reserved ones are medial varicose veins. So, great saphenous vein Ablation resulted in subsequent resolution or regression of many lower limb vesicle veins. As Sir said, the AVF guidelines are very clear about what to treat the pathological perforators. But the US vigorous guidelines added, for most patients with varicose vein without skin changes, treatment of incompetent lower leg perforators is not recommended. And for patients with advanced skin changes with isolated or residual incompetent perforator veins thought to be significant, treatment may be considered. And they come to be reference. To summarize, the presence of IPV alone does not justify its interruption, and the decision to intervene should be based on clinical judgment and the specific IPV in the overall hemodynamic picture of the limb, since occlusion of the IPV doesn't influence the venous pressure. While contrary to that, elimination of saphenous reflex alone has a profound hemodynamic effect with the reversal of incompetence in the untreated segment. Even though up to 58% of the IPVs incompetence will reverse up to 2 years after surgery. Even if they persist after 2 years, they have a questionable impact on the status of the limb. So, gentlemen, so which path to choose? I side with our President, Dr. H.S. Bedi. So, we choose the middle path. Definitely, we have to treat what we should treat and wait for some cases which are not indicated. Thank you.
Thank you, Ilya Kumar. Have a seat. Dr. Bedi, 2 minutes rebuttal, if you have any.
I think you chose the wrong people. Me and my distinguished colleagues agree on the indications. I a little bit more aggressively. So I think we both agree that in advanced disease, that is CBI, if there is an ulcer, which and you can show definitely that the pathological perforator is contributing to the ulcer, then obviously it should be treated. And as I myself said, in C2, C3, even if it's pathological, we would not be treating that. Thank you.
Yes, thank you, Dr. Bedi. I think the consensus is like, Indians stand on Ukraine, the middle path, right? Neither here nor there. Okay, so we quickly get into discussion. Anyone in the audience who would like to add to what you've already discussed, or Dr. Pinjala?
I think both the speakers very carefully treaded their path. The words they use, pathological reflex, what does it mean? We want to differentiate perforators into re-entry perforators and reflexing perforators. Would you like to do intervention in re-entry perforators? That is what the question is. The question is not about the reflexing perforators in C5, C6. So will you routinely deal with the patients with perforators, re-entry perforators, irrespective of their size and the reflexing material?
Anyone else who would like to?
See, that depends on how you define that. It's not very easy for yourself or your radiologist to, exactly besides these three, two, the duration and the size. Whether it's a re-entry or it's an overload perforator, that may be difficult to, diagnose. So we would not really know. So the best would be to first treat the truncal reflux, which is treatable, wait for 4 to 6 weeks, and then go.
I agree with sir. Most of these will settle down. This reflex will reverse if we treat the axial reflex. So we wait for some time. Some may continue up to 1 year, or even up to 2 years it may take for the reflex to completely reverse. So I don't think we have to go ahead with intervening in such special situation. So it is not a general rule that applies to all type of perforators. So is the specific IPV, is it contributing to any ulcer or skin pigmentation changes? Then I think we can manage conservatively.
Yeah, just another question which always comes in the mind in the clinical practice, besides what we have already discussed. You see a patient where the ulcer is not healing and it's very slow healing. And clinically, if you make the patient stand, you will not see any veins because it's all, the skin is very thick and you don't see the veins. But when you do an ultrasound, you find a huge number of veins which are present at the base of the ulcer, on the peri-ulcer area. And when you check the reflux, there is no reflux in that. So now, but the amount of veins which are there are huge, like number of veins on ultrasound, what you see, which you don't see in the subcutaneous place on an ultrasound, like normally. So what we have observed is that in some patients where the ulcers are not healing, your perforators are there, and number of veins in the, at the base of the ulcer, and still there is no reflux. We treat them with foam. And imagine you do 1 4-layer bandage on that, in 2 weeks the ulcer heals up. So, I'm just putting in another question mark area there, that not every time, what science is showing and what clinical picture is showing. And I think it's a venous pressure which is there and which is not reflexing also helps in healing.
I think that's very correct, and what we have to look for is not just the anatomy, because there are 150 perforators, known perforators in each leg. So you are not justified in hunting all of them. It's only if one, it is pathological, two, it is functionally causing the problem. So I agree with you there.
So I think I'll quickly wind up by asking each of the speakers, say, I'll give you a situation. You have a venous ulcer around the malleolus, which has been around for a couple of years. You have a truncal reflux. You have a pathological, a peri-ulcer reflux more than 0.5, and the diameter of your perforator is about 4. Would you treat right away, or would you ablate the truncal and wait with compression? I would ask this to both of you, so if each of you could just reply one after the other.
Yeah, if it's C6, which you're saying
C6,
it is,
yeah.
and I'm doing truncal ablation with whichever procedure, whichever modality I'm comfortable with, I would ablate the perforator also.
Same. Even the ESUS 2022 guidelines has a similar scenario. So either it can be done concomitantly or also, but the thing is it has to be ablated.
Yeah, so that is what exactly is the debate actually. If you see slightly different wording, it's not CVI. What the debate actually in essence tries to bring out is, or whoever has made this topic, is that you have a C5 or C6 or a 4B, C4B. You have the pathological, and what is pathological, what is not pathological has been clearly defined. There's no ambiguity on that if you see the AVF guidelines. So would you only treat the truncal ablation and wait for the ulcer, or would you simultaneously also ablate the perforator at the same go? That is what is contentious, I think, because once upon a time when I really was presenting a paper on this, I asked 10 people in Mumbai about how they would treat such a scenario, and you'll be surprised that about 7, each of them had a different take on it. So it just goes to say that still there is no consensus. There are many ways to skin a cat.
If I like to add, sir, considering the Indian scenario, so multiple procedures, the costs involved,
yeah,
and the anesthetic requirement.
Yes.
Right?
So, that
So
would be
this
one
also
major reason why I would
be-
treat it at the same sitting. But
So
I'm
I
sure
will
there are
take it
people.
the same sitting also.
There are many people who would probably treat it secondarily. Yeah. Thank you. So I think that was a good kind of a discussion. Thank you both speakers. And thank you audience.
Thank you so much, Dr. R. Sekar, for driving the entire debate. We will now move ahead to the general body meeting. I would like to request the committee members to join us for the meeting. Post this meeting, we have a gala dinner which starts at 7 p.m. and you are requested to join us at Savannah Hall 1 for the gala dinner. We have performances that's lined up. We will relax down. We have a wonderful band, our own internal performers who will entertain us tonight. And now I'd like to request the committee members to join us. Dr. Harinder Bedi, Dr. Deepak Selvaraj, Dr. Sanjay Desai, Dr. Gulshanjeet, Raul Jindal. Over to the committee members for the general body meeting. Post-meeting, requesting all of you to join us for the gala dinner at 7 p.m. onwards at Savannah Hall 1. Thank you. Over to the